cartilage defect. Fortunately, it's not on the weight bearing zone. This is outside weight. We will remove that piece, which is probably it has occurred during the time of incident, I think. See, you can see the meniscus, medial meniscus bucket handling is there. I think it's the old medial meniscus, very old, deformed bucket handling, larger side, and there is some cartilage changes. You can see a lot of fissures are there on the medial femoral condyle as well. Okay, so we are unlikely to repair on the medial side. This is a deformed one. Can you give me the saber? No, we need to needle and knife, whatever. Yeah. So we'll make the anteromedial portal just on 1 centimeter medial to your ligamentum pedis. Yeah, that's fine. Yeah. Have you increased the size? Where is the foot piece? Can you bring it out a little bit here? So it's an attachment. So we'll just save the fat a little bit to have a nice view. Won't save too much of fat. I think this is opened. This is not working. This is very dangerous. Yeah. Okay. So give me the probe. This looks like to me an old. The two layers of meniscus is there, and anteriorly see there is a lot of deformity. I mean the quality of meniscus doesn't look good on the medial side, and probably this is the reason the bucket handling is the reason why he didn't had any too much of see pivot shifting, or the latchman was not that positive. It's not reducible as well. So can you come this side and do an valgus? Looks like the really an old, because the secondary changes on the cartilage has also occurred. Can you see this? So I think I'm not going to repair this one. Anyone would like to repair this one from the house? What is the opinion? See? There are two.
Looks a degenerative.
Yeah. I think this might be that the patient had an ACL injury along with the medial meniscus tear earlier, and about 6 weeks back he had another twisting injury, which led to the lateral meniscus probably. So I'm not going to, repair this one because it looks very bad. We'll just have a look on the lateral meniscus as well. So figure of yeah. Yeah. Yes, that's good. No, too much of flexion. Keep it, yeah, that's good. Yeah. This is the lateral meniscus. This is the tear of the lateral meniscus, flap tear. Can you see this? Under surface tear. Yeah, this one. And this is our popliteal hiatus area. Okay. So I think this is the tear length from the root, almost starting from the root from there until the midpoint. So we'll use, this is the popliteal hiatus area. So I think we'll use few all inside in horizontal manner to repair this one, or in a vertical manner as well probably. So this is the popliteal tendon coming out. Can you see this?
Yes, sir. Yes, sir.
Yeah.
It's clearly visible.
Okay, so plan is to cut the medial meniscus, do the femoral tunnel, repair the lateral meniscus, and then do the tibial tunnel and graft passing. Is it okay?
Yes, sir.
Okay. Yeah, it is. We'll just look at the femoral side attachment and the tibial attachment side of the ACL now. Clean all these debris. Give me a punch. This is the ACL which is flipped on the anterior side. And if you leave this, this probably will cause a restriction in extension. So you need to debride this flip part very nicely, and only then you can probably have full extension. This patient had a little bit of a fixed flexion deformity as well, and probably this was the reason. Yeah. So this is the stump which we would like to leave. Okay. This is the your meniscus. Can you see this one? This is coming from the lateral meniscus. So ligament of Reisbach. This is the meniscofemoral ligament. This is the meniscofemoral, and behind which is PCL. This is meniscofemoral ligament coming from the meniscus. We'll debride the notch a little more to see. This is a really old, so we don't have any footprint on the femoral side to bank upon for doing the femoral tunnel. So that's why we are debriding entirely, so that we can have a look at the posterior wall of the femur very nicely. Okay. Yeah. So we'll have a look from the medial anteromedial side as well. Oh, you mean artery fracture?
Sir, for a 22-year-old, this degeneration looks probably due to he was using his knee irrespective of the
Yeah,
injury.
yeah, of course. I think it's not a good thing for him, I think.
Performing any loading activities and
Yeah.
So hello, sir.
Yeah.
So we can stress the importance of ligaments and meniscus to prevent degeneration. This is the live presentation.
Yeah.
Yes.
I think that's true. But probably the lateral, fragment was due to the injury. You can't say that that lateral fragment, which is here,
Yes, sir.
is probably due to the some sort of meniscus tear. This one is probably the direct injury. Okay.
Yes, sir.
And on the medial side, this fissure and everything, these are probably
second
due to the overuse, because the meniscus is not there. These are the grade 2 changes, outer bridge grade 2 changes. And we can see still see. And do you have the needle? So we'll make the third portal. I usually make the far medial portal. No, it's fine. It's fine. So we'll. Huh? So I think it's okay. If we can target from there
Yes, sir.
without
Yes, sir.
affecting, so the site is okay. So we'll make a port there. Give me a probe. So you can still probably visualize a little bit of. I think the coupling device has a little bit of problem. I think. I think. Yeah. Is it okay? Very dangerous. If the things get decoupled, the chances of breakage of the scope is very high. This is the posterior border, and here you can see the femoral footprint starts.
Yes, sir.
And it ends here. And above probably it's there, and lowermost point is here. So we'll probably make a femoral tunnel somewhere here. You have something to mark between.
Yes, sir. We
all?
can see it properly.
Yeah.
Yes.
All. Do you have all? Do you have offset engine? So what is the size of the graft? I haven't measured. No, no, all. There's all you don't have, no? Give me
Yes, hello, sir.
Yeah. Artery
Dr. Raman sir is asking, what is your plan for osteochondral defects?
I think that osteochondral, these incomplete one, we don't have any plan. We'll pray to the God that this gets cured automatically.
Okay, okay.
Okay, and for this one, we'll remove this one because this is a not non-weight bearing zone.
At least we can prevent further damage. Yeah.
This one is on the non-weight bearing zone, so we'll remove this piece.
Yes, sir.
Okay. So, and I will tell him in the post-operative because he should continue to pray to the God.
Yes, sir.
So this is the posteriormost point, and this is my entry point. We don't have all to show you. So give me a beat pin. Oh, that's good. We have all as well. Everything is there. So this is probably where we are planning to make.
Yes,
Okay.
sir. Yes, yes.
Center. Can you?
Center of footprint.
Yeah.
Yes.
Hammer it a little bit. Yeah. This is okay. So I think it's high time that we should remove that fragment because if that fragment gets dislodged,
It is already loosened, no?
Yeah, it's disengaged but not dislodged. It's there in place. We can see it.
Yes.
What I mean that it's get dislodged and migrate somewhere else. Whether we can find that.
Yes, yes.
Give it the artery first. Artery first. It is almost separated, but probably attached with some sort of
Fibrous tissue. or
fibrous
something.
tissue or synovial attachment. Oh.
What is the exact location of this?
Fragment. This is
What-
this is lateral femoral condyle, lateral edge of the lateral.
Okay, okay, okay.
This is the intercondyle notch,
Yes, sir.
lateral femoral condyle, and on just on the lateral edge,
Outer
like
side.
on the lateral cord,
Outer side.
outer
Okay.
side.
Yes.
So I think this is the fragment. Oops. Yeah, give me a brush. Yeah. I think we have lost that small fragment in the track. Cameraman is coming too close. So comfort.
This looks like degenerative knee only already.
Yes.
sir.
Yeah. Yeah. Okay. So now I think we'll cut the medial meniscus first so that we can have a good idea. I can't I think we have lost that fragment. I think it has fallen up or might have been there in some track, but it's a really small one, so we are not too much worried about that. So give me a punch or scissors. So we'll cut this one first, the anterior attachment. Yeah, the grasper. Hold it nice and tight and then keep it pulled like this and then cut the posterior edge. Okay.
Yes, sir.
Okay, so I think we need to shift my scope. Can you hold this one? There is no catch. Yeah. So we'll shift the scope to the far medial portal and use the lateral anterolateral portal to cut that. Yeah, just keep it pulled. Yeah, like this only. What is it? Okay. Okay. No, not from this. No, not like that. Yeah. So we are struggling for space a little bit. I think this is okay. Yeah, hold it like this. Okay. Yeah. Yeah. Give me the scissor. No issue, no issue. Uh-huh. Yeah. Okay. Now let's see. Are you comfortable? Yeah. So now we'll cut the posterior edge. And I think we might struggle to take out from that portal because the port is really small. Okay, so we'll cut at the base. Don't show the outside. The outside picture is not that important, I think. I think inside picture is what people will like.
Yes, sir.
Yeah. So actually the cameraman is coming a little too close, and that's why I'm a little worried about the sterility. I think it's better hold it. So we have changed the plan. We'll view from the anterolateral side because we are finding it difficult to cut from the anterolateral.
Okay, sir.
So
Yes.
we'll now cut it from the far medial. We have taken a 1 or 2 bite and now we'll finish it off from this side. Can you clean it? Okay. Yeah. Keep it intact. Yeah. So we are okay with it. We are probably cutting it nicely. Yeah. We have cut it and it has come out. Can you see the medial meniscus?
Yes, sir.
Yes, sir.
Okay, a little bit of remnant should be there on the posterior limit.
You can shave it.
Can you do a little bit of external rotation and valgus? Okay. A little bit of flexion. Yeah, this one. Fine. This is the remnant which is given the probe, which is unlikely to actually get caught into the condyle. So we can leave that, but we'll probably try to save it a little more. Can you see this? This is the remnant.
Yes, sir.
Yes.
So I don't know whether
No, no.
the shaver can save this thick meniscus. Because of the punch, I think, it's a really small one. We'll see if we can save it a little more. So we have a very nice assistant, so it will be good if he agrees to come with me to Calcutta.
Jerson. Sandeep is saying he will not send Jerson. We have Dr. Porser also in the audience right now.
Okay,
Patient belongs to him.
I think we will probably do a little more damage to the cartilage than anything. Give me a punch. 1 or 2 punch. Yeah.
Sir, are you able to assess the status of the root, sir?
Yeah, the root is attached. I'll show you. Yeah, give me the probe. See this? This is the root meniscus. There in anyway the remnant which is left on outside is very small. So see this
Yes, yes, sir. Yes.
root is attached. Huh? Can you see this?
That is root.
Medial meniscus is actually attached just by the side of PCL. It's not like the lateral meniscus where it comes really anterior here. So you can see you can't lift the meniscus. You can't lift. See the root is attached there.
Yes, sir.
Okay. So give me the paper.
Sir, have you already done the pie crusting, sir?
Pie crusting? No, I haven't. Actually, we can actually, this is the only the excision. That's why I'm not, while repair, we might have done the pie crusting. But since this is only excision and we have a very nice assistant who is opening the medial joint line without pie crusting. So we are not actually bothered about doing the pie crusting. We almost done the excision also. It's, I think the posteromedial corner, which is more important, which gives a little more opening if you really do the pie casting. So what we are doing is on the medial root, posterior root, and the anterior root to cut the, the two ends of your bucket handle. Okay.
Yes,
I
sir.
think now it's okay. There is no much meniscus left, so it looks nice. A little bit of meniscus is still there. Hopefully, do a little more job. I think that's given the prompt. Yeah.
Now we can make the portals.
Yeah. Portal we have already made, so the root is attached there.
Yes, sir.
See, root is already there, and this is your PCL. So now we'll do flex it, keep flex. Now we'll do the femoral tunnel.
Yes.
And then repair of the lateral meniscus. Give me an offset dig. कितना ग्राफ कितना साइज है थिकनेस चेक कर लीजिए बस. So we haven't checked the graph, so we need to have the graph thickness first. Okay. Okay. There is a problem.
Sir, is it
That's-
possible to show the graft preparation?
I think it will take a little longer. We can always show you. Okay, give me the. Can you show the outside picture? Switch on the light, please. Yeah, graft is there. Okay. We'll go on that side first. Okay. Yeah, this is how both the grafts look. He has already stitched on one. No, he has not stitched it. Okay. So both the grafts are almost similar length. Can you see this?
Yes, sir.
So I think the length is usually it's 30, oh, more than 30, 31 and 32, right? Okay. So give me the artery first, mosquito. So what I do, I like to keep the AC bond or non-absorbable suture as little as possible. Okay,
sir.
so I'll prepare both the grafts together
Yes,
so
sir.
that I don't use too much of bond because on the tibial side, these bonds makes the graft too much thicker if you use
Yes,
too many
sir.
grafts. So we'll stitch the four ends together, but we'll stitch it very nicely or in robust manner so that this becomes a single tendon. Give me the yes, hand from hand. So hold it both the ends, both. So like this. Yeah. We'll try to hold all those grafts together and stitching.
Oh.
No, hold it. Leave the one. Yes. Okay. So, yeah. I think we are able to catch hold of. Leave the one. Yeah, hold the one. Oh, yeah, that's fine.
Hello, sir. Hello.
Yeah.
Your choice for this type of Miss HL is always hamstring, or you depends upon the patient?
No, majority of the time hamstring, I don't use the other peroneus graft. Only
Okay.
when in revision situation or when something wrong with the hamstring, then only
Okay.
in multi-ligament situation I use other graft. Then the ligamentum patella, I haven't bone patellar tendon, I haven't used it for quite a long time. So I think majority of us probably do that only.
Hamstring only. Yeah.
Yeah. Sandeep has a very nice technique of graph preparation. He doesn't stitches at all. I think we need to learn it from him.
He has patented it, sir.
Yeah, he has patented it. Then we can't steal from him, but we probably acknowledge him whenever I will use that technique. Cut it here. No, it's without needle side. I don't need needle. I don't need. Cut it here. Yeah. Yeah. So this is the, we'll use one loop on this side. We won't stitch it any because this ends, this is the only amount of suture which will be there. Okay.
Yes, sir.
Okay. Now we'll quadruple it. Yeah. Hold it like this, I think, and then we'll measure it. Okay. So, yeah. I think we have 8.5 maybe. We'll pull it. Yeah, I think we can barely insert through the 8 and 8.5 on the femoral side, it goes nicely. On the tibial side also 8.5 goes, no, I think on tibial side it's 9. So we'll drill the femoral side. We would like to have a little tight graft on the femur. So we'll drill the femoral side with 8. Oh, even 9 is some.
9 भी tight है.
9 भी tight है. तो फीमर में 9.5 करते हैं टिबिया में and femur में 8. Okay.
Yes, sir.
So 9.5 is okay, I think. So on the length, we have, I think, adequate 7.5 to 8 centimeter length. Yeah, it's 8.5 almost. Okay, so we are happy with this graph.
So
Yes, keep it
femur, you will use 8.
Yeah, yeah. Even if I find it little difficult to put it, 8.5 is smooth, but I'll use the 8 on femur side.
Okay.
If there is any problem, the suture gets torn, I can always blame the Mytech.
You are using a fixed loop.
Yes. Give me an artery forceps. Artery forceps. Offset jig. I think I'll use 7 offset 7. More offset jig 7 mm. Yeah.
Do you have cold, sir?
No, I think I don't know what. Too much of. I mean,
Because of yesterday's.
yeah. I enjoyed the hospitality a little more than anybody else. I think. Yeah. Netflix. Yeah. Come on this side. Come on this side. Femur 8.
Yes, sir.
Yeah. Can you drill? Are you ready? Yeah. So I think this is the offset. Yeah, drill it. A little more flexion, please. Yes. Yes. Wait. I think. Yeah. Go ahead. Yeah. Go ahead.
Excuse me, sir.
Yeah.
It is little blurred now.
Sorry.
Camera can be fine tuned.
You can't see the. I mean,
The image is not
Image is
sharp.
blur.
Yeah. Even I can't see as well. So don't worry. It's not blood. It's purposefully so that you don't detect my fault. No, I think because too much of flexion is there, na, so I think a lot of fluid and the camera focus is also we need to adjust a little bit. I think focus has changed.
Focus. Yeah.
Yeah. Is it clear now?
Yes,
Yes.
sir. Yes.
Yeah. So I can always blame the camera for the any malposition of the femoral tunnel, isn't it?
Yes, sir.
Okay. खुद का गलती नहीं होना चाहिए, बाकी सबका तो खुद खोज सकते हैं गलती. I think we are okay.
Yes, sir.
No.
Yeah.
Looks good, sir.
Yeah, looks good on the center of the footprint. Carefully.
Can we see posterior, sir?
I think in hyperplex position, it's very difficult to show you the posterior. Once we drill that tunnel, then we'll show you the posterior.
Okay,
one.
okay, okay,
Yeah.
sir. Okay.
Give me the heart rate, sir. Yeah, you go ahead. You go ahead. Take out, take out. Coming out. Wait. Give me a robust artery.
I welcome Dr. Rajendra
Yeah,
Abhinkar, sir,
go ahead, go ahead.
on
Take
the
out. Yeah,
stage,
good. Now the 8 mm drill.
who is our MOA president.
Acha. So initial part always you should do it with hand so that you don't damage the femoral condyle. Yeah. Once you reach the femur, then you start drilling it. Yeah. Go ahead. 20. 25, huh?
Sir, are you drilling the femoral tunnel
No,
now?
wait.
Or
Yeah, yeah,
It's 4.5.
yeah. See, this is on the medial condyle, and we are making the femoral tunnel.
Sir, what is the length of the tunnel?
I think we haven't measured it. We expect it to be 40 or 45, in between 44, 42, something like that, because it is a very lengthy guy. So since I'm using the fixed loop, I'm doing it 25 mm of 8 mm. It's almost 25. Now come out. Be careful. Huh?
25 is inside.
It's not coming out. Yeah, take this out. I think we'll leave this. We won't put any sutures right now because we need to do the lateral meniscus repairing. So we'll put the sutures later. Can you hold this one? Give me the saver. Okay. So we'll clear all the debris first. I think can you increase the saver? Do you have the depth gauge? Yeah, can you flex it a little more once again? Yes, just a minute, let me put this one. I can't see. Yeah, go ahead. Go ahead. A little more flexion. Yeah. You have done it? Yes. Okay. Okay. Yeah, this is the length. Can you see this?
Yes, sir. Not clearly, sir.
Yeah, I'll show you. Yeah. So I think the 50 is there. So probably it is 44, I think.
Little bit clear, sir.
Yeah, I think what's wrong with it, I don't know. Hold this one. This the focus always gets changed. Okay.
Yes, yes.
ठीक है ना बस.
Yes,
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 sir,
sir.
clear.
Yes, sir.
So I think that 50, 48, 46, 44, 42 or 44. I think it's 44, huh?
45, 44, yeah.
Okay? 44, 42, 44 के बीच में नहीं बस.
Yes, sir. Yeah.
1, 2, 3. Huh? Okay, so we'll take this as a 44 size. Okay. Yeah, the meniscus repair now. I think I need the diamond rasp. Hold this one like this. Yes. Yeah. Again, we need to adjust the focus on the thing. Yeah. Give me the rasp, meniscal rasp, and take out one. This is a diamond rasp. So now I'm preparing the bed.
Yes,
See?
sir. Yeah, yeah.
This is relatively fresh one. I think he has suffered another little more injury recently. The ACL was a little, old, along with the medial meniscus bucket handle, and this is probably the fresh injury.
This is fresh
which
injury.
we
Yeah.
usually got that history yesterday. He said that it's only 6 weeks old, so we were very happy. I was very happy that I got the chance to operate on a 6 weeks old meniscus.
Yes, sir. Yes.
And Ankit was actually cursing. He said he has a 3 years old meniscus, which he is going to operate next. But this medial meniscus really look more than 3 years old probably. And the kind of cartilage he has, probably his ACL and medial meniscus injury is there for more than 2 to 3 years.
He should have come a little earlier to get that
Yeah.
repaired.
But we don't have any options in India. We usually
Patient
get
came
these
very
patients,
late.
yeah. I think really troublesome zone is this one. We don't want to catch the popliteus. Okay, so we'll
Yes,
put
sir.
one here and one here, then stitch it from the upper side. Looks much better. So we'll put one vertical mattress from here and one bite from there. Okay,
Yes, sir.
and then we'll go a little beyond that popliteus to stitch it there. Okay. So we'll start from anterior first. Give me that all inside device. Have you taken it? देखें. ना गाइड है क्या? ना.
So what is the success rate of lateral meniscus repair, sir?
Success rate. I think lateral meniscus gives a better result. Probably the more vascular and bigger. And
Yes.
usually the tears on the lateral meniscus are a little more periphery.
Yeah.
And success rate in lateral meniscus is better.
Yes, sir.
But yeah. Okay. तो इधर से हाँ हाँ प्रेस करते हुए रिमूव करना है. Leave one press, leave, and then take out, and then one second press. Second press, इसमें कुछ करना है. This is the depth adjustment. Okay. Okay, so we'll take the remove the Kannada. We'll first take the inferior bite. Yeah. This one is. ये वाला किधर गया? Where is the needle? Yeah. Give me probe here. I think we need a probe.
We,
You know everything.
Sir, which true span is it? Is it 12 degree or 24 degrees?
12 degree. I need to keep it the meniscus pressed a little bit. Oops. Yeah. No, not there. I want to put. Why it is not going under surface? Okay.
Dr.
Under
Ajit
surface. Yeah,
Bhosle sir is coordinating in from the OT. So we are getting nice pictures, sir.
okay. Hold it, leave it. Hold the camera. So. What is he saying, Rajiv?
Nothing, sir. Continue.
Okay,
We are just thanking Dr. Ajit Bhosle who is coordinating
okay,
from
okay,
the theater.
okay. Yeah, many thanks from my side also. You are being so kind, not asking difficult questions. What happened?
Blame the MyTech.
Yeah. What is that? Yeah, I think. Yeah. I think we have
First
done.
anchor is
No, both the anchors are deployed.
Okay.
Yeah. And now I'll pull the switches. Oh, oh. The second anchor has come out.
come out.
Okay. I think the anchor has really gone outside. I think it has not done well. Hmm. What happened?
Yeah, I think Sunita, you can take horizontal matters from superior surface.
Yeah, yeah,
that will
good,
work.
I think I,
Yeah,
and
yeah, yeah.
I was
Just
carrying
cut
like
this
that,
one.
yeah.
Cut this one, and
Yeah.
it's in the
And
yeah,
repairing it from the underside is a little more.
Oh,
Give it the artist first. Okay.
just yeah, just cut this, and
Uh,
I think so just upper border. You take one horizontal
Yeah,
matters will be good
yeah,
enough.
give me
Two
one.
horizontal, yeah.
Yeah, one horizontal, but and the real worry is the popliteal. If I catch the popliteal, then that's popliteal tendon. Give me one more.
You know anterior or posterior area, sir?
So this is the anterior. I'll put one posterior as well.
Okay.
Okay.
वर करायची sir.
then ठीक है. Okay. I think this is my posterior bite first to the meniscus. Hmm.
Yes, yes, yes. If it works.
Yeah. Why didn't you put?
Very clearly seen, sir.
Yeah.
Thank you.
Yeah.
Yes, sir. Yes. Fantastic.
Okay. You don't have the proper cutter. This is the very dangerous one. This is the small one. This is the only thing. How much?
Sir, I have probably a difficult question maybe for you and even Raman sir. Would you consider leaving this alone? Because you're also reconstructing the ACL and it is likely to heal.
No, no, it's a very long tear. I think it's 2 to 3 centimeters. This will not heal
Okay.
on its own. Once up to 1 centimeter, you can leave it.
Okay.
Punch. Give me the punch. Yeah. Yeah, give it. I think the cutter system is probably a little difficult. Uh, yeah. Therefore, okay, flex. Is it pressed? Yeah.
Huh?
What is it?
No, that.
Hmm.
Inside. Yes, yes,
Okay.
perfect,
Yeah.
perfect.
Give me one more. I think now we need one more on the posterior side, and that should be okay. I think. Yeah.
Yes,
No,
sir.
no, hold it like this. And place it like this. Give me the one more.
Sir, Raman sir is suggesting use post 24 in posterior,
24 or degree? Acha.
24 degrees.
Okay.
Yeah, so
That's
Sunita,
why I was telling you to come to the hotel.
no, 24 actually it gives more
Yeah,
movement in the
angles. Yeah, that I can
posterior part.
understand.
So
Yeah.
you can just give away the tibial spine will come in the way. So
Okay.
24 is good for posterior. Mhm. And this is a very simple device. It's
Yeah.
like gun mechanism. You have to trigger. I think.
Yes. It's a sort of robotic arthroscopic surgery, isn't it?
No, I am just marketing my tech. Amit is here.
Okay.
So
Yeah.
for next IAS One, all those meeting now we have to take Louis
Okay.
pen is the best one. Again, posteriorly, I think you can take one horizontal mattress.
I think now that give me the probe. Let me see.
Or if you you can adjust the length also from the superior part, yes, Sunita.
Yeah, I think it's difficult to use the vertical one.
But horizontal will do because it
Yeah,
will have
I
a good
think-
cinching there.
yes.
So just posteriorly,
Yeah, I
yes.
think.
One horizontal mattress will catch both.
Yes, I think, putting vertical, I'm really a little difficult.
Yeah.
The first one actually was not work.
Yeah.
So, no, it's fine. Not required. If it goes nicely. If it doesn't go, then we will use the camera. Okay.
Sir, if I can suggest, maybe if it is possible, you can try an oblique configuration. So we can
Yeah,
get to
Oh,
see
okay.
a good one here. This.
We'll take the posterior bite first.
Yes, posterior. Yes, good.
Press it little more. Press it little more. Yeah. Keep it up. Okay. Yes. We'll use only one, so we'll probably take the posterior most bite here.
Yeah.
Yes, we have pierced
Yes.
everything, hopefully.
The 24 gives you a good access on the posterior compartment. You can
Yes,
just
yes.
rotate it. Yeah. Yeah. And then come anteriorly and yes.
Yeah, I think.
Yes, good one. Good tissue is there. Yes. Yes.
Mhm. No, I think it's difficult to use it one.
Now take it out. I think you have to
I
take it
think
out. Yeah.
It doesn't make sense. निकल ही गया पूरा.
निकल गया. Take it out. Take it out.
Punch. Fluid कराऊंगा थोड़ा fluid देना. Push a little bit. Yeah. All this way. Yeah. Yeah. Is it that one? Yeah. So we have taken out that one, but I think,
This one you just cut it, I think,
Yeah,
at
I
the
think-
end and leave it there.
give me the punch.
Yeah, fine.
Push it with pulled. Pull. पकड़े पकड़ लो
With scissor, you can cut that at the end only. Yeah, leave it.
This
Yes.
way, hold it like this. Yeah. और push करो हाँ open नहीं हो रहा टूट गया नहीं ठीक ठीक this one yeah think we don't have any
Yeah,
option to
You
cut
can do,
it
yeah,
from-
yeah, just push it posteriorly toward the
Yeah.
poplite has that with probe
Hmm.
and
Saver is very dangerous अटक जाएगा सूता saver के अंदर
saver will stuck.
हाँ
The blade will stuck if you use saver. Na?
think we'll use the saver even the saver
Sometime posterior horn, if you can change your portal also, so if you can
Ah.
put your ankle to the lateral portal, it gives you a good access also.
yeah I tried changing the portal but I think the visualization is getting even more difficult
All right. The posterior horn sometime because tibial spine comes from the medial portal in the
Yeah.
way. So it
in reaching there yeah
good thing is that this is orthocord is partially absorbable.
yeah
Done, yes.
Yes.
You can take another anchor, I think, one
Yes,
more.
yes. Give me one more
Go ahead.
24 degree. Okay, give me the 12. Yeah.
Yeah.
It is not coming. Yeah, the opening is decreased. No, it's fine.
Uh.
So,
You can use this trocar also, Smita.
yeah.
Yeah.
But I
But
think
like
it was
sometime,
going on nicely. Give me
nice.
the carrying, yeah, miss it.
Sheath,
Uh,
slotted cannula, and see the length, it is on 20, na?
yeah,
Sometimes
it's
what
20,
happens?
it's
Yeah,
20.
20, it's good for that. Otherwise, sometimes what happens? Yeah. Only one stitch will be, another stitch will be good enough because, yeah,
Yeah, one more stitch. should be
good enough, yeah.
Take that out.
That is the tibial spine is the only issue in the posterior horn. It comes in the,
Yes,
yeah,
exactly.
sometimes. You see this tibial spine. So
Right, the opening is also
yeah.
quite less.
Yeah, normally I do that. So yeah, good. So 12, you rotate it and take various.
Yeah.
So true span is that you fire and just wait and then take it out so that, and yes, go full and yeah, full and fire, and then gradually take it out. Single fire, yes, good.
The space is really.
Yeah, yes,
really-
we can see the needle, yes. Yeah, good. Again 20, yes.
Yeah.
Yeah, fantastic. I think it's not opening up. Joint is not opening up. Yeah.
That's the main issue.
Yeah.
It might have swelled.
No,
before
swelled out.
treatment comes.
He's a tough guy, na. We saw
Yeah, it's
Saya.
a
It was a
tough
go.
one.
Yeah. Go up to 20. Otherwise, if it is in meniscal tissue, sometime 20.
नहीं ये बहुत जगह I think we are purchasing some tendon या bone में जा रहा है.
Just rotate and it will go in soft tissue. Rotate up. Yeah. I think it's toward the popliteus, so that you are feeling the and you can take bite through the popliteus also. And I think it now sometimes it's recommended also when you have poor tissue, you take bite through popliteus also. And wait, yeah, and yeah, just come at this stage, yeah, and keep a probe in between, and I think it's a very good bite. Excellent.
Should be okay.
Yeah, it's just here. Yes, this will provide a good cinching. You just pull it. Yes.
Pull it. Yeah.
Pull.
Gentle.
Good. Yes. 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 And now take it out. Yes.
Yeah.
Fantastic. Excellent. So I think job is done. Yeah. Good job. Sunil. Yeah.
Yeah, I think it's a little too difficult for the site because
Because of the tighten, it's a big thigh. It's a
the
yesterday
lateral
we saw
side
the,
on both the sides of popliteal. I think-
It is tighter on lateral sides.
yeah, tight. Joint
Yeah.
is tighter and it's a big guy.
Yeah.
No, it was okay. I think we took a little more time as well. We wasted 1 or 2 anchor that led to some swelling and then.
You can blame my.
No. I think the anchor system is very good. Sometimes you have poor meniscal tissue that
Yeah,
also causes your.
Yeah. It was a little bit of technical fault as well. I think we should have on the second time it misfired because I think I used a little less force. The
Yeah,
entire
yes.
system came out actually.
Yes.
So we should have kept a little more forcefully inside because probably it was the Needle was almost going through the popliteus.
I think after using it now, you must be loving Mitec anchor. Huh?
Yeah. Yeah. So,
So this is very good device, not pusher come cutter.
not pusher
Cup
good,
cutter,
yeah.
yes. And it's autoclavable. You can autoclave it also. Yeah.
Yeah.
So now you will
Give me
make
a
your
probe.
tibial tunnel,
Give me a
Sunita.
probe. Yeah.
Just show the repair. Yeah.
Yeah, I think it's okay now.
Yeah, it's
We
okay.
don't want to put the probe through and pull it out,
No.
but it
Looks
looks
good,
okay.
sir.
Yeah.
looks okay.
It's stable. I
Its
think
inching
the
is there. I
lateral
think it will
is
heal.
okay.
It will be heal
Yeah.
with time.
Okay. Okay. So give me a tibial jig.
Very nice demonstration, sir.
Yeah.
Sunita,
Yeah.
we have another 10 minutes now.
We'll-
So
10 minutes.
tibial tunnel and
Yeah.
so that is the standard time for Sunita, I
Yes,
think. So
Give me. Put it in between. Yeah.
so this is a footprint jig.
Yeah.
Yeah. So you routinely use a footprint jig only, or
No, I use the elbow jig majority
Yes,
of the time, but
yes.
here we have the footprint, so I will be using it footprint jig. My choice is mainly, yeah. Go ahead. It is coming out, yeah. Just don't put too hard, yeah.
delegate any questions from your side? Any one of you? Prashant wants to ask one question here.
9.5, huh?
No, it's
Direct.
good going.
Go ahead. Yeah.
Sunita,
Yes.
like nice demonstration what you showed all inside. But what about inside out if we are doing? Whether you have used
Inside
it?
out on the lateral side, posterior, just posterior to the popliteus, it's not possible inside out.
Acha,
It's very risky on the lateral side.
you are not doing it.
Yeah, but on the medial side, I think we do it on the posterior medial corner up to. But at the far just near the root, I think I use the all inside on the medial side as well. Yes.
This is your on the tibial footprint, no?
Yes. Yes.
Yeah.
Give me a probe.
Sunita,
So I think
Sunita,
430.
you can just for the anterior
30 will
horn
be
of the
do you have 28 loop? 28 or 26? 28 loop, sir? 28 loop? Rigid loop? 28 or in 5 increment? 30? 20, 25, 30. Okay, what is the length? I think we'll use the 25 loop.
what is the
Go
graft
ahead.
size?
Graft is 8.5 we have length. And the tunnel length is around 44.
What are the landmarks for tibial tunnel?
I think this is the landmark, the posterior border of the anterior horn of lateral meniscus. It's in the between should come at this level or at the base of the footprint. Yeah, come out.
If your graft is of 10 mm, still you will opt for the same landmark?
No, maybe are a little more on the posterior side.
Use anything else to protect?
What?
Any scoop or something?
What happened? Uh-huh. Okay. Give me a silver. So, you'll clear the bony debris a little bit. Give me a artery forceps and keep a bead pin ready and take the loop and artery forceps.
Sunil da,
Artery forceps.
are you happy with the graft size or thickness? It's 8.5 because as per as history,
Yeah,
this patient is kabaddi player or sportsman.
yeah.
And you have put such a thin grafts with a triplet.
8.5, you think it's a thin one? 8.5? 8.5 is okay, I think. How much graft you would have preferred?
I would have prepared 6 times of the size and 10, size 10, because he's a
6
sportsman.
times we have used eightfold.
8. Why don't you prefer BTB?
I think it's BTB is usually
Because-
thinner graft.
Because he's a sportsman.
Yeah, I can understand, but I don't think he should be able to continue the punch with his sportsman too much because the arthritis changes are also quite significant. I don't think he can make out to the very high level sports person. Yeah, give me a bead pin.
These are remnants of ACL, no?
Sorry.
What you have removed just now?
Yeah, just a little bone fragment which came out from the
Okay.
the tibial side.
Tunnel.
Tibial tunnel. And a little bit of lateral meniscus anterior flexion. Flex. Hyperflex. Complete. Flex it. Yeah. Yeah. Get up. The graft is ready. I need a, the depth gauge. Give me the depth gauge. Or grasper. Do you have the grasper?
What advice we can give to him to prevent further degenerative changes?
I think the overactivity, the jumping, cutting activity, don't flex it. Yeah. And limitation of activity. I think the more the sporting activity he will be involved, the greater is the chance.
That he will progress in.
Yeah. You have the retriever? What's the color? What is it? Pull it a little more. Little more. Faster. Pull it. Yeah.
Voilà.
Yeah. Give me the graph. Yeah. Open. Is it the Milagro Advanced or Milagro normal one? Advanced, no? So 9, 10, 11. We'll use the 11 one then. What
So do
happened?
you soak the graft in any antibiotic solution?
Yeah, I prefer to soak it in gentamicin.
Gentamicin. He prefers Syngenta. What is your preference, sir?
A lot of people now shift to
Rajiv sir is saying
yeah,
vancomycin.
yeah, vancomycin, yes. Sir, custom is off. Give me the probe. Have you? Yeah. Please go ahead. Hold the camera. I'll do it. Huh? इधर बंधा हुआ है ना? Hold it. I'll try. Leave it. Yeah.
Sunitda, sir,
Yes.
what's the plan for tibial side fixation?
Sorry, I
Yes.
mean, I'll use
So
one
the disc
interference screw. Since he is only 24, 2 or 24 years old, yeah, very young. Otherwise, I tend to prefer a dual fixation. But here, I think since he is only very young, so we'll prefer single interference screw fixation only. And the graph is also quite long, so we'll expect. I'll put it. Give me a minute more. Yeah. Huh. It has come gone inside. How long? How much? Ah. 1 centimeter is there. Okay. I think both the graph has gone inside the femoral tunnel,
Yes, sir. Yes, sir.
but not yet flipped. So we'll pull it a little more.
So we will start with the inauguration ceremony, and after the inauguration, we'll come back to the OT, sir,
Yeah, yeah, please.
to see the final picture.
Okay.
Okay.
Is it going inside? Not flipped. गया क्या थोड़ा? गया?
So very good. Welcome to Satara IAS One conference organized by IAS, IOA and MOA along with SOS, Satara Orthopedic Society.
जा रहा है क्या?
I would like to call upon dignitaries of IAS, Dr. Sandeep Biraris, Dr. Rajendra Abekar, sir, President of Maharashtra Orthopedic Association, Dr. Rajiv Raman, sir, Joint Secretary IAS, Dr. Prashant Tonpe, sir, Dr. Yogesh Mokashi, sir, Dr. Santosh Yadav, sir. We'll do the lamp lighting ceremony first, and fine.
सरस्वती महाभद्रा महामाया वरप्रदा श्रीप्रदा पद्मनिलया पद्माक्षी पद्मभद्रा शिवानुजा पुस्तकप्रज्ञा महाविद्या महाभारतनाशिनी
I will invite Dr. Abhinkar sir to say a few words.
Good morning, everybody. The organizers of this live surgical demo, my colleagues in Executive Committee of Maharashtra Orthopedic Association, our guest, Dr. Raju Raman, and friends. It really gives me great pleasure that the Maharashtra Orthopedic Association vibrantly is organizing all those things. As if now, as in today, just now, we are running 4 such conferences in Maharashtra and one on a webinar on a Veteran Surgeons Forum AVN. So I was talking with Raju, he says MOA is very vibrant. It is only because of the enthusiastic members like these in front of you. So a big round of applause to them. I will take this opportunity to inform you that we have rejuvenated the fellowship program of Maharashtra Orthopedic Association, which was not there during the COVID time. 3 weeks and 6 weeks fellowships. And again, Dr. Tonpe and Dr. Biraris are the in charge. We will be shortly publishing the fellowship program. The next is we have handed over the publishing of the Journal of Maharashtra Orthopedic Association, JOTS, to an international publisher, Kluwer and Porters. So the next issue we will be publishing through the international publishers, and I request all of you to send the maximum number of articles, and definitely MOA members will get preference on that. The third thing is we have an extraordinary GBM in Kolhapur on 8th of July. We have KOA Con also there on 8th and 9th, and I request all of you to attend the same because we are going to implement the backlog of constitutional amendments in that particular GBM. And the last is we have a conference in Jalgaon, a small place though, but I think we should register and promote the small places. Otherwise, again, we'll have to go back to only metro conferences, which is not good for the unity and coming together of all the districts of Maharashtra. So I again appeal all of you to register for Jalgaon and we'll meet in Jalgaon. I thank the organizers, Satara Orthopedic Association, Dr. Davde especially, who invited me for this function. Thank you so much.
I will now invite Dr. Sandeep Biraris to say a few words.
Thank you very much. On behalf of Indian Arthroscopy Society, I'm so delighted to see the enthusiasm of the Satara Orthopedic Society to conduct and organize this conference, which is like a exclusive event, which is being held with Indian Arthroscopy Society Sports Subcommittee of IOA and Maharashtra Orthopedic Association. I'm proud to say that I'm a member of all 3 associations and Satara Orthopedic Society. They have taken lots of efforts. So actually, the IAS One theme is decided by our president, Dr. Sachin Tapasvi sir, because it is based on the concept that to train maximum people in a tier 2 and tier 3 cities, the conduct program in those cities, and so that the people of that particular city they benefit from the conference, and the faculties from that particular region, they get exposed to the national platform. And again, similarly, we increase the membership of Indian Arthroscopy Society and all our local societies. And I'm so happy to see that we could gather a lot of crowd today. And this is since I took over secretary of IAS, this is the third event. First one was held in West Bengal, Durgapur, by Dr. Rajiv and his team. Second one was last month. It was in Visakhapatnam, and this is the third one. So I'm so thankful, and I'm thankful to all the sponsors, especially MyTech, who have supported this event wholeheartedly by providing a implant free of cost for all the patients. For whatever surgeries we are doing, they are not going to charge anything to the patients for the events, and they have taken efforts for setting up all these infrastructure for the AV. And special thanks to Dr. Amol and Dr. Ajit Bhosle sir for giving venue for the live surgeries, and Paul sir who could gather patients for us, because the program was arranged within very short span of time. Thank you very much.
I will like to call Dr. Por sir to give memento to Dr. Prashant Tonpe, sir. Doctor, I will like to call upon Dr. Samir Sheikh sir to give memento to Dr. Santosh Yadav sir. I will like to call Dr. Ashutosh Bhosle sir to give memento to Dr. Mokashi sir. I will like to call Dr. Lavan sir to felicitate Abhyankar sir. I will like to call Dr. Kshirsagar sir to felicitate Dr. Rajiv Raman sir. I will like to call Dr. Barge sir to felicitate Sandeep. We'll have a group photo. Yes. We will go to the OT and have the final picture. Then we'll break for a tea break. Dr. Sunit sir. We can see you are already closing the.
Hello.
Yes,
Yeah.
sir. Yes, sir.
So we forgot to take the final picture. I thought you guys will be taking a long time, so we didn't take the final picture. But I think we fixed it with the interference screw, and we added one. Suture disc over it, and then we are closing it.
Okay.
Okay, sir.
I thought it was saved. The recording was saved, so we could have shown you. But I think he's saying that we could not retrieve that recording now.
Okay.
Okay.
Yes, sir. Sunita, just one question. You have
Yeah.
used the adjustable loop.
So no, I used the fixed loop.
You have used the fixed loop. Okay.
Sorry.
Okay. Okay.
What was the question?
It was fixed loop, no?
It was fixed loop, yes.
Okay.
How you decide which type of loop to use in according to age or
No, no, nothing. I don't use and adjustable loop. I use the fixed loop
always?
always.
Okay.
Okay.
Wonderful demonstration.
Okay, thank you.
Yeah.
Okay.
We'll now take
Thank you,
a
sir.
tea break.
Yeah. Okay.
Can we start the next session?
May I invite next moderators for the session? Dr. Ajit Inamdar, Dr. Santosh Yadav, Dr. Nikhil Likate, and Dr. Rajiv Raman. Please chair the session.
Hello. We ask the delegate to please sit on so that we can start our next session.
So first talk we have first talk by our IAS president, Dr. Sachin Tapasvi sir. Why should we save the meniscus? Can you run the recorded talk? Sandeep? Yes, it's there, please.
Menisci, the medial meniscus, which is attached at the anterior and the posterior root, which is very mobile and wider posteriorly. And on the other hand, you have the lateral meniscus, which is of similar anteroposterior width, but it covers a greater articular surface. The medial root on the posterior side is closely attached to the PCL, and the lateral is closely attached and in relation to the ACL. The anterior root attaches for a far distance in a variable location proximal to the ACL, which is what must be kept in mind. The menisci serve many important biomechanical functions. The medial meniscus carries about 50% of the load in the medial compartment. The lateral meniscus carries about 70% load in the lateral compartment. And if you look at the ACL injured knee, which is a fairly common injury that we see in our clinical practice, you would find that a third of all ACL injured knees will have a medial meniscus, and a third of them will not be repairable. On the same hand, you would find that almost about 40% of all ACL ruptures will have a lateral meniscus tear, and only 10% are non-repairable, which means that we have to go all out and try and get to these injuries early to save the meniscus. The main biomechanical functions of the meniscus are those of load transmission, which is the main role. The menisci allow to transmit load from the femur to the tibia, and they convert the axial loading to circumferential hoop stresses. The roots of the meniscus play an important role. They help dissipate the force to the subchondral bone area, and hence the meniscus root is now recognized to be an extremely important reason for getting back the stability of the knee joint. When you perform a meniscectomy, there is increased peak contact pressure on the articular cartilage, and the amount of meniscus that you remove will be the most important predictor for development of osteoarthritis. So the more meniscus you remove, the higher are the chances that you will get to osteoarthritis, because there is increase in the contact forces. This is more important on the lateral side than on the medial side, because on the lateral side, you have a convex on convex articulation, which makes the role of the meniscus so far more important. Meniscus tears can be classified on the basis of the tear depth, location with respect to the zones of the menisci, the pattern of the tear, and the quality of the tissue. But on a broader aspect, you can classify them into traumatic tears, which are essentially seen in young athletic individuals, which are usually associated with an ACL or some cruciate tear, and they're usually of a peripheral longitudinal type and are amenable to repair. On the contrary, you have degenerative tears, which are seen usually in patients above the age of 40, 45. They will occur with a trivial injury, and you would find that there are pre-existing degenerative changes in the cartilage, and the meniscus may not also be of normal quality. These may not have the same healing capacity as that of a traumatic tear, and these are usually of complex tear patterns, and repair may or may not be possible. It was way back almost 100 years ago that the meniscus was found to be capable of healing if the tear had access to a synovial blood supply. And Warren and Ornoxy about 40 years ago did show us that the peripheral capillary plexus, which originates from the synovium and the capsule, richly innervates and supplies vascularity to the periphery of the meniscus. So based on the same, you can classify tears of the meniscus as zone 0, 1, 2, and 3, based on whether it is at the level of the capillary plexus or with decreasing vascularity towards the central area. You could also classify them based on the configuration, as we discussed, whether it is a radial tear or a flap or a horizontal cleavage tear or a longitudinal vertical tear, which is what we need to look into in proper details. On the basis of chronicity, a chronic tear is less likely to heal, and which is why we must look at this aspect very critically, because a tear which has been out for a very long time may not heal properly at all. And of course, we need to look at the age of the patient. Older the patient, less the chances to heal, and a non-compliant patient is someone that you should stay away from. An unstable knee needs to be corrected before you perform any form of meniscus surgery, and this becomes critical because if you leave a knee that is unstable, the meniscus repair is bound to fail. If you look at surgical techniques, the meniscus can be repaired with an outside in, inside out, or an all inside technique based on the zone or the area of the meniscus. And we now have better devices of all of these three techniques, which allow us to repair more and more of meniscus zones with increasing ease. If you look at the repair principles, we understand that we should perform divergent superior and inferior vertical mattress sutures, something which will be highlighted by my next speakers. Why is it important and critical to repair? It is important to repair because if your meniscus repair tides over the first 24 months after the repair, then there is a good chance that it will survive for more than 10 years, which is very important. And this happens because 20% of the meniscus repairs will fail, and probably they could be as a result of a wrong indication or a poor technique or a meniscus which did not have good biology. Another important critical aspect is that if you remove the meniscus at the first go, then you will perform a meniscectomy, which is 85% more than what would be if your repair failed at a later date. Also, this study showed that you will have a 50% higher chance of landing up with a chondral lesion if you perform a primary meniscectomy. The association between anatomical healing and clinical results has also been demonstrated that with improved meniscal healing, there is improved clinical outcomes. Also, is very critical to understand that if you perform a meniscus repair, you are more likely to not get osteoarthritis, and you are more likely to return to the pre-injury levels. So which are the factors to consider? I think consider tears which are in zone 0 and zone 1, and some selective tears in zone 2. Definitely repair all the lateral meniscus tears as much as possible. They stand a lower risk of failure than the medial tears. Repair the smaller tears for sure. If you have a longer tear, then it may lead to a poorer prognosis because the healing rates may be lower. But please understand that if you perform a large meniscectomy, you are definitely going to get a poor result, which is why you should try and repair as much as possible. It's also important to understand that partial meniscectomy will lead to lower reoperation rates than meniscus repair. And this is more so on the lateral than on the medial side. But what is important and critical to understand is that we need to do a good combined repair if we want to ensure that we want to have good stability and good outcomes. The Lishom scores and the amount of caudal degeneration is definitely going to be more when you perform a meniscus repair, and that holds true for osteoarthritis as well. So to conclude, to save meniscus tissue is of prime importance. It prevents osteoarthritis and restores normal biomechanics. You need to be aware of the various different methods of meniscus repair, including those for hidden lesions, which are the ramp and the root tears. Thank you very much for your kind attention, and I hope to meet all of you soon in person.
Sundar sir?
Yeah, can you hear me?
Yeah, we can hear you. So, sir, Dr. Rajiv Raman, Dr. Nikhil Likhate, Dr. Santosh Yadav, and Dr. Ajit Inamdar are the chairpersons.
Yeah.
Rajiv.
Yeah, welcome, sir.
Rajiv, good morning.
Good morning. Good morning.
Good morning, all the moderators and the faculty. And I thank personally Sandeep, Amol, and all the team of Satara for allowing me to present virtually. I'm sorry about it. There's some personal commitment in the other course here. So please accept my apologies. Shall I go ahead?
Yes, sir, please.
So my topic is on meniscus root and ramp tears. I think I don't need to speak much about the effect of the meniscus root if you have been excised over the partial meniscectomy. We know that the biomechanical studies have shown that if you do a root tear, it happens, the effect of the weight bearing over the tibial articular surface is almost like a total meniscectomy, which is proved by Lapradite studies and the Robinson studies. So I talk about the two kind of tears in the meniscus root. One is the traumatic tears, usually happens in association with the anterior cruciate ligament and multiligamentous injuries. And we know that the lateral meniscus posterior root tear is more common with the ACL. Sometimes, rarely, you can see medial meniscus root tear. It happens in posterior cruciate ligament tear too. We know the classification of the Lapradei, and that type 2 is the most commonly we see that with this complete root tear close to the attachment. You can have some bony avulsion, bicameral tear, and all those other types, but most commonly what we see is the type 2. And this is one of the classical example of the ACL injury. You can see the complete absence of the ACL, and you can see that the lateral meniscus is completely lifted off from the bony bed. So usually it has got a meniscocapsular attachment. Sometimes it will be just lifted off without meniscocapsular ligament attachments. It will be very stable, but usually this kind of tears are unstable. So whenever you see an unstable lateral meniscal tear, you do the repair in acute root tear also. So you can use the same kind of ACL flat jig. Usually I like it because you have the space which is very narrow over the prominent lateral tibial spine and the lateral femoral condyle. And this kind of jig allows you to keep the jig over the tibial spine with the less space. Then you do the transtibial pin, the drill. Then you can use the this kind of antigrade device to take the bites. You can use the number 2 fiber wire, but it cannot be done directly. So you can usually use the 0 fiber wire and exchange with the number 2 fiber wire. And usually I try to make at least 2 cinch knots so that they have a more security, and then you take it through the transtibial side and you fix it up. So this is how it looks, that ACL, and you can see that that lateral meniscus is completely sitting over the bed of the lateral femoral condyle. So then you attach in the tibial side with the suture button. This is what commonly done in practice. When you come to the degenerative medial meniscal root tear, which is the more controversial, and you know that it is more commonly happens in the middle-aged females. Sudden onset of pain with a trivial trauma with or without pre-existing pain is the most common history which you always come with these patients. And the coronal axial view shows the typical traumatic, degenerative root tear, and you can see that the gap, which is the bed, this is the root which is supposed to come and attached here. If you see the sagittal view, you will see the ghost sign. Of course, extrusion is one of the common finding with the root tear, but you have to be very careful that even in osteoarthritis with the degenerative osteoarthritis with the grade 4 also will have extrusions, which is very normal. So we should not consider it as a diagnostic. So when would you operate for this? Whenever there is a symptomatic root tears with acute history like this, young and middle-aged patients, no significant pre-existing arthritis and no significant virus. And transosseous suture repair is one of the commonly done method. With the single tunnel, you can use a 2 tunnel also. There are other methods like suture anchor repairs. Even the quality of the root is very bad. You can use the Gracely's autograft, which is described by Bancha, but very rarely done. But most commonly done procedure is the transosseous. This is a 53 years old female, pain in the left knee for 3 months time, and pain started while getting up from the floor. This is one of the common history. The patient says no significant knee virus of this patient. As you see that typically there is a root tear in the coronal axial view. This is what you normally see when you see these kind of patients. The root is completely avulsed. You see the cartilage is almost like a normal, not even a grade 1 or 2. So you can have this kind of root tear. So this kind of root tears should be repaired. And usually the space is a bit narrow in these patients because of the tight middle compartment. You can use the pike crusting whether on the femoral side above the joint line or tibial side. I like to do it in the tibial side. We can see that gradually it opens up. Only you have to open it up whatever it is necessary. If you are opening too much, it can create a valgus instability. Then you do the bed preparation, remove all the cartilage for the better biology. That is the most important thing because the root has to heal to the bony bed. That is very, very important. The same jig can be used, which I talked about before. You can flat dig. Other separate root jigs are also available. The most important is that you should not deviate 3 to 4 mm from the normal anatomical, because non-anatomical root repair can fail in healing. That is how this entry point, then you drill with the 4 mm drill. Then here I'm using the suture tape. You can use that can be directly used to the loaded to the your scorpion, and that can be taken up through the hole, and that's what final look shows that in the last video how completely sits over there. So controversies in root tap, does it heal or not? That is a question. And can extrusion can be halted? That is another question. And we published one study on the correlation of the factors affecting the correction of meniscal extrusion and outcome after meniscus root repair, where we found that we found that the patient is less than 50 years. The patient has got only the grade 2 cartilage damage, has got a better outcome in the functional, also radiologically, and also this patient has got a less extrusion. If it goes more than over that, or grade 3, 4, more than over the age of 50, the chance of extrusion remains or sometimes increases. This is another case. You can see the healing. It's a 42 years old female presented with the root tear on the right side. She was operated for the left side 2.5 years before. And we had a chance to look on that operated side. You can see this is the grade 4, which where microfracture was done. We can see the good fibrocartilage repair, which has happened over the grade 4 lesion. And that was the meniscus root, which was repaired. We can see the nice healing over there. I'm putting the probe and trying to lift it up. So they have a high chance of healing if it is adherent to the age and the less cartilage damage. To conclude, the root repairs, you repair in the acute cases. In chronic cases, if they're younger than 50 years, low-grade cartilage damage, if the alignment is less than 2.5 degree, whereas they have a better functional and extrusion correction after the repair. When it comes to the ramp repair, we know that it's not a very new, described by Strobel in 1988. It's a meniscocapsular longitudinal tear up to 25 mm in the posterior corner of the middle meniscus. And the prevalence varies from almost 9.3% to 23.9% in the literatures. And the risk factors, you see the more common in males, even though it's commonly described in the chronic ACL injuries, I could see lot of cases in the acute ACL tear also. This is the classification described by Thanet et al. The type 4 and 5, where you have a complete tear and also there is a double tear, where the more unstable tears, and definitely they require an operation. The MRI is not diagnostic most of the time because we can be easily missed with us or also with the radiologist. So because they are very, very less sensitive in extension, because only it opens up in the knee flexion of around 90 degrees. So, but still you can see that edema in the posterior medial bruise can have a indirect evidence that this patient can have a ramp tears. How to visualize these hidden lesions? They got to put a scope in the between the medial femoral condyle and the PCL, and you can have a flexion of 70 to 60 to 90 degrees. Can give us some valgus force. It opens up. It can go very easily. It's not a very tough. So you can see in the biomechanical study, if you don't repair, this can result in anterior tibial translation and also an axonal rotation. It is also proved with the Labrador type studies. So it is imperative that you have to look for these hidden lesions and to fix this to prevent this kind of excessive tibial translation, even though clinically there is no difference. How do you repair? The most commonly done repair is that using this kind of lasers coming through the posteromedial portal. You can take 3 or 4 bites to repair this. But there are some other technique like all inside techniques also available. I'll come later. This is a 28 years old patient with a 5 weeks old injury. We can see the complete ACL tear. And you see that MRI may not be very diagnostic, but if you see that hidden lesion, if you go through the posteromedial between the femoral condyle and the PCL, if you see that large unstable lesion. So you do the standard fashion, as I say that you create a posteromedial portal. I think all of us know we have to make a posteromedial portal by doing the PCL reconstructions. So I use normally 25-degree lasers to take the bites. You can take 1 or 2 or 3 bites like this. You can see that is I take the bite and take out the nitrile wire through the same portal and I exchange with number 2 fiber wire. So it is not very tough, but at the same time, the maneuvering is a bit difficult and tricky. And if you are doing a shoulder, it is always easy to take. But if you are doing a knee by practice, it is easy to get it. So this is how you take the bites and exchange, and you can see that then you tie the knot one by one. We can see that I use the cannula. Then I take the first most lateral portion of my threads and I tie the knot. Then what I do that I cut that. After tying the knot, I cut the knot, then take out the cannula. Then I take out the second stitch through the cannula so that the suture tangling can be easily avoided. So that's how you put the knot. Once you've done the knot, cut it, then use the second one. That's how this is what finally it looks. You can see that after the repair, you see that the meniscocapsular, the height of the posterior horn of the meniscus is maintained by doing the repair, and it is completely stable. So this is how it looks, the ramp ACL and also that is the ACL reconstruction with the ramp repair. So you can use the all inside technique also, but it is a bit tricky. But if it goes below, if it is retracted, it's very difficult to do it. And that's how the technique has been described. Do the heel. I think the most of the literature had shown that healing rates of ramp lesions were significantly better in the repaired group. To conclude, to look for these unstable ramp lesions in ACL reconstruction, yes, it is hard to find. Subchondral marrow edema over the posteromedial tibial condyle on MRI is an indirect sign. And the intercondylar notch view and the posteromedial are the key to get the success of your ramp repair. Repairing ramp tears can prevent anterior tibial translation and excessive rotation to prevent the indirect stress on our ACL reconstruction. Thank you very much. At the same time, with the permission of Sandeep, Secretary, and the Amal, Organized Secretary, I request all of you to support me and vote for the President-elect in IAS election in March 2024. Thank you very much.
Thank you, Sundarajan sir. And on behalf of IAS, I would like to congratulate you for becoming executive member of ISACOS. A big hand for Sundarajan sir. He has been now in ISACOS executive. Any question from audience?
I'm in the committee for last 6 years, Rajiv.
So today I saw in your slides, sir. Yeah.
Yeah.
So
thank you.
So what do you say about the degenerative tears, sir?
Yeah, yes, I already said that the degenerative tear is always the tricky. So whenever you see a patient comes with you with knee pain, if the MRI shows the root tear, you have to take the consideration of what is the age of the patient, what is the history this patient has got. If they have an acute pain within the 3 months to 6 months time, as already said in my talk, If the patient says that I had a sudden snap sound while getting up from the floor or coming down on the staircase, these are the two common history the patient usually says. And usually I put on a leading question. Did you have the pain before that? How far you are walking before that? How was the knee pain before that? If the patient said, absolutely, I didn't have any pain before, even the MRI, X-ray shows that some arthritic changes, still you can go ahead and do the root repair alone if the varus is within 2.5 to 3 degrees. Anything goes beyond 4 or 5, they are gray zone, then you should talk to the patient about this patient needs an alignment correction. If you do an alignment correction, that is the most important when the patient has got a more than 4 to 5 degrees. Even you don't do a root repair, literature shows that they do very well. If anything which is 3 degrees, you can do a just root repair alone with the grade of articular or cartilage grade of 2 to 3, and less ages are more favorable. So anything which is grade 4, if the varus is more than 4 or 5 degrees, then you have to be cautious. Then they are not the candidate directly for only for root repair. So you should consider osteotomy in those patients.
Thank you, sir.
Thank you, Rajiv.
Yes, Dr. Sunit Hajra wants to ask
Yes,
something.
Sunit.
Yes,
Yes.
Sunita.
Morning, sir. Sunit. Sir, how do you decide the repairing of the lateral meniscus root, posterior root, where the meniscofemoral ligament is intact? So when do you repair them or do you leave them alone?
So what I mean, my practice is just I see that lateral meniscus root is completely off of the bed. Even the meniscocapsular junction is intact. Many of the time, if you see from the bed, it's just slightly lifted up. It has not moved out of the bed. Sometimes lately it will be just lifted up. Once you do a reconstruction of the ACL joint, gets more stability. Even you don't need to do repair, because the literature had shown in the lateral meniscus tear with the stability of the meniscocapsular ligament, if it is not off from the bed, you can treat conservatively. There is no difference in the outcome. But anything which I see that sometimes it's lifted off and moved out of the bed, that means sometimes it is very, very unstable. That means that the meniscocapsular ligaments are also putting into the stress. So better to do the repair. So anything, if you have a doubt that it is completely off from the bed, you do the repair. It takes extra 5 to 10 minutes. Always giving the anatomy back is most important. So giving back the anatomy, put a less stress on your ACL reconstruction.
Hello, hi Sundar.
Hi, Samir.
Sundar, if you are having a root tear, a posterior horn root tear is there. Along with that, you need to do a HTO.
Yes.
So whether you will combine both root tear repair plus HTO or only HTO?
So I do both together at the time. At the same time, I do the root repair with the HTO. If the repairing quality of the meniscus is good, unless if it is very fibra, if it is a very chronic nature, because when you do an osteotomy, you know that it's a chronic nature. That means a grade 3 to 4, the grade varus is around 4 degrees. That means they are in the little lateral stages that had come. So if the quality of the tissue is good, I do the repair all the time. Anyway, I'm doing in a prospective randomized study. Probably I'll be able to answer in another 2 years.
Okay. Does it make any difference in your study up till now? Even though if you do only HTO?
No, I am not sure, but I have to see the results. I started only 1 year before, so we're still in the early stages.
Dr. Sundar, Dr. Nikhil. Okay. See,
Yes,
if you have a chronic root tears, actually, the meniscus extrudes out. Okay.
Yes.
So do you add some kind of centralization of that extruded meniscus along with the root repair, or you just do the root repair and let the meniscus extruded out?
Yeah, so very, very good question. Thank you. So what my current practice is mostly what I was doing before, not now. A year ago, 2 years ago, I used to do the meniscal extrusion repair mostly for the chronic ACL deficiency in the younger patients. You had seen that these patients comes with the root tear. I don't know, many of you might have been observing in chronic ACL deficiency with the varus deformity, they'll have a root tear with the completely extruded meniscus. When you do these patients, I do an osteotomy, I do an ACL reconstruction, I do a root repair. I try to correct the extrusion also, because they are all very young patients, 25 years old, 24 years old, 25 years old. But I'm not sure what happens in the older patients, because some of the studies which I had shown that even if you do a meniscus root repair, extrusion can progress. Some studies have shown that extrusion may not progress. Some study has shown that it worsened or improving extrusions improved. So again, this is a very controversial topic, whether do extrusion correction in the root repair or not. Again, I'm doing another RCT is going on, which was registered. We are doing in our institution. Again, probably I will be able to answer in another 2 years. Sorry about it.
Thank you.
Thank you, Sundaranjan sir, for being there online.
Thank you, Raju. Again, please accept my apologies for not being there. Probably I will try to join some half marathon in Satara next year. Sandeep
Yeah,
invited.
done. Yeah. So it's I think one of the we have been to that place yesterday, and it's a very beautiful place.
I'm looking forward. Thank you very much.
Thank you, Sundaranjan sir. So we'll continue our session. Our next speaker is Dr. PG Kulkarni. He will be talking of knee preservation, my algorithm.
Slide, first slide. Knee preservation, my algorithm. Next slide. The significant advantages in arthroscopic and minimum invasive techniques have changed knee surgery over past decades. Knee surgery is in a period of rapid transformation with new therapeutic tools and modern treatments. Knee surgery is becoming more conservative, as human tendency is toward conservation, preservation, rather than reconstruction or replacement. Okay, then. नाही त्याच्या अगोदर नाही नाही सेकंड थर्ड स्लाइड पुढे जा. So my concept of knee preservation is to preserve the natural structures of the knee inside the knee joint as well as the knee itself. So in last 25 years, the procedures I was doing to preserve the structures inside the knee joint, that I'm going to tell about those surgeries which I do for last so many years. Out of that, one is the transverse fracture of the patella. I do percutaneous wiring, which prevents the incision over the knee, either transverse or vertical, and preserves the integrity of the knee joint. Second is knee tibial plateau fracture fixations. That also I used to do with help of the arthroscopic assistance as percutaneous pinning, avoiding the opening of the knee joint. Then acute lateral subluxation of the patella, traumatic, treated with arthroscopy assisted procedures. Fourth is ACL avulsion injuries treated with arthroscopic figure of 8 loop fixation. These particular procedures I have presented, also published also long back, and I'm doing it for last almost 20 years. Then PCL avulsion injuries treated with arthroscopic loop fixation. Then in grade 1 and grade 2 osteoarthrosis, arthroscopic clearance of the compartment to treat the mechanical problems of the knee. That I do for many times. And lastly, the microfracture technique to preserve the cartilage loss with fibrocartilage. So now coming to the first, that transverse fracture of the patella. So I started doing that after my visit to US, where I saw this particular procedure in the video library of that particular hospital.
And I thought that I can do this particular procedure. So I started doing percutaneous tension band wiring and encerclage loop for transverse fracture of the patella and presented it in our Maharashtra State journal. So these are the a few pictures where you can see that the wires are put percutaneously with help of the image intensifier. And as well as after that, I used to do the arthroscopic examination of the knee joint to see the surface, internal surface of the patella, inner surface of the patella. Or sometimes if there are some loose bodies or hemarthrosis, that also I can take out. So the second procedure is the knee tibial plateau fracture fixation percutaneous. So you know that the tibial condyle fractures are high energy injuries which require anatomical reduction and stable fixation for early mobilization of the knee joint. Arthroscopy assisted fixation of these fractures provide additional benefits of minimal dissection, accurate visualization of the articular surface, and faster rehabilitation. Grade 1 or 2 Schatzer classification fractures types can be managed with arthroscopic evaluation, removal of the fragments, and with cancellous screw without the need of opening the joint. So this is an example where the tibial plateau fractures have been fixed with the cancellous screws without opening the knee joint. Then acute lateral subluxation of the patella, traumatic, treated with arthroscopy assisted procedure. Acute patellar dislocation is a common injury, especially among the adolescents, and is usually related to sports and physical activities. Medial patellofemoral ligament repair in acute dislocation can provide good clinical results and has been increasingly applied in recent years, which can be done under arthroscopic evaluation. We can repair the patellar attachment with minimum invasive incision with arthroscopic assistance. Then this was the topic of my interest. That is ACL avulsion injuries treated with arthroscopic figure of 8 loop fixation, which I am doing for last almost 25 years. Anterior cruciate ligament is one of the main structural support of the knee joint that connects the femur to tibia. It's the main restraint of anterior translation of tibia. ACL repair can decrease the risk of morbidity of patients than the conventional reconstruction method, and it is less invasive than that. Wire loop and thread loop techniques can be used for fixation of ACL avulsion fractures while preserving the ACL ligament. So actually, how I do this particular procedure, I cannot go into the details of this now because of the restraint of time. But this is, you can see that there is one needles-like thing is there, owl, which has got a hole. So that can go posterior to the anterior cruciate ligament or posterior cruciate ligament, whichever you want. You can put either a thread 5 number ET bond, or you can pass a stainless steel wire there and you can make a loop around that, and that you can fix. So these are the external pictures of how I used to ACL avulsion injuries treated with arthroscopic figure of 8 wire fixation. This is a post-operative X-ray view where you can see that the figure of 8 loop and the wires are there inside. So this particular work I actually presented to Humidi also. And this also I published in the Journal of Orthopedic Surgery, Maharashtra State Orthopedic Surgery Journal in 1917. This was, I put it in Humidi long back, and 2 years back, there were about 4,000 viewers to that. We made some work with our PG students. That is the comparative study of functional outcome and complications between wire loop fixation and thread loop fixation in the treatment of anterior cruciate ligament avulsion fracture. And so what we found in that is, instead of wire loop fixation, the thread loop fixation is better, because because there is no, implant inside the joint. There is no need of removing the implant from the joint. And secondly, most important thing, what we observed and studied this was because when the wire was to be removed from that particular patient after the ligament is healed, most of the times while removing the wire, there was a fear that the anterior cruciate ligament may be cut through. And because of that, we moved towards the thread loop fixation. And with 5-number ET bond, we are doing those particular procedures for last so many years. Again, the same thing with PCL avulsion injuries treated with arthroscopic loop fixation. The PCL is the main restraint for posterior translation. PCL injuries are less common as compared to the ACL injuries. Arthroscopic fixation of PCL ligament can be done by making anterior and posterior portals. Additional transpatellar tendon portal can also be used. I do it with anterior portals and transpatellar tendon portals. I don't use posterior portals for this particular procedure. And what I believe more is that the tension inside the either anterior cruciate ligament or posterior cruciate ligament, the physiological tension which should be there in that ligament, if it is there, and then the piece of the bone will unite afterwards. It will take its own time to unite. But if the ligament's physiological tension is good, then the patients do well. So in all my procedures, wherever I have done an anterior or posterior, this type of fixations, I see the anterior drawer test, and on table, the anterior drawer test is better, 0. And that's why I continued with these particular techniques. So this is a MRI picture of PCL avulsion. These are the external view of the PCL avulsion. These threads which I have taken out from anteriorly. For PCL avulsion, I make an canal from tibia to posteriorly to the insertion of the PCL. Not exactly the anatomical insertion of the PCL over the tibia, but little bit above that. I take the tunnel, and from that tunnel, I took both of them anteriorly and tie them to the over a button. So this is, you can see that this is the internal picture of arthroscopy picture, whereby both of the threads, 5-number ET bond threads, have gone posterior to the PCL. And those are pushed down a little bit, and about 1 centimeter downwards. From there, those threads can be pulled out. These are the internal pictures. You can see that owl, that particular owl with the eye very nicely here. So this work also I published in 2017 in the journal. And the 6th important thing, which I do very frequently, and it is controversial, I know, but I do it very frequently. And why I do frequently, why the patient, more and more patients are coming for doing, they are getting one knee done like that. 5 years back, they are better with that knee. They are asking for the same thing, do the same thing on the right knee. And I definitely agree, it is not for only osteoarthritis. But when there are mechanical problems, then this particular arthroscopic clearance is far better procedure to avoid early knee joint replacement. Grade 1 and 2 OA with mechanical problems can be benefited with arthroscopic debridement and clearance. And arthroscopic debridement can postpone the need of total knee replacement. What I do in arthroscopic debridement consists of lavage, debulking of the meniscus, removal of calcified menisci, and chondroplasty, removal of loose body or osteophytes from the joint. And the 7th procedures, what I do routinely is microfracture technique to preserve the cartilage loss with fibrocartilage. So this is, I got an opportunity just now about 15 days back, when 8 years back, I had did the microfracture technique in one patient, and after 8 years, I could see the joint, his joint, so that has been healed with fibrocartilage. Though I don't do these procedures so frequently, but I respect these procedures. And those are cartilage cells transplantation. You know that this is now coming up very fastly. Then second is mosaic plasty. That also is good procedures to, in small, portions of the cartilage loss. Meniscus repair. Now you have seen that the most eminent speakers have already told about what is the need of meniscus repair. And now platelet-rich plasma. So platelet-rich plasma also, the results are coming better and better. And we can try that thing also in the patients rather than giving hydrocortisone injections inside the knee joint. And the posterior horn and root fixation, I need not tell you anything more after the last lecture which has been there. So these are the pictures of this cartilage cell transplantation, mosaicplasty, meniscus repair, platelet-rich plasma, and posterior horn and root fixation, what we have already elaborately we have discussed upon that. So at the end of my lecture, I want to tell you that preservation is a human tendency. Preservation is a global tendency. It's a universal tendency. When preservation is not possible, then replacement or reconstruction. Thank you very much for giving me this opportunity. Come and talk to you.
Thank you very much, Kulkarni sir, for such a wonderful talk. Now I request Dr. Shrikant Deshpande sir to give a brief discussion on the posterior portals in the knee arthroscopy.
Good morning, everybody. At the outset, I want to thank IAS One and Dr. Dovle and Satara Orthopedic Association for inviting me for this lecture. So, use of posterior portals in knee arthroscopy. See, back is always beautiful, but so also the back of the knee is also beautiful, but every beauty comes with some danger. So, today's learning objectives are indications for posterior portals, anatomy of the posterior portals, tips and tricks to create safe portals, learn about complications of the posterior portals. So what are the indications? Up till now, everybody has been covering this PCL avulsion, posterior horn, posterior compartment synovectomy, loose bodies, popliteal cyst, arthroscopic popliteus, and posterior corner reconstructions. Though I am not well versed with these techniques, the giants like Samir Sheikh, they are doing this very regularly. So challenges. This is danger to the vital structures in the posterior compartment. The basic two portals are posteromedial portal and posterolateral portal, in which the posterior medial portal is more capacious, and how to avoid the danger to the vital structures is to flex the knee. That is the main crux. Because in extended knee, if you try to do this, and different degrees of extension, they have also tried it, but 90-degree flexion will give it more appropriate space to create these posteromedial portal and posterolateral portals. The danger being saphenous nerve, which is there on the medial side, and laterally, obviously, common peroneal nerve. Though the studies have shown the distances, they have measured the distances, especially in the Japanese literature, that distances are in various degrees of flexion. So posteromedial portal is knees in 90-degree flexion. The sartorial branch of saphenous nerve moves more posteriorly, and that gives a safe passage for your portal. Arthroscope is placed in the posteromedial compartment with the transcondylar notch visualization. Advance as far as medially as possible, and a soft spot between the medial collateral ligament and medial head of gastrocsoleus and tendon of semimembranosus is palpated, and posteromedial portal is localized with a spinal needle at this soft spot just above the joint line. Now here, these are the techniques to create the posteromedial portal. Here the scope is in the anterolateral portal, and we are aiming at the posteromedial side, and you can see the bright spot over there. And these are the landmarks where you can produce this posteromedial portal. So first confirm with the needle, then you can do the procedures. You can put a sleeve and you can go ahead. Now another comes, that is the posterolateral portal. The common peroneal nerve, long head of biceps are immediately posterior. Lateral collateral ligament and popliteal tendon, they are immediately anterior to the posterolateral portal site. High suspicion of tear of posterior horn of lateral meniscus is one of the indications, and when instrumentation is necessary in the posterolateral portal compartment, example is PLC reconstructions. They are doing all inside. Then now coming to the dual posteromedial portal, that is of advantage. In dual posteromedial portal, one is created at a higher level and other is created at a lower level. You have to go for the dual posteromedial portal in certain selected indication. What is the need of this dual posteromedial portal? Conventional technique is viewing portal is on the contralateral side from the working portal, which can make the triangulation difficult in the limited space, which is especially on the posterior side. So two posteromedial portals will allow indirect inline visualization and instrumentation of the structures in the posterior knee compartments much more easier, because posteromedial space is 1.5 times more as that of a posterolateral side. The potential applications of this dual posteromedial portal are identification and removal of tumor masses, arthroscopic synovectomy, loose body removal, use accessory portals during PCL reconstruction and PCL avulsion fracture fixation techniques, meniscus root repair and posterior horn repair, ramp lesion repair. Already Dr. Sundararajan has covered it extensively. So these are the landmarks for the posteromedial, dual posteromedial portals, in which the blue arrow will indicate the proximal and posterior portal, whereas the red arrow will indicate anterior and distal portal. And that is how it is looking. Here you can note one needle is bit posterior and distal and anterior. One is proximal and posterior. So advantages and disadvantages of dual posteromedial portal are: advantages are improved access and instrumentation, easier triangulation because working portal is not contralateral, it is on the same side, allows the indirect inline visualization and work. Disadvantage is it is a less familiar technique, restricted motion in a small space, limited visualization of the posterolateral knee, and increased fluid loss due to these additional portals. The third one is the transseptal portal. Actually, it is very less explored and less used, but it is useful in certain selected situations. The posterior septum in the knee joint is an embryological remnant actually, and you have to define the triangle. It is it is in a Bermuda Triangle, you can say this, because this is a popliteal vein and artery behind, anterior is the PCL ligament, and you have to go in between. And in the proximal part of this portal, there is a medial genicular artery and many mechanoceptors, they are located. So whenever you are taking this transseptal portal, you have to avoid all these things, and then you can go. This is the MRI image which is showing the septum, and septum is at times needed in certain selected complicated surgeries. Transseptal portal. So transseptal portal is used in visualization of posterior superior aspect of the femoral condyles, posterior portion of the PCL, entire periphery of the posterior horn of the meniscus, posterior meniscofemoral ligament, and posterior aspect of the capsule. These are the visualized things in the transseptal portal. The medial genicular artery, as I already told, it is a branch of the popliteal artery, and it is abundant mechanoceptors are present in the proximal part of the septum. So distal part of the septum is safe for creating the transseptal portal. Popliteal artery lies just outside the posterior capsule, approximately 10 centimeters lateral to the septum. So it is advisable to visualize from the medial side and create the portal from the lateral side, because your entry can be seen if you enter from the lateral side, and where that is the area where artery is located. So better to enter from that side and visualize from posteromedial side. And that's how they do. They categorically, Takahishi's paper, he has produced that technique, and here it is described that they serially pass the graded K wires, and over that they will pass the 4 mm rod. First, why these K wires are preferred over these blunt rods? Because the blunt rods tend to slip proximally and they may injure. They try to be as flush to the posterior condyle as possible in that area, and the K wire will penetrate just in this area in the anterior part of that relatively anterior part of this triangle. So if your blunt trocar, if you put it directly, it will try to slide and it will go proximal and it will injure the medial genicular artery and nerve. So better than that, you go for serial dilatation and approach for the transseptal portal. So this is the transseptal portal, where you can see this is a neurovascular bundle in the proximal part. This is a part of the PCL which is anterior, and this is a transseptal portal. So these are the few things that you can do. Already it has been extensively described, that PCL avulsion fracture fixation, suture bridge technique, then ramp lesion repair. This is the ramp lesion where you can repair with these posterior portals. Posterior compartment synovectomy, that can be done thoroughly with the transseptal portal, and posterior compartment synovectomy is needed, because otherwise it will result in partial synovectomy, not a total synovectomy. If you don't use these posterior portals, it could be an incomplete synovectomy. Then you can do the synovectomy using the transseptal portal as well. Arthroscopic loose body excision, that is routinely done. The loose bodies have got a tendency to go posteriorly due to the gravity, and they will go behind the femoral condyles, which are inaccessible from the anterior side. So sometimes you have to take help of these posterior portals to take out this. Then arthroscopic PLC reconstructions, they are doing it. Arthroscopic Baker cyst excision. Baker cyst excision, it was shown very nicely by Dr. Bancha in one of the PKCs. He injected the methylene blue in that Baker cyst, and he was locating it from the inside. And from inside, he gone there and he has taken care of that Baker cyst. Take home message is posterior portals are essential inclusions in the knee arthroscopy. Better understanding of the pathoanatomy is with the posterior portals. Properly executed steps will end up with a safe posterior passage. Expanding the horizons of knee arthroscopy is possible with apt technique of posterior portals, and recreation of the anatomy is much near normal, because with these posterior portals, you can exactly locate where your guide wire is exiting at the exactly crater of the PCL, because usually this PCL origin on the TBI is way below the articular surface. It is 1.5 to 2 centimeters below the articular. So these posterior portals will help you in exacting your techniques. And last but not the least, you respect the tissue, tissue will respect you. Thank you once again. And thank you once again, Satara Orthopedic Association, for calling me here.
Thank you, Deshpande sir, for such a wonderful talk, because posterior portals are always important. Now I request Dr. Prashant Tonpe sir to have a rehabilitation after the knee arthroscopic surgery, because every ligament repair or meniscus or multi-ligament repair has got different rehabilitation protocol. So he's going to deliver us a very important talk on the rehabilitation of the after the knee arthroscopy surgery.
Yes. Good afternoon. I first of all thank you, Dr. Amol Davle and Sandeep Birari sir, and all Satara Orthopedic Society to give me opportunity to talk on this rehabilitation. Actually, this is a lot of bit theoretical topic, but still the rehabilitation is very important for the any procedure we are doing for the knee after the knee arthroscopy. So all this is all usually depends on the what type of surgery we are performing on the knee, and actually recovery is and long-term result outcomes are depends on extent of potential damage in the joint, what surgery we perform, and age of the patient, and functional aspiration of the patient in terms of what type of job they are doing. So, and whether it is office based or it is a manual worker, and what exercise they are doing, whether it is a super fit person or couch potato, means just layman in a home. Then at the level of sports, what kind of sports he is doing, that they're competitive or non-competitive sports. So there are a lot of indications in this. Means all these kind of all surgeries, there's partial meniscectomy, meniscal repair, microfracture, articular cartilage, grafting, ACL reconstruction, MCL repair, PLC, PCL, meniscal transplantation. These all surgery needs rehabilitation. But after literature search, lot of stalwarts, what they are following the all protocol. I'm going to present here only on isolated ACL injuries. So every protocol of the ACL, if there is a meniscus damage, meniscus repair, articular cartilage damage, suppose we are doing any microfracture chondroplasty, then so along with ACL, the protocol will change. So that just the time frames and guidelines after this ACL reconstructions are most protocols are becoming very a lot of protocols are there, but they are always follow that we should get the early range of motion, then developing the quadricep controls, obtaining the full passive extension, then control weight bearing, and initiation of the closed chain exercises. So before starting the we can start the rehab before the surgery. Suppose there is injury patient is coming, then we are planning the for the let the edema subside, and we can start the rehab that time only. So if there is only isolated ACL, you can give the you have to give the some anti-inflammatory, restore the to give the exercise to fully range of motion of the knee joint, then voluntary muscle activation, and you have to educate the patient regarding his future rehab protocol after surgery, what he have to do. Then the exercise are like preoperative, we can give them just these are very simple exercises, ankle pumps, then passive knee extension, passive knee flexion. If there is a in here, I wanted to tell you, if there is a MCL tear, MCL injury is there, so we should not ask to flex. Let it be in extension, let it heal, and let the bone edema subside. Then SLR by 3-way, flexion, abduction, and adduction. Then squats. Then we have to give the brace, long knee brace. Then you can give the to reduce the swelling, you can give the crepe bandage. Then you can ask the patient to do weight bearing as tolerated, with or without crutches. Then preoperative, you can give the long knee brace as I told. Then weight bearing with crutches or with walker. Then coming to the phase 1, when immediately after the post-operative days, our goals are to restore his full passive knee extension, and reduce his joint swelling, restore the patellar mobility, and gradually improve knee flexion, re-establish the quadricep control, and restore the independent ambulation. So coming to this in the day 1 to first week protocol, we can give this the people may give in a big institute, we can give the muscle stimulation. You have to instruct your physio that he should get the less pain by the side where giving the medication. We can start, it is continuous by CPM as tolerated by the patient, we depend on the pain. Then you can give the ice and elevate the limb for the to reduce your swelling. Then give the long knee brace, and which should be the lock-in extension. You can start ambulation. Sometimes it depends on, as I told you, depends on the injury. If there is a meniscus, and if it is a MCL or any cartilage procedure, you should not start the weight bearing immediately. But you can do the non-weight bearing walking as to and improve his range of motion. He can remove the brace and do the exercises. In first then exercise, he has to do like a multi-angle isometric knee extension exercises. Then you have to give the, like we are we are saying to the patient about the overposition and extension, the ankle pumps, then straight leg rising test, mini squats, main our standing hamstring curls, and main is the quadricep isometric exercises. These are the some pictures. You can see the ankle pump, then knee extension, passive and active hamstring curls. Then you can give the muscle stimulation as I told in a post-operative period also. Continue the CPM we can give up to the 90° in the first week. Then you can give you can apply the ice and some same time elevation to reduce edema. So coming to the phase 2, to go in a phase 2, that is a 2 to 4 weeks. The criteria is like that the person should have little quadricep control, full passive knee extension is very important. Then passive range of up to 90° is there. Then we can 90° of flexion is there. Then we can start our phase 2 rehabilitation. there should be the less effusion, and patient should ambulate independently. So our goals are to maintain full passive knee extension, gradually increase knee flexion, then decreases swelling and pain, muscle training, restore proprioception and patellar mobility. So in phase 2, you can discontinue the brace after 2 to 3 weeks. This is only for the ACL what I'm talking, not for the MCL or meniscus injury. He should continue that brace up to the 5 to 6 weeks. And then weight bearing as tolerated, we can give them weight bearing. You have to instruct your physio that he should do these motivate the patient to do the self stretching exercises 4 to 5 times a day, and maintain his passive and active range of motion. Then for the swelling, same like ice and compression and elevation. The exercise in this stage 2, the phase 2 is like muscle stimulation, then isometric quadriceps sets you have to start. Then same like all leg press. I'm not going to detail leg press, knee extension, hamstring squat, weight shifts, front and side lunges, then hamstring curls. By this all our suppose you have your physiotherapist very good, then you can tell to the patient, depends on his age and what sports activity he wanted to do. You have to do these all exercises. Then patellar mobilization. Then main other is like well leg exercises. The normal limb also he has to do all this strengthening exercises. Then in phase 2, they continue this range of motion and stretching and overpressure in extension. That is very important, extension, because that quadricep control is very important to continue his long-term sports and achieve the good range of motion. Then the passive range of motion should be at least 115 degree. So 0 to 50, 115. And you can start in this stage that bicycling, static cycling. Then some people can, for the sports person, suppose their facility there, the pool program is also started. Then lateral lunges. These are some pictures of the phase 2, that is early rehabilitation, that bicycling and active quadricep exercises. This is the static cycling muscle stimulation, and here we can start the proprioception and balancing activity without brace. So any that sportsman get his proprioception and a good balance on his knee.
Prashant, you have to conclude. You are running out.
Yeah. So I mean, coming to the phase 3, the same the criteria is like a progression to the phase when there is a minimal joint diffusion and active range of motion should be the 0 to 115. So goals are the same: restore full range of motion and enhance proprioception and neuromuscular control. So these are the same exercise you have to continue. In the phase 4, I wanted to tell you exactly. Some people are doing this isokinetic test. So we can, if the facility is available, we can do this test, and depend on this test for the sports person and who is active in the sports, we can do this start phase 4. That after the 16 week, there's to regain his pre-injury level, and again to join his competitive sport, we can start this after doing the KT test and active kinetic isometric test. So in this phase 4, the goals are same: normalize the low strength and endurance muscle power, improve neuromuscular control, and exercise the same exercises. Continue. Phase 5, after he can return his in a normal sports on what he wanted to do, play after the 1 year to like that, he can join with full. So after this isokinetic test, this fulfill this criteria, he can join to that sports. Coming to the, so I wanted to tell you that the protocol is a time based basically, and it depends on the tissue healing as well as the criteria. Then the specific intervention should be based on depend on the needs of individual and what surgery, meniscus repair or root repair or MCL repair is there. So the all our time is protocol will change. The time frame for the expected outcome may vary based on the surgeon's preference what additional procedure we perform and what complication happen in while doing surgery. To follow more conservative protocol with regards to range of motion, weight bearing and rehab progression when there are associated injuries like meniscal repair and MCL repair. Thank you. Thank you for it.
Thank you very much, Dr. Prashant, for a wonderful talk. Now I request all the faculties to come over the stage. Dr. Deshpande sir, Dr. Kulkarni sir, and Prashant sir. I would request Dr. Nikhil to felicitate Dr. Prashant Donpe. Thank you very much, sir. Now I request Rajiv sir to felicitate Kulkarni sir. I request Inamdar sir and to felicitate Deshpande sir. Thank you very much for such a wonderful session. Now I'll conclude the session and hand over mic to for the new session.
सामने आ गया
Ankit sir, are you listening? Tonpe sir, क्या दूसरा? Okay.
जैसे सुबह
अंकित
किया था
सर।
वैसे ही कर लेते हैं दोनों बराबर साइज की
Hello.
Hello.
हाँ,
Dr.
Ankit sir.
Ankit, can you hear?
वो दे दीजिए मुझे
Hello.
Police force है। Police force है। तो निकाल देना इधर से।
Ankit sir.
Yes.
Hello, Dr. Ankit.
Yes.
Can you hear me?
Yeah, clearly.
Here, Dr. Raju Munde here.
Hi, Dr.
So
Rajiv.
you can skip the initial steps which has been told in
Am I
previous
visible to
case.
everyone?
Yeah.
Yeah, sir. Yeah. Slideshow.
Yeah, just about the patient history and the X-ray MRI if you're having it.
Ortho card ले लीजिए please.
Operating surgeon Dr. Ankit Varshini.
एक निकाल दीजिए ortho card please.
Case pain in right knee, difficulty in walking, history of twisting injury 1 year ago.
थोड़ा volume बढ़ा.
While preparing for police recruitment. Has entered drawer test grade 2 positive, McMurray test positive, virus stress is negative, valgus stress grade 1 opening, MRI suggestive of ACL tear with grade 3 buccal handed tear. This is a clinical examination.
So am I visible to everyone?
Yes, sir. Yes,
Yeah.
sir.
Audible also?
Thank you, sir. Yes, sir.
Great. So we have this 29-year-old gentleman. He's a police recruit, and he had this injury to his knee, to his right knee, about 15 months back. We've all seen his clinical examination. He's unstable. His Lachman is positive. His pivot shift is positive, and his medial, he has a McMurray test positive, and the medial joint line is tender.
Yes, sir.
So clinically, we suspect ACL
tear and a medial meniscus tear. His MRI says a full thickness ACL tear and a bucket handle medial meniscus tear.
Yes.
So I've harvested the hamstring tendons. So his semitendinosus was about 30 centimeter long. His gracilis was about 29 centimeter long. So we are trying to do a 8-strand sort of a thing for him today. Maybe we have a 7.5 centimeter long graft available today. Chalo, scene में इधर करो. इधर है? इधर करो. Orthopod से. Yes, sir. We're going to whip stitch the tendon from both the sides.
Okay.
And then quadruple it so that we have 8 strands of.
Your preferred graft of choice is semitendinous, or you take other graft also?
Sorry?
Whether it is other graft of your choice?
So my primarily all my ACLs are, most of my ACLs are hamstring. If I'm doing a soft tissue graft, I keep my peroneus longus for revisions and other situations. So primarily I would do a hamstrings most of my cases.
Okay.
I keep my BTBs for the high-end combat sportsmen like wrestlers, kabaddi players, footballers.
If there is a concomitant grade 1 or grade 2 MCL injury, just strain, MCL strain, then still you will use the hamstring?
Yeah, so it's a good question. So in that situation, I'm going to consider the patient's occupation, sport. If the patient is a recreational sportsman or just a sedentary lifestyle individual, I would still prefer the hamstrings. Otherwise, if it's a soft tissue graft that I've decided, I may take the peroneus longus for that patient.
Yeah. Now more and more use same PL graft for that kind of thing.
Yes.
Whenever there is MCL grade 1 or grade 2.
MCL, I think grade 1.
Sprain. It is
Yeah.
some laxity. Some opening is there still. Why to again?
Yes.
Oh.
Take one more orthopod, please.
What is the duration of surgery once a patient got injured? It's like what did you wait for ACL reconstruction?
So earliest I would do in about 3 weeks till after the injury has settled down, the knee has become silent. Is that the question? Am I right?
Yeah. Yes.
Okay, so the earliest would be about 3 weeks. Yeah.
In case of MCL injury.
Just a moment. Orthopod, please. So I'm hoping to get a minimum of 8 mm graft here. Scissor, please. Yeah. Don't put my. So this is about a 7.5 centimeter long graft.
Okay.
Not the ideal that I would want, but considering the thickness, I'm quite happy with the thickness out here. Yes, so it looks like a 10 mm femur and 10 mm tibia.
Okay. Length is 7.5, right?
Length is 7.5.
And you are planning to fix it with a fixator button.
A fixed loop button, yes.
Okay.
So we'll have to do a little bit of compromise here and there, but I'm really happy with the graph thickness. So chalo, let's go ahead with this. इसको आप tensioning पे लगा दें, vancomycin. Okay. Now we are going to start our arthroscopy. Standard anterolateral portal.
After the size of the and length of the graft, what is your planning for the TBL fixation?
TBL fixation. I'll still prefer an interference screw, and maybe if the graft is short, I would use a post down.
Okay.
It could be a metallic post, or the remaining threads can be tied on a bone bridge also on the anteromedial aspect of the proximal tibia. Can we have the top lights off, the OT lights off, please? Just the OT lights. Keep the ambient lights on. Yes, the OT light, the top light off. This light off, please. So we don't have a good vision today. Can somebody help me with the vision? We had a good white balance, everything was okay.
You will prefer to do in limb with the side support?
Yeah, so my position always is a supine with the side support and with a post down there at the end of the table.
Okay.
Are we okay with the vision? So I think this is the best that we can get today.
Some cloudiness here. Maybe very foggy night?
It was not fog before. We tried it.
No, because of the camera cover. Fog is there.
So do we have some time to change the camera cover?
Maybe try the foggy, the like scope.
Sorry?
Can change the focus the camera.
Tried all of that.
No, still there is. You can take, you can just, you can change the cover.
Chalo.
Till that time we can, by the time we can continue with one lecture.
Sure, please go ahead.
Okay.
No, the lens is not the problem, it's the camera cover. एक नया camera cover दे दीजिए please.
So I would like to call Dr. Rishi Joshi to have his talk, that is surgical step setup for patient positioning for shoulder arthroscopy.
Good afternoon, friends. I thank the Indian Arthroscopic Society and the Satara Orthopedic Society for giving me this wonderful opportunity. This is a very important topic. We'll now be deviating from knee towards shoulder, and we have a good lineup of shoulder surgeries also. So it's very important to know the setup and positioning for a shoulder arthroscopy, because if the position is not right, your surgery is going to get messed up. So having the right setup, the armamentarium, and knowing your instruments is very crucial.
today. So as we know, most of the surgeries around the shoulder are possible with a scope, leaving apart the replacement and the fractures. So for all the young budding surgeons here, all the postgraduates, it is a good time to invest to learn from the beginning the arthroscopic techniques. Shoulder arthroscopy has seen a tremendous evolution. Right from a diagnostic tool, it has gone to be used for the final treatment. And we have seen a tremendous evolution in the fixation devices which have been used for the instability as well as for the cuff repairs, from the metal anchors to the absorbable anchors to the peak anchors. And still every year on year, we see different type of implants being made available. So in our armamentarium, it's important to have these different type of lassos, which are very useful for repairing the ramp repairs for the knee, as well as for the Bankart labral repairs for the shoulder. And these are the different penetrating graspers, tissue graspers, 30 degrees, 60 degrees, sixter, all these devices you have to be oriented. These are the devices which will help us to repair the different type of the labrums. Labral tears at the 6 o'clock, at the 3 o'clock. So the basic kit should include everything that's mentioned here, but it's very important to have a radio frequency probe, a good RF, a good motorized shaver, and be versatile in using all these equipments. As well, a fluid management system pump helps in cases like a Latarje. A routine Bankart may be done without a pump. A grasper, a Weisinger rod is very crucial. It is helpful to change between portals, to change the position of the scope when switching from the anterior to the posterior portal. And these cannulas are also very useful to avoid losing the tract of the scope. So getting into the position, it is very important for the surgeon to operate in the position he is trained in. Beach chair and lateral decubitus, both of them have their own advantages and disadvantages. So I recommend for the surgeon to stick to the position he has been trained, but to be able to also learn the newer position. So this is the beach chair image on the left, and that is the lateral decubitus. So in the lateral decubitus, the patient is on the standard table, and with the help of a bean bag and anterior posterior supports, patient can be easily positioned. The arm is essentially distracted by a vertical traction and a longitudinal traction. In lateral decubitus, the patient is tilted 30 degrees posteriorly. This helps to align the glenoid parallel to the floor. This also decreases the risk of neuropraxia. Tilting the patient 30 degrees posteriorly accentuates the labral tears, making it easy to identify. And this also gives easy access to the 6 o'clock position. And vertical and longitudinal traction, the most traction important here is the vertical traction, because it distracts the glenohumeral joint, and generally about 4 to 6 kgs is applied. All pressure points have to be well padded. This is the standard beach chair position with a head positioner. Here are the certain advantages. It is upright anatomic position, very faster and easier orientation for the surgeon, easy for the examination under anesthesia. Arm is not hanging in the way of the anterior portal. Again, important is there is no need to redrape or reposition to convert to an open procedure. In case if you're not sure and you want to convert to a letarge, let's say. If on previous examination, there is a critical bone loss about 14 to 15 degrees. So post your arthroscopic examination, you would like to convert to open. Beach chair makes it way easier compared to a lateral position. Certain disadvantages: there is increased risk of hypotension, bradycardia, causing cardiovascular complications. So as a surgeon, you have to be very well versed with your anesthetist and communicate to them, and based on the patient's risk, because majority of our cuff repair patients are in their late 50s, 60s. So if patient has deficient ejection fraction less than 50, sometimes even our anesthetist advise just to do the surgery under block, and we have done beach chair only in regional block like interscalene. Sometimes fluid can fog the camera, and cautery bubbles sometimes obscure the view in the subacromial space. Very rarely, prolonged hypotensive episodes can lead to death. Thank you.
Thank you, Dr. Doshi.
We can check the vote. Yes.
Yeah. Dr. Ankit, can you hear us?
Can you increase the volume, please?
Hello, Dr. Ankit.
Okay. Am I audible?
Yeah.
Okay, so we've changed the camera cover. Now there's seems some problem with the camera now. I'm waiting for it to.
Can you shift to the monitor view?
The monitor is not working right now. We're trying to fix it.
Yeah, Dr. Ankit.
Yes.
How much time will take? It's like to restart again. So can you wait for 5 minutes more?
I know the guy out here is trying to fix the camera. There's some problem with the camera console.
No, okay. So we will start the next lecture.
Sure. Please go ahead.
Yeah, yeah. Till that you continue.
Yes.
And we'll rejoin again.
Sure,
Okay?
sure. Please go ahead.
So next talk will be Dr. Abhishek Mahajan. His topic is clinico-radiological examination of shoulder injuries.
Hello, good afternoon, everyone. On behalf of Satara Orthopedic Society, I would like to welcome one and all over here, and extremely sorry for the technical issues during the surgery. I'm Dr. Abhishek Mahajan. So today I will be speaking about a very important topic which is often neglected, or we just read it for our academic purposes or for your exams, and don't implement it correctly or fail to do it in clinical practice due to our busy schedules. So my topic is clinico-radiological examination of shoulder injuries. So as all of you know, shoulder pain is one of the most common conditions for which the patients will be visiting your outpatient department. And in such cases, the first thing you should do is differentiate the pain. Okay, so whether it is referred pain, which is caused due to some diaphragm pathology or gallbladder pathology, or radicular pain, which might be neural in origin. So what we are going to talk about today is actual shoulder pathology, which may bring patient to our OPDs. Okay, so first part will be clinical tests, okay? And this after that, after examining the patient, we will order for some radiological examinations. So first and foremost, everyone should remember is both the clinical as well as radiological findings should correlate. Okay, so without that, you shouldn't treat or operate on the patient. Okay, so the clinical tests, as always, clinical test begins with a good and detailed history. And many times in some common conditions, the patient will answer or tell about the diagnosis themselves. You have to just be meticulous in your questioning and have your ear on the patient's answers. So as many of you must be aware, there are lots and lots of publications on topics which are focusing just on shoulder physical examinations. Okay, so sheer number of these papers tell a lot, and indirectly it is telling that there is lack of consensus or lack of ideal tests in shoulder examinations. And there is obviously an unmet need. If you read any textbooks, there are multiple tests which are described for most of the conditions. And unfortunately, we don't have a single test which is either pathognomonic or which can be said it is the best for that particular condition. Okay, so many tests don't have ideal sensitivity or specificity. There are lots of variations or modifications which are described in performing the same tests. And many tests can be positive in multiple conditions. Okay, so it is very difficult to state exactly which condition is causing which test to be positive in a particular patient. So I have just 10 minutes to talk about this topic. So it is very difficult to elaborate and describe each and every test. So what I'll be doing, I'll be just giving an overview about clinical tests and some radiological investigations. And we unfortunately, we'll have to wrap up on that. So for ease of talking, I've divided the shoulder conditions into following types. Okay, so first will be cuff, second will be impingement, third will be instability, fourth will be labral pathologies, then biceps pathologies, sixth will be stiffness disorders or frozen shoulder, and seventh will be others. So it can be AC joint, neural or vascular pathologies. And some important things which I won't be discussing, but you should be aware in your clinical practice. First is fractures and dislocations, especially in osteoporotic patients where there may just be a simple fall and we may miss out on fractures. And second category of patients will be those who are malingering, those with psychosomatic disorders, or those with ligament laxity. Okay, so managing these patients is a different ball game, and we'll not be talking about it today. Yeah, so I was doing this topic when I was doing my fellowship in South Korea. So there are at that time, so in 2015, there are about 129 tests which are described for shoulder pathologies, and I'm sure the number must have grown now. So it is a huge number, and practically it is not possible for any one of us to remember each test, the specificity, sensitivity, positive predictive value of each test. So this is so it is an extremely huge number, and I believe that it is the largest number of tests for any single joint in the body. Okay, so as we have discussed, there are dozens of conditions, hundreds of tests, and it can be overwhelming for anyone, especially the beginners or young surgeons out here. So how can we deal with this predicament? First is we have to focus on common conditions. As they say, rare things are rarely correct. So at least in beginning of your practice, we can ignore the rare conditions. And another trick is master just one or two tests for each condition. Okay, so you need not mug up or know each and every test. Just one or two tests, if you're able to do appropriately, correctly, it is more than enough. So which test will you select? First of all, it should be easily reproducible. Okay, so if you're doing it in any setting, in the OT, in the OPD, in your office or in your house, it should be easily reproducible by you and by someone else as well. So if you're communicating with your colleague, so I have done this test and this is positive, that person should also be able to do it in the same way. Secondly, it should be least painful for the patient. So if the test is painful, he won't allow you to do any further examinations on the shoulder. So the test should be least painful. Third, it should be as sensitive and as specific as it is possible. Okay, so maximum amount of sensitivity and specificity should be opted for. And lastly, personal experience. Okay, so each one of you will be having some experience regarding this test, and you'll be correlating those findings on further radiological investigation. So that also plays a role. And so now I'll be describing the condition. So what I've done, I've mentioned the condition, I've listed the commonly used tests, and the one in orange, they are with the best validity. Okay, so I have scanned through some frequently quoted papers in literature. So the ones in orange, they will be the ones with the best diagnostic criteria. And obviously that will be varying. If you refer some other papers, that will be again different. So it has to be taken with a pinch of salt. So most common condition is rotator cuff injury, and most commonly injured tendon will be supraspinatus tear. Okay, so these are the list of tests. Okay, so some of them even I read it for the first time. So the Job's empty can test, which most of us must be doing, and the drop arm test. Okay, so these in literature, they have shown to be having maximum diagnostic value. And for SSP, again, these are some tests, and the ones in white, they have shown to be of doubtful value, or the value has not been tested through rigorous scientific evaluation. Okay, so the second category will be rotator cuff tear involving the infraspinatus. Okay, so external rotation lag sign. So when you ask the patient to keep your the limb in this position, the patient won't be able to do this, and the arm will fall back into internal rotation. So external rotation lag sign, here you have to note that it is either positive in infraspinatus alone, or combined SSP and ISP lesion can also give it, it can be positive in that as well. Third will be subscapularis. Bear hug and belly press, most of you must be aware. Bear hug, you have to ask the patient to keep the arm on the opposite shoulder, and ask him to resist the external rotation force. And belly press, ask the patient to keep the hand on his abdomen with the wrist straight just below the xiphisternum. If the elbow is not remaining in this position, it's falling back behind the abdomen, then it shows weakness of subscapularis. And those for massive tears involving two or more tendons. So we have something known as hornblower sign. The patient won't be able to keep his arm in this position, and it will tend to drop down. Okay. The second category which we deal with is impingements. Okay, so it can be either external impingement, which is commonly known as subacromial, or internal impingement occurring due to some pathology in the shoulder glenohumeral joint. So the Neer's test and Hawkins-Kennedy test, most of us must be aware. But the recent literature has shown that these tests don't have any diagnostic validity. Okay, so they did a number of tests, meta-analysis was done, and they found that at best it can be doubtful. So as of now, there is no clinical test which is recommended for impingement. So it has to be combination of tests, history, and your radiological evaluation. Okay, so the same is with internal test. There are tests described, but it's not of any diagnostic value as such. Third most common category will be anterior instability, commonly known as Bankard's lesion. So anterior apprehension and relocation tests we all have been doing. So they have proven their worth over time. And again, there are a lot of tests for Bankard's lesion. For posterior instability or posterior labral tears which are causing dislocation, again, there is no test which is of proven diagnostic value. Another very interesting pathology, and on literature search, I have noticed that SLAP lesion. Okay, so it has the maximum number of publications and maximum number of papers which are describing tests for this condition. It is the maximum for SLAPs and biceps pathology. So O'Brien's test we all have been doing. So there are lots and lots of tests. I have included only the common ones. There are others which are like described in one or two papers. I've not included them. So O'Brien's test, you can like do it very easily in your OPD. And yeah, so similarly, you can have posterior labral tear without instability. Okay, so it is commonly seen in throwers, athletes. Okay, so if you are dealing with those kinds of patients, you have to be aware about these lesions which will cause pain on the stress. Okay, so biceps pathology, as I told you, very like frequently visited topic in publications on PubMed. Okay, these are only PubMed listed tests. So irrigation test, speed test, we have been doing it since our PG days. So unfortunately, none of these tests have any diagnostic value. Okay, when you do it in then the test is done on its own. Okay, so stiffness or adhesive capsulitis, again, a very common condition. So quadrant test and internal external rotation limitation test. The second one is very easily done. Patient is not able to rotate internally, externally limited as compared to opposite side. So it is of good diagnostic value. AC joint, again, lots of tests. So very simple test, direct compression of the acromioclavicular joint, and tenderness elicited on percussion or compression is of good diagnostic thing. Okay. So these are some common conditions and these tests which I have described. And there are some rare conditions and it's not possible to cover those in short duration. So I would recommend you know these tests which have proven diagnostic value, you know them by heart. And as mentioned, as per your personal experience, you can modify your tests or whatever you are doing for examination. So second part of the topic is the radiological tests. Okay, so important point to note is it should be used only for confirming clinical diagnosis. Okay, so depending on just your radiological finding or patient comes to you without examining, just ordering MRI, sonography and treating on that, it can be problematic for you as well as the patient. Okay, so as per American College of Radiologists and their recommendation, initial investigation should always be X-rays, and the next modality is guided by your clinical findings and whatever your findings on the radiograph. Okay, and generally fractures, dislocations, any tumors, okay, or late stage avian, they can be diagnosed with X-rays. And also it is very useful whenever implant is there. Okay, so sonography or MRI is limited when implant is there. So in presence of implant, X-ray is very good. Second is USG. First of all, it is portable, it is very cheap, and it is real-time investigation. Okay, so unlike others, the only real-time investigation which we have is ultrasound. And in patients who have contraindications for MRI.
Can you little bit wind it?
Yes, two, 3 points, yeah. And it can be therapeutic as well. However, it is user dependent. Okay, so CT scan, it is just for evaluating your glenoid lesions in most cases or fracture anatomy. MRI, it is gold standard in most cases. There are some described ABER protocol, shoulder is placed in abductional external rotation and MRI is done. So it is all very limited or in limited centers it can be done. MR orthogram, CT orthogram, bone scan, they are in limited cases, and whenever you have such patients, you can do them. And last but not the least is diagnostic arthroscopy. Whenever you are operating the patient, you insert the scope, you have to thoroughly examine entire shoulder and only then start your surgery. So finally, I would like to conclude, well begun is half done. So good diagnosis is very important before you operate or treat the patient. And no ideal test exists for majority of shoulder pathologies, and good history and combination of multiple tests is the way to go. And radiological findings should be correlated with clinical findings, and always be aware of malingering patients, psychosomatic cases and ligament laxity cases. Thank you.
Thank you. Thank you, Abhishek. Can you check with OT? No, okay, we are continuing with lectures. Okay. So next talk will be.
थोडं गरम केलं बाबा चालेल, थंड करू नका. It's very cold.
Maybe because of that.
Yeah.
Okay. Ankit, can you hear Ankit? Dr. Ankit.
Tape. अजून
Dr. Sandeep, can you hear us?
Yeah, so we are trying to fix the fogging issue of the camera. Maybe this time we'll go live now.
Okay.
We'll tell you right, sir बताएंगे जो sir बताएंगे वो करो.
Okay, it's all right. Looks good.
Thank you. Is it okay, Rajiv?
Now, can I have?
Vision good now?
Yeah.
Perfect. Chalo. Shaver, please. I'll try to quickly wind off
Yeah.
so that we can compensate for the lost time. Am I audible to all of you there in the hall? Great.
Yes, Ankit.
So that is the notch that we can see the ACL is absent. And those are the remnant fibers of the ACL. I would clean up a little bit to find the over the top. Yeah, shaver is okay now. Yeah, shaver is fine. Thank you. Try to find the over the top position out there, which would guide me for the femoral footprint. There are multiple ways to find the footprint. In the morning, we saw how Dr. Sunit Hazra showed us the anatomical. Yeah, I'll just show that. So that is the, can I have a probe, please? So that is the posterior cartilage margin of the femoral condyle. That is the bifurcate ridge. So our femoral footprint has to be between this and this area. And the height is decided. I try to be just close to the over the top position somewhere out here. So that would be my starting point for the femoral socket. Now, you have on a roll. Okay, so that is the medial compartment. We know from the MRI that he's got. Can I get a needle, please, for pie crusting? We know from the MRI that he's got a bucket handle component. See how bad is it? So I normally do pie crusting just below the joint line, and that is the opening of the joint. Probe.
Pie crusting you do in every cases or in some cases where?
In some cases, when I have to actually work in the medial compartment, the medial compartment is tight. I don't like scuffing the cartilage, so I'm okay with releasing the MCL. Okay, so this injury is 15 months old, and this is like a transected bucket handle. There are two flaps out there. I don't think there's anything to repair.
It's like a complex type of meniscus.
Yes. He's got a rim, remnant rim on the periphery, which looks healthy to me, stable, healthy. I'm going to resect out these two pieces and balance it. Can you hold the leg, please?
There is some fish mouth opening kind of.
Yes, so that is the horizontal component, the degenerative component in the complex meniscal tear. I need a shaver after this. Please keep that ready. Okay, a shaver, please. I've got a solid team out here. Kudos to Dr. Dowle's team from the hospital. Excellent work. So that is the resection of that part of the loose part of the medial meniscus. Started to fog again, I think. Punch, please. So the root looks stable from here, and there is a remnant rim peripherally. So I'm happy with the remaining meniscus that we can see. Shaver, please. I can see it has started to fog again. Apologies for the vision, but I think in the interest of saving time, I'll try to finish off the case. Okay, so that is all that I want to do for the pro, please. For the medial meniscus. So the root looks stable. So that is a small fish mouth opening, which is of the degenerative component, and the remnant is stable. Of course, that is not the best for him for the medial compartment, but great. So that is all for the medial meniscus. Now we'll go to the lateral side, figure of 4. Okay. Pro, please. Great. So that is the root area. It's got a small undersurface tear, but that looks like an incomplete tear. The body looks okay. That is the popliteal hiatus, the popliteus tendon coming all along, and the lateral meniscus looks perfect. Great. So we go for the ACL and roll RF, please. No. So that is the over the top position. The RF is not working. Can you please do something to it? And it's not just working. बढ़ाने का issue नहीं है. Okay. So somewhere here would be the footprint of the ACL. I normally like to mark with my RF so that I'm able to aim when I'm using the femoral offset. The RF is not working out here, but okay, a little bit of mark out there is okay. So let's go with the offset, please. 6 mm offset is what we're using today.
We were preparing for the femoral tunnel first, right?
Sorry?
You are preparing for the femoral tunnel.
Yes. So I would use a.
That's it's like that is a routine of.
That's my routine. Yes.
Of tunnel.
Absolutely. So if I have to do some repair work for the meniscus, I would make the femoral tunnel hyperflexion first, finish off the meniscal work, and then come down again for the tibia. Chalo, go ahead. Flexion, please. Wait a minute. So I think we've got a 10 mm graft. So if let's take a 7 mm. Yeah. So we'll be a little more safe. So this is going to render a 2 mm
measuring probe for the lateral condyle.
Sorry?
Measuring probe.
The measurement for the lateral condyle? Yeah, so that is one way to do it. You can measure with the ruler the entire lateral condyle, and then about 40% from the posterior. That is the starting point. Chalo. Flexion. Really, the vision is not really good today. Chalo. Can you please? Yeah, go ahead.
How much flexion you will do, or you will just bend the knee fully?
Yeah, so the knee is in about 110, 120 degrees of flexion. Okay. So go. Yeah. So this is about 110, 120 degrees of knee flexion, hyperflexion. That is the bead pin right in the middle of the footprint of the ACL. So key, please. 4.5. 4.5. So we have a graft which is 10 mm wide. both on the femur and tibia.
So have you used accessory medial portal, or you are
No.
taking from the medial portal only?
I'm visualizing from the anteromedial, anterolateral, and the standard anteromedial portal is what I'm using for the preparation of the femoral tunnel. So this is 4.5 mm wide. So this would be through and through. Hello, reverse please. Depth gauge please. Drill. So a little bit of cleanup so that we keep removing the bone debris and are able to visualize properly the depth gauge. Depth gauge, please. Okay, pressure, please. Pressure. Okay, great. So this is where's the marking? 40. So the tunnel looks about 38. 38. So I'm using a fixed loop today.
So what is the size you have planned?
So-
Size of fixed loop,
So
length?
we don't have a 25 mm fixed loop. I think it's not there in the inventory. Number one, that is the first issue. Second, really? मुझे बोला था किसी ने 25 नहीं है? है? 30 नहीं है? 25 नहीं है ना? Okay, so we don't. Allah. Okay, so we have all the sizes of the fixed loop. The issue out here is that I've got a small graft. The length of the graft is small. So I'm going to compromise a little bit on the so say about 30, I'll take a 30 mm rigid loop, the maximum size.
So Ankit, there is a question from audience.
Yeah.
I am Dr. Devendra Jadhav from Kolhapur.
Yes.
You said that you had a graft of 10 millimeter of diameter.
Yes.
You have taken an offset of 7 millimeters.
Yes.
To drill it.
Yes.
So suppose that you will be having only around like 2 millimeter of cortex, which will be left posteriorly.
Yeah.
So do you worry? What's your calculation for that?
So I'm okay with.
You're okay with 2 millimeter of posterior
yeah.
cortex?
Yeah, yeah. So 2 millimeter is okay. So anything less than 1 mm should not be pressure, please.
Any chance of posterior tunnel blowout with this?
Luckily, I've never had it.
Okay.
2 mm is good enough.
Directly with the 10 mm you're drilling?
Sorry?
Directly 10 mm
Yeah,
or
yeah.
serial?
Yeah. So this is direct 10. So the vision is not good. So I'm expecting fogging to be a little hurry.
No, you just puncture a little bit of that camera cover.
वो सब करके देखा है सर. Yeah, so I'm,
You can take your time.
okay,
because
chalo.
already we have covered two lectures.
Reverse, please.
So,
Camera
Ankit,
ko-
can you tell your plan? It's like what button you are using, what
I'm
is size
using-
of button, and
yeah.
how much you are drilling?
Yeah, so
What is your plan? Yeah.
yeah, so the length of the femoral tunnel was 38. I've drilled till 30. So I have a 8 mm cortex available for the button to fit.
Okay.
Now I've got a small graft, but in the interest of the thickness of the graft, I'm going to compromise on the, yeah, please go ahead, on the graft available in the femoral socket. So I'm going to use a 30 mm rigid loop.
Okay. So you
About-
are using the 30 mm, 30 size, right?
Yes, 35 closed loop. Can you please clean the?
So there will be the only 8 mm graft inside the femoral tunnel.
Okay. So that is the femoral tunnel, right exactly where I want it. So a little bit of cleanup to remove the bone debris. Great. Chalo. Let's go down for the tibia now. Go. Okay. So I normally like to park my passing suture back in the gutter there, so that it does not interfere my vision.
Ankit, can you show us the exactly your femoral portal from the rear portal?
Yeah, I'll do that.
Yeah.
Sure. So that is where the femoral tunnel is. So that is the 2 mm posterior wall that is available.
Okay.
That's the femoral tunnel. Is it visible?
Yeah, it is visible.
Yeah. Are you guys happy with it?
Yeah. But your plan for the 30 loop, just little, there's only one.
I know.
Huh.
I know, but the length of the graft is not too good.
Okay.
Just that, chalo, you can use a 25 also.
Yeah, you can use 25.
Okay. Okay, so Dr. Sandeep wants to clean the cover again so that we have a good visualization.
Till that, you just tell how much size will be inside the tunnel, or if you when you use 30 mm.
So, so there would be 8 mm graft in the femoral tunnel. I know that's not ideal,
Yes.
but he's a big guy, he's a bulky guy. I'm expecting a long tibial tunnel also. So because of these two issues, I'm choosing to keep 8 mm inside in the femur.
Okay, but you can use it's like 25. You can put a more graph on the higher side, and you can
Higher
use
side.
the endo button. Sorry, suture this on the tibial side.
Yeah, we can do that also.
Yeah, because you can,
That will be better, right?
that will be more better because graph length in a tunnel of femur 8 mm is very less, right?
Yeah. Yeah, scissor se cutting. Scissor blade something please. Okay. You clean किया? Okay. I know we all can relate to what is going on here. In our initial days, we all have had these issues.
During times of the, that also could be the reason for this
No,
temperature going haywire.
Yeah, there is a question from.
Yes.
Sir, can you please explain the calculations in a fixed loop about the tunnel size and how much should we take the fixed loop for particular?
So fixed loop system, in fixed loop, basically you need about, in any suspensory device fixation for the femur, you need about 5 to 10 mm of cortical wall, Prokar please, for the button to sit, that is one. Then ideally you should have minimum 15 mm of graft in the femur. So you have to minus that from the length of the entire tunnel, and that gives you the loop length that you have to choose. Okay, that's a little better now. So let's go for tibia. We're running late, guys.
Get it or you don't? Okay.
Tibial jig. Sorry. So this is a footprint jig. That is the remnant tibial stump. We have a wide graft. It's a 10 mm graft. So I'm going to err a little posterior here and do sequential reaming.
Okay.
So chalo, let's go.
No, it will still come ahead. You have to go a little posteriorly. I think.
Yes,
So, yeah.
I'll do that once the bullet is inside because chalo, please right angle, please. Chalo. Great. Please fix it on the tibia. Okay. So I think that should be
Yeah.
the
That is
place
okay.
from where, yeah. Chalo, go.
What's your location of entry? Means like how much away from the lateral meniscus root and away from the PCL?
Just a moment. Bus. So we have to know that about 70 to 75% of the tibial footprint is within the area of the root of the lateral meniscus, just adjacent to it. So you want the entire graft to be within that area. You have to be about 7 mm behind the PCL from there, the entire tunnel. And the exit of your bead pin should be in line with the posterior border of the anterior root of the lateral meniscus. Chalo. So we'll take a 7 mm first, then yeah, sequential. No, sequential. 7, 9, 10, or 8, 9, 10, whichever way you want.
Why we are, can see your pin is coming out from the PCL, ACL stump, which
Yes.
is little bit looks like a posterior, but ideally the pin should have more anterior, right?
No,
Yes.
Than the pin.
as
Yeah.
there is a size 10, so that's why we
Femoral
take
size
the
is 10. I don't want a.
Yeah, but still it looks like ideal only because it's 2 mm away from the PCL lateral meniscus root and the 7 mm away from the PCL.
Aram se karna, aram. Chalo, go. Just in the substance of the graph.
For the beginners, see the Ankit is doing. He just put the guide wire little posterior because of the size, and now he's doing sequential in the first 7, and as he goes higher, he will just press that guide wire so that it will more rim
that is-
posteriorly.
So this is 7 mm. I have a chance to readjust my center of the tibial tunnel if I want to lateralize it, medialize it, posterior, anterior. So this is a tip for the beginners. Always do sequential out here so that you're sure. Chalo, go ahead, 9. Just be gentle. We don't want to remove the native remnant. Please. Okay, out. Okay. So that is 9 in, and now we're going to take a 10.
His bone quality is good.
Sorry, yeah, bone quality is very good. He's a police recruit. I'm sure he must be.
If there is a bone quality is little dicey, so then you can use 9, you can little dilate and compress that bone against the wall of the tunnel.
Yes.
So you can dilate the tunnel.
Okay. Yeah. So that is where the graft is going to come out from. So let's just give out सब लेते हैं। बाहर निकलना किसका है? I don't want notch impingement also, so a free space for the 10 mm graft to exit. Chalo. Is the graft ready with the button, guys? So I heard somebody suggesting 25
Yes.
loop. Chalo, let's do that. We'll take a 25 loop, load it in the graft. And the suture disc is also ready so that we can do a accessory fixation down. So normally I take my camera off at this point and be in total control while my graft is being passed. But today, for demo purpose, we'll keep the camera inside and have the graft pass.
You can keep your camera scope in an AM portal so that you can see.
Yes. So my assistant is going to pull the pulling thread in of the loop, the white one, and keep on removing the slack from the green one. mouth of the tibial tunnel clean. It's a tight graft. Yeah, I'm happy even if I have to spend some time passing the graft, because a 10 graft is really good. Nice. Can somebody come and give counter here? Okay, great. Flip करेगा एक बार आतिश? हो गया flip? Excellent. So that is the graft there in the joint. Probe, please. We'll take a 1130 Milagro Advance. So Milagro Advance is my preferred screw. I'll just remove this telescope now. Milagro Advance is my preferred screw because of various reasons. It has easy penetration in the tunnel.
How much graft is inside tunnel?
I'll just see. Sure. Sure. Acha, chalo. Okay. So in the interest of saving time, I'll just show you the final picture inside and then fix it down so that you guys can continue with the lectures, because we've already taken some extra time out here. So that is the graft.
No, we can't see the picture. Yeah.
Great, chalo. The next step, after I fix it, I'm going to check for impingement.
Yeah.
I can see slight
Impingement is there.
impingement. I'll do a notchplasty in the end. Great, I'll do a notchplasty for sure. And if we have time, you guys can come back and we can see the end picture of the notchplasty and the fixed graft. Will that be okay?
Yeah.
Great.
How much that graft came outside the tibial tunnel?
I'll just let you know. Retractors, please. Retractor, please. Retractor, please. Yeah, so the graft is right at the edge of the tunnel. Let me just give you a peep out here. So 25 was a good decision. So that is the graft.
Yeah.
Can you guys see the tissue?
Yes.
It's started to fog again. So that is the tissue coming out with the thread.
Yes.
So that's the graft. So 25 was a good decision. I'm going to use a 1130 Milagro Advance.
Okay, but you can't use disc now.
I will not be.
You can
so
use a
normally, I don't like to use any metallic.
pillar post.
Yeah, so this is good enough for me.
Okay.
Sure.
I think.
Cycle करेंगे.
Thank you, Ankit. We'll see you again after fixation.
Sure.
I
Thank
think
you so
it
much.
showed-
Thank you for bearing with all the issues in the operation
I
theater.
will call upon next moderator, Nishant Gaukar and Dr. Srikant Deshpande, sir.
So for your question, so there is bone breach of 8 mm, right? We have used 25 mm of the fixed endoponent, right? We required at least 10 mm the gap between the tunnels to flip the endoponent. That's why we have to use it 10 to 15 mm more than the routine. So here you can see the graft size is around more than the 8 mm. They are around, you just minus the 38 minus 25 that, and then minus 10, that will be the graft size inside the tunnel. Okay.
May I request Dr. Rahul Patil and Dr. Sanjay Shesagar sir to come on dais. Dr. Nishant is here. A gentle reminder for in-house guests who are staying in the hotel, you need to check out. Those who are not checked out, please check out at your time. Thank you.
Announce
Next speaker, I request Mr. Dr. Shyam Singh to come on the stage and give his lecture.
Good afternoon, everyone. I express my gratitude towards Dr. Amol Dhavle and my friend Dr. Sandeep Beraris for inviting me here. I'm going to talk on shoulder arthroscopy portals and diagnostic round. In 1931, first cadaver shoulder arthroscopy was done by Burman. In 1974, first shoulder arthroscopy in Vaivo done by Johnson LL. The same person did first arthroscopic repair of shoulder instability in 1982. This is the diagram of portals. Patient positioning, my friend has taken elaborate on patient positioning, so I skip these slides. Lateral decubitus, I usually do it in a lateral decubitus position. I did in beach chair, a few cases in beach chair position, but I found it uncomfortable for me. The main problem in shoulder arthroscopy, first thing, portal, finding joint in the beginning, and the second is control of bleeding. There, three techniques can help you. One, arthroscopy pump at a pressure of around 40 to 60 mm of Hg. And second measure is adding 1:1000 epinephrine to each bag of 3 liter of irrigant. The final technique and perhaps the most effective is hypotensive anesthesia with a systolic BP of 90 to 100 mm of Hg. If you don't have shoulder pump, then elevation of fluid bag at about 3 feet above the level produces a similar pressure gradient of 66 mm of Hg. Portal placement. Before making arthroscopic portals, a thorough understanding of the local anatomy is necessary to prevent the damage to neurovascular structures. The surface marking. Acromion, marking the borders of, first you have to palpate the posterolateral border of acromion and mark full acromion with clavicle and AC joint. Then these are the portals, various portals. The posterior portal, it is the viewing portal, 1 to 2 centimeter distal and 1 to 2 centimeter medial to the posterolateral corner of the acromion. The position may have to vary according to the procedure to be done. Verify the position with the spine needle prior to the incision. Some surgeons inject normal saline to inflate the joint and easy joint entry. Obturator with sheath to be directed towards the tip of the coracoid process, but in shoulder instability, we may have to introduce more inferiorly. It is a primary wing portal, pierces the posterior deltoid muscle and travels in the interval between the infraspinatus and the teres minor. The axillary nerve and suprascapular nerve are at the risk with this portal, but are relatively safe. View through the posterior portal. First thing you are going to see is the rotator interval and this bicep tendon. If you move slightly superior, you will see the bicep pulley and bicep tendon exiting through it, just medial to its subscapularis muscle. These are the axillary races. This is the bare area of humeral head, which is an area of Hill-Sachs lesion. You can see the bare area just below the infraspinatus muscle. This is the Hill-Sachs lesion. This is the globe of normal humeral head, and which is a smooth and firm articular cartilage. The rotator interval. The rotator interval is formed by in superior border of subscapularis muscle and the supraspinatus muscle. But on outer side there is a bicep tendon. Means bicep tendon between the bicep tendon and the subscapularis muscle is rotator interval. In that you can see the superior glenohumeral ligament, middle glenohumeral ligament. This is the rotator interval. You can see the superior border of subscapularis, and on left upper side there is a bicep tendon. There are numerous villi in the rotator interval. Posterior inferior 7 o'clock position portal, 2 centimeter above the posterior axillary fold, used as an inflow portal. It can be used for taking inferior capsulolabral bite or to retrieve the sutures. Dangerous portal due to the proximity to the axillary nerve, posterior humeral circumflex artery, and suprascapular nerve. Anterior superior portal. Superior and lateral to the coracoid, just anterior to the joint, localized with a spinal needle in an outside in technique, just anterior to the bicep tendon, next to the superior glenoid. Primary and instrument portal, but can be used to visualize the anterior glenoid rim and a labrum, the posterior joint. Pierces the anterior deltoid and travels through the rotator interval, avoiding injury to the rotator cuff. Neurovascular structures at risk include the musculocutaneous nerve, axillary nerve, as well as the cephalic vein, brachial plexus, and axillary nerve artery. As AS portal, anterosuperior portal, entry with the needle. Actually, ideally, this needle should enter slightly inferiorly, just above the glenoid rim. I'm taking nick with the knife just to facilitate to introduce the cannula. This is AS portal cannula insertion. Pardon me for spelling mistake. This is a Wissinger rod. Over that, I am inserting the cannula. Yes, this is the cannula. Anterior inferior portal, inferior and lateral to the coracoid, localized with a spinal leader using outside in technique superior to the subscapularis, used primarily for instrumentation for anterior banquet repair, suture anchor placements. A portal entry with needle. The superior cannula is of anterosuperior portal. Needle is coming just above the subscapularis tendon. Now I am introducing Wisinger rod over that cannula. What's it? Yes. These are the AS portals, both view in a same frame. This is superior portal, navigator portal, corner of the supraspinatus fossa, enter just medial to the supraglenoid tubercle, penetrates the trapezius muscle and passes through the supraspinatus muscle belly, used for slap and rotator cuff repairs. The lateral portal, 2 to 4 centimeter distal to the acromion, either mid acromion, anterior to posterior, or at the junction of the anterior 1/3 and posterior 2/3. Used for subacromial decompression and rotator cuff repairs, can be extended for many open procedures, deltoid splitting rotator cuff repairs. Pierces middle glenoid muscle and axillary nerve at rest, because this averages at 5 to 6 centimeter from the lateral border of the acromion. This is subacromial space. My RF cautery is coming through a lateral portal. And this is the torn rotator cuff, releasing superiorly and as well as inferiorly. This is subacromial space, and this is a rotator cuff mobilized. Posterolateral portal, Willington portal, 1 centimeter anterior, 1 centimeter distal to the posterolateral corner of the acromion, used for the instrumentation during the slap repair. These, just to complete the list, these are the other portals. Common arthroscopic procedures, we know rotator cuff repair, slap repair, bicep tendon pathologies, repairs of labral tears, acromioplasty and distal clavicle resection, adhesive capsulitis. I will show directly a video of this, perform diagnostic arthroscopy step by step. This is the bicep, mobile bicep, the tendon, getting pulled through the anterior superior portal. This is the subscapularis. Just rotating the scope, we can see the glenoid surface as well as the anterior labrum. This is a rotator cuff attachment over the humeral head, supraspinatus. Lower down, it is infraspinatus and axillary races. Posterior labrum. You can see the posterior labrum and globe of humeral head. Now through the anterosuperior portal, you get the view of posterior labrum and posterior capsule. This is the anterior labrum. And this is glenoid neck and subscapularis muscle. This is a bony banquet. Thank you for listening, Sandy. Thank you.
Thank you, IAS and the Satara Orthopedic Association, Dr. Amol and Dr. Sandeep. I will be highlighting on the arthroscopic Bankart repair, how we do it and how to assess it. It's indicated in the recurrent dislocation of the shoulder with the glenoid bone loss, which is less than 20%, and on track Hill-Sachs lesion. Usually we are doing it in this. And how do we assess it clinically and radiologically? That's very important. That history is very important, whether it is acute or chronic, recurrent, whether how much number of episodes are there, direction of its anterior, inferior or posterior, onset, and whether it is having a voluntarily dislocation or hyperlaxity, and also the epileptic lesions. And history is very important. For that, we see whether participation or the contact sports are involved in that, duration of the dislocations, and the hyperlaxity, whether it is present. Similarly, the physical examination, apprehension test is very important. What we do regularly, 90-90 test, as well as the bony apprehension test. On this basis, we can decide whether we'll need the remplissage along with that, or whether we'll need a lethargy in that case, as if there is a more bone loss. And plane radiography also plays a very important role. AP radiographs in internal rotation as well as external rotation, and we do routinely in our patients the striker notch view to find out whether there is a Hill-Sachs lesion present or not, as well as the west point views to find out the glenoid bone loss is there or not. But in spite of all this plane radiography, the 3D CT scan and the modified Baranagius view, that is what we say the watching TV sign, that we routinely do in all our patients. Now 3D CT scan, this is the gold standard for all the Bankart repairs or the Bankart repair surgery. We do it according to a best fit circle method, and also we compare it on the other side. Humeral bone loss is also very important. We have developed a software along with our radiologist, and he gives us the readings whether Hill-Sachs lesion is present, whether it is on track or off track. We know pre-operatively, and that's a very good thing. What now, because of this etoids concept, we are able to find out whether remplissage is needed at pre-operative. Glenoid track concept is a very important thing. Whenever we go ahead and do a Bankart repair, whether we need to do a remplissage or not along with that, or something else is needed or not. As glenoid track concept, you all know glenoid pushes 16% of the glenoid width. That's why the glenoid track is 84% of the glenoid width. And that's why if you say glenoid track is 84% of the normal glenoid width minus glenoid bone defect, whatever is present anteriorly. And this measuring again the glenoid track on the 3D CT scan has made our life easy to find out the glenoid bone loss pre-operatively, and even we assess it arthroscopic way also. Now off-track Hill-Sachs lesion, in short, it is when a medial margin of the Hill-Sachs defect extends beyond the glenoid track. This Hill-Sachs engages the glenoid rim, that is off-track. If off-track is there, glenoid bone loss is less than 20%, then we have to add a remplissage along with the arthroscopic Bankart. And on-track Hill-Sachs lesion, if Hill-Sachs lesion is within the margins of the glenoid track, it's on track, only a arthroscopic soft tissue Bankart repair is enough in these cases. So this glenoid track, again, we plot it on the CT scan and we come to know pre-operatively how it is. Now arthroscopic Bankart repair, how we do it. Like initially, all equipments, as you all know, now we will be seeing in our live surgery also, we will be using our ideal suture passer 45 degree, 90 degrees, as well as sometimes if you need, we can use a scorpion, that is anti-grade suture passer. RF is also very important in this case. Yes. And clockwise and anti-clockwise rasps, what are there to prepare the glenoid is very important. Shaver blades and burrs are also very important. Patient positioning, usually we prefer to use lateral decubitus position for all our instability cases, except arthroalthargy, what we do it in B chair position. Portals, now as Dr. Sham has highlighted in details, I will not go into the details, but routinely we do a posterior portal, anterior superior portal, and anterior inferior portal. Sometimes we might need a 5 o'clock portal, but rarely. After a diagnostic round, Usually we do arthroscopic assessment of on track and off track, even for, and the glenoid bone loss. My fellow, he will be there on the back table and he will be calculating in the same thing. Like how we calculate the glenoid bone loss is, the first thing is that we put the scale from the posterior portal and we see it from the posterior border to the bare area and bare area to the anterior border. There we will get the rough estimate of your diameter, that is what we calculate. And after calculating the diameter and the bone defect, how much is there, we can find out arthroscopic assessment also. That means on the back table, my assistant will be ready with the pen and he will be just calculating 83% into the diameter, what I have given him, and the bone defect, how much I have given him. In this case, what you have seen just now, there was a 19.9 glenoid tract. And similarly, we compare it with the Hill-Sachs index. Preoperatively, we have got the Hill-Sachs index, how much is there, but again, arthroscopic assessment is very important when we are doing Bankards. If you'll see the defect here is a 12 Hill-Sachs defect, you can see it here, and even a bony bridge which is present medial to the rotator cuff, that is also 12 which counts out to be a Hill-Sachs index to be a 24 This arthroscopic assessment as well as pre-op assessment will help us to decide we are going to add a remplissage or not, whether it is on track, off track, we'll come to know. And this again, if you'll see in this case, 19.9 was a glenoid tract and Hill-Sachs index was 24 Sure shot, Hill-Sachs index was more than glenoid tract and it's off track. So you can go ahead and do a remplissage in this case along with that. And glenoid bone loss calculation is also can be done on the table, but anyways, we are getting it from the pre-op CT and the MRs. So my algorithm for that is for sure anterior shoulder instability with the bone loss. If glenoid bone loss is more than 20%, I will do arthroscopic Latarjet in all my cases. Yes, and if it is less than 20% and off-track lesion is there, we'll go ahead and do arthroscopic Bankart repair. Off-track is there, Bankart plus remplissage. So if you'll go ahead and see one case is how we do the arthroscopic Bankart after visualizing from the posterior portal. Now we are visualizing from the anterior superior portal, and from the anterior superior portal, you can see what we are trying to do is we are elevating our IGHL we are trying to locate, and we are trying to move, do a superior to inferior capsular shift in all our patients, and as well as after doing releasing all the labrum from the inferior aspect and anterior inferior aspect, we will put a suture anchor at 5:30 o'clock and we will take a bite at below that anchor at least 5 to 7 We are using here in this case, we are using in 45-degree passer. Sometimes you might need a scorpion or any other type of passer. If you are going beyond 6-degree release, then in that case, we can come from the posterior portal and take a bite from the 6 o'clock position. Again, after plicating the IGHL, which is very important, and making a inferior to superior shift, if another double loaded anchor, you can use it. At least 3 anchors, we are using it for the Bankart repairs. And sometimes you might need 4 also, but that depends if it is going beyond 6 o'clock. Again, here we are using a 45-degree passer and we are trying to give a bumper effect. And definitely what we are trying to do is putting our all knots away from the articular cartilage. And similarly, this noose maneuver is very important when we are doing that. Noose maneuver is we have to just shift the capsule from superior to inferior. We have to hold it with the help of the grasper and then tie a knot for that, which will give you a good bumper effect as well as a good shift for that. Now, when we are doing Bankards, as I said, when there is off track, sometimes we need to do a remplissage. In that case, remplissage case, we just need to do this remplissage procedure before arthroscopic Bankart. How I am doing it is we are going it from the posterior same portal and putting one on a triple loaded anchor for that, or a double loaded anchor depending on the Hill-Sachs lesion. And from once if you have placed a switch anchor from behind, you can do either ways. You can use your 90-degree passer, or you can use your arthropiers, you can use your sixters to take the bites. Somehow these bites should be from superior to inferior, and all at least I prefer to do a mattress suture, so that, and your bites, you have to take it as lateral as possible into the infraspinatus tendon, so that after your remplissage and arthroscopic Bankart, you should not have loss of external rotation in your cases. So that is a key point, and that your bites, it should be as lateral as possible. And after passing all your sutures, you can, after finishing your bank cards, then you go ahead and do your remplissage knot tying. What we do for success, preoperative assessment or the evaluation must rule out the glenoid bone loss, whether it is more than 20% or less than 20%. If it's more than 20%, you go ahead and do a Latarjet, whether it is open or arthroscopic Latarjet. If it's your off-track lesion, you need to add a remplissage along with that. And if it's a Hegel lesion, again, you have to fix it along with bank card repair. So the key point is inferior glenohumeral ligament is very important structure which needs to be plicated in all your bank cards lesions, and inferior capsular shift from south to north is a key to success as for the arthroscopy bank cards. Again, this is again, I do it in all my cases, curettage of the cartilage on the glenoid edge in arthroscopic bank card repair, so that the healing of your tissue, the soft tissue should be to the bone, and that will give you good results in all your, and suture anchors, at least 3 suture anchors for the arthroscopic bank cards. And for remplissage, always while doing in a lateral position, you can just external rotate your external rotation of the head will give you a good view that the cannula in front of the lesion, and always you should see it from the anterior superlateral portal. And always try to take your bites from the lateral aspect of the infraspinatus tendon to avoid any external rotation deficits. So sequence of your surgery when you are doing bank card repair along with remplissage is first diagnostic round, confirm anterior bank card Hill-Sachs defects, bank card repair, lesion mobilization is done, glenoid preparation is done, remplissage procedure is done except knot tying, and then after completing the bank card repair, you can knot tie. So arthroscopic bank card repair with capsular shift gives you a good results. If on-track Hill-Sachs with glenoid bone loss is less than 20%, remplissage plus bank cards gives good results. By adding augmentation such as remplissage, repair can be much stronger in your practice. And if its glenoid bone loss is more than 20%, always with on track or off track, poor capsule quality, arthroscopic Latarjet or open Latarjet, depending on the surgeon's choice, can be done for that. Thank you.
Congrats for a nice lecture. Now there is a slight change. Dr. Samir Sheikh has to move for the live surgery. So I request Dr. Shirsagar to felicitate him. And then we'll proceed with the next lecture by Dr. Deepak Joshi. So I invite Dr. Deepak Joshi sir for mini open rotator cuff repair. And we'll keep our questions reserved during lunchtime, we can ask, so as to match the time.
Mini open rotator cuff repair surgery. Rotator cuff repair is one of the most commonest surgical procedures done in shoulder joints. And traditionally, the repair has required an open incision with release of deltoid attachment and acromioplasty. Arthroscopically assisted mini open approach has gained popularity in the past, and this has been facilitated by the advances of the arthroscope. And all arthroscopic approach has recently been used for rotator cuff repairs. So why mini open technique in 2023 and whether it is relevant today? It was a gold standard in the past, but it has been quickly replaced by all arthroscopic procedure. However, the diagnosis is becoming more and more common due to the advent of the MRI facility available even in small towns. And when the patients get pain, they directly go to the MRI centers and they can get the MRI done, and they come to us with rotator cuff tear diagnosis. In small cities, it is very difficult to find arthroscopic surgeon experienced in rotator cuff surgery, and cost also is an issue. And we cannot send all the patients and refer the patients to the bigger cities. So that is why I think it is very important that an average orthopedic surgeon who is well versed with the open procedure should be able to do this mini open procedure with or without arthroscope. And that is why this technique is still relevant today. Mini open and arthroscopic technique results are comparable with no difference in result by the end of 1 year. Although arthroscopic results are little better in early postoperative period. That means even if you do mini open, there is no harm and you are giving justice to the patient. The purpose of this talk is to discuss the mini open rotator cuff repair technique and highlight the technical aspects of converting from mini open to all arthroscopic technique as you gain more and more experience. So the advantages of all arthroscopic are that perioperative morbidity is less. There is less or no surgical insult to the deltoid, better cosmesis and less pain. However, this technique is limited to the surgeons who are experienced in arthroscopy with large volume, and they can only do this procedure proficiently in given time. However, the disadvantage of this is that the procedure can be intimidating for low volume surgeons, and significant technical hurdle you can face if you are not proficient in doing arthroscopic repair. It has a high learning curve. The time initially taken will be more, and of course, cost again is a factor because instrumentation as well as implants will require a lot of cost. This procedure can be done without arthroscope by transosseous method also. So the advantage of mini open procedure is that it again has a less perioperative morbidity, less deltoid insult, better cosmetic appearance and less pain as compared to the open procedure. And low volume surgeons can also do this procedure well, even if they have a basic arthroscopic skill. And they can further progress to all arthroscopic technique as they gain more and more experience. By opening mini, you can see, assess the tear and repair it well. And you can even assess the repair, whether you have repaired it well or not. And tying the knots arthroscopically are difficult, and they are very easy because they are just in front of you and you can tie the knot securely. If you are not using anchors, transosseous repair is also good. The disadvantage of this procedure is again, the pain is a little bit more than arthroscopic. So there is, you may have to detach some part of the deltoid if required, cosmetic appearance, and there is a limited space, and that limited space, there is a well inside, and that well you have to work with. There is an issue of illumination. If there is an issue of illumination, you can use a headlight or you can use an arthroscopic optical cable, light cable also. So there are many studies and meta-analysis which have in every conference there is a debate between open versus arthroscopic repair. But most of them say that the long-term, more than 1 year result, patient-reported outcomes or cuff healing rates between open and arthroscopic repairs are almost same. However, arthroscopic only technique is associated with better short-term improvement in post-operative recovery of motion and decreased pain. So there are different meta-analysis done which even show the same result. So the indications for mini open, open or arthroscopic are same. Basically, the shoulder pain and weakness that limits the work, sports and other activity of daily living. Again, the decision what approach to be taken depends upon the surgeon's proficiency as well as patient's preference. And all the patients should have gone under conservative treatment before going for the surgery. However, younger patients with large rotator tear in traumatic injury should be focused primarily. For newcomers, it is very easy to get lost during scopy of subacromial space. So you can convert back to the mini open procedure anytime at any stage if you are endeavoring for the arthroscopic procedure. There are issues of fluid extravasation, fogging, just the way you saw today in the case. There could be excessive bleeding at the subacromial space and suture entanglements. If you face these problems, don't give inferior results by doing all arthroscopic procedure at that time. You can straight away go in and open the lateral portal and do the mini open procedure proficiently and give a good result to the patient. So there are 4 strategies dealing with the rotator cuff repair. First is open, which is not done nowadays. Then another is mini open arthroscopically assisted, that most of the times, most of the things, half of the things up to the subacromial decompression is done arthroscopically, and further things are done mini open. Then again, mini open assisted arthroscopic. That means most of the work you do arthroscopic up to the fixation of the implant or up to the fixation of anchors, and then you can open it and tie the knots with proper and secure fixation to the cuff. And then you go to the all arthroscopic procedures where everything is done arthroscopic. So as I said that our arthroscopically assisted open repair, mini open repair up to subacromial decompression, you can do arthroscopic. Then cuff release, tagging sutures, gripping sutures, and tendon fixation, all is done open. Mini open assisted arthroscopic repair, then in that case, you can even put the anchors and then open little bit and do the knot tying and fix the tendon. Arthroscopic assisted mini open repair, what you require is the basic arthroscopic set and Gulpi's retractors and some deep retractors. I prefer beach chair position. Then it is better to have these instruments like suture lasso and scorpion type of equipments to take a good bite in the rotator cuff tendon, and also suture retriever, grasper, and knot tying, knot pusher, etc. should be kept ready.
Very short time.
Yeah. So first of all, diagnostic arthroscopy is done, and you see the glenohumeral joint. And if there are any pathologies identified and can be dealt with, you do it accordingly. You pass one needle through the tear so that you can pass a thread through it, and through this thread, when you are doing the subacromial bursectomy, you will see this thread here, and you know that where the tendon is. Then go to the subacromial space and do the acromial bursectomy, and then with the burr you can do the acromioplasty. Then release the rotator cuff from superior and inferior margins. Give one or two stay sutures to the tendon edge so that you can retract and give traction to this tendon. And then do the opening at the lateral arthroscopic portal. You do the 3 to 4 mm 4 centimeter incision. Do the bursectomy. Open approach, do the subacromial bursectomy, deep retractors are placed, and you see the rotator cuff. You know the anatomy, whether it is small tear, crescent shape, L shape, or big U-shaped tear, and accordingly you suture it by open technique with small needles, and anchors are placed at the supralateral edge, and even as you are doing it open, you can suture it well. This is the tendon which is retracted with a suture, and then anchor is passed, and then sutures are tied. You can do this procedure even transosseous fixation also. Rehabilitation varies according to the numerous factors like surgical approach, size of the tear, tissue quality, and fixation methods. The primary goal of rehabilitation is to protect the repair, promote healing, gradually restore the passive motion and muscle strain, and finally restore the function properly. So post-operative rehabilitation. Concluding, the mini open or arthroscopic assisted repair of rotator cuff is still a viable option with clinical results which are proven well. It represents middle ground between traditional formal open repair and newer complete arthroscopic cuff repair. Mini open repair can also represent an excellent transitional technique to someday accomplish a more technically difficult complete arthroscopic repair. Thank you very much.
Thank you, Deepak. I request to collect your moment.
Deepak sir, memento. Next, call upon Dr. Sunit Hazra. He was there. He was not there. He was busy in surgery. Dr. Yeah, Dr. Rahul Patil will be visiting. Dr. Rushi Doshi.
Dr. Sham Shinde.
Abhishek, Dr. Abhishek Madan. Dr. Abhishek Madan, not there. There is a lunch break.
We have a lunch break now. 20 minutes. So surgery pass. We can have a place here. Surgery can start. We can have a discussion. Yes, yes. We are about to start. First,
Good afternoon. While we are having lunch, start the third case. The patient is already prepped. Uh, we'll have the brief history of the patient. Can I have the slides on? You can, everybody can sit and watch even the case. So this is the case 3. Dr. Samir Sheikh sir is going to operate the case. 18-year-old male having complaint of pain in right shoulder. He had a history of fall on outstretched hand 10 months ago. Had history of 3 dislocations and history of locking of arm while playing. The apprehension test is positive and the sulcus sign is positive. We have the AP X-ray. These are the clinical videos, full range of motion. You can see the apprehension test positive. Internal rotation, external rotation. These are the MRI images. You can see the Bunkart's lesion. The CT scan is suggestive of 14.4 millimeter glenoid index, and Hill-Sachs internal measures 19 millimeter, and it appears off track. There is 14% bony loss on glenoid, and type 3 acromion is seen. So we'll go over to OT.
How's the needle?
Dr. Rajiv sir is
Jara ye
going to
what-
moderate the session.
You काढून टाक.
You can have the
Light. Needle.
You can have your is already ready.
Rajiv,
Yes, he is in the moderator chair, sir. So what is the plan?
just a minute. Let them sit over here.
Dr. Samir, Dr. Rajiv here.
Yeah, Rajiv.
Yes.
Now, as I have seen the patient and
Yes.
just I have made a posterior portal, routine posterior portal.
All right.
That is hardly 1 centimeter below and 1 centimeter medial to the posterolateral border of the acromion. You can see me, na?
Yeah, we can see. You can put a picture in picture. I think outside picture is not coming. Cameraman, we can see the inside. Yes, now it's okay. Perfect.
Yeah. So we have marked our all marking, surface marking we have done. And after that, the posterolateral part of the acromion has been found out. After that, 1 centimeter, 1.5 centimeter below and medial, I have made my posterior portal.
All right.
And now I am just about to make my antero-inferior and antero-superior lateral portal. You can see these 2 needles I have placed.
Yes.
1 needle, I have just placed it above the middle glenohumeral ligament. You can see this above in this rotator interval, just above the subscap over here. And I have seen for the subscap, it's fine. This biceps is also fine. And we have seen the rotator cuff. This supraspinatus insertion is also good over here. And once if I come here at the anterior part of the labrum, you can see this labrum. You can't see the labrum anymore. It looks like a Alpsa lesion.
You have a glenoid bone loss also, I think.
Yeah, we are having a glenoid bone loss. From the preoperative planning, you can see the glenoid bone loss. What they claim is about 16% of the glenoid bone loss is there. And even once if I go into my antero-superior portal, I'll see for the Hill-Sachs defect, whether it is there or not. From this portal, these now 9 things what I have seen. I have seen the MGHL. I have seen the subscap. For subscap, what we see always for the hidden lesions, that is in the internal rotation, as well as giving the posterior push, what we say, we see for this. You can see this?
Yes, we can
Now,
see.
yeah, the hidden lesions of the subscap also we can find out from this is with this maneuver in the lateral position. And after that, we have seen for the labrum. And this labrum, if you see, there is no absent labrum over here.
And
All right.
if you'll see easily, I can go up to the axillary pouch.
Samir, what is your plan?
Now at present, there is no plan. At present, what I have confirmed is the glenoid bone loss. Just I know that it's about 16% and even off-track lesion was there according to the pre-op plan. So arthroscopic Bankards plus remplissage is the plan. But once if I make my portals and confirm after doing my arthroscopic assessment, we'll come to the conclusion whether I'm going to add the remplissage or not. That's fine.
Can you show the Hill-Sachs defect?
Yeah, I can show you the Hill-Sachs defect, but still, once if I come, you can see this. This is a flat Hill-Sachs
It's
defect.
a big Hill-Sachs.
It's a big Hill-Sachs. You can see it's not the deep one, but you can see there is no bony bridge much more left.
Yes.
You can see here.
Almost
So
it's coming
if
here.
it is there, it's up to the medial almost edge. If you see, it's a big Hill-Sachs.
Yeah, big Hill-Sachs.
So both things are positive. So probably I will be going ahead with my arthroscopic Bankard plus remplissage.
All right, good. We will see two procedure.
Yeah, now if you see here, what I'm trying to do is I'm trying to locate antero-inferior portal, but slightly higher I'll go so that I'll be able to reach up to the 5:30 or 6 o'clock position.
All right.
Here.
So for benefit of audience, what are your landmark for
Yeah.
superior anto-inferior portal?
For antero-inferior portal, I have palpated for the coracoid process, and after palpating for the coracoid process, just lateral to this, we have to go to the coracoid process, and after that, just above the subscap, you have to be there, and in between the middle glenohumeral ligament and superior glenohumeral ligament, you can see. Okay. So I have confirmed, and then I'll be going just above the subscap. I'm making my portal. I'm not removing my needle. This will guide my direction. This needle will guide my direction.
Yes, yes.
Samir, what cannula you use for inferior and superior portal? Diameter.
Ideally, I use always 7 mm cannulas, but today we are not having the 7 mm cannulas. That's why we have changed our plan to use it 8.5 mm cannula in the antero-inferior portal. Otherwise, I'm always comfortable with 7 mm cannula.
And there is always, do you find that there is crowding between superior and inferior portal? And
Yeah,
do you have any tips to avoid that?
Yes, I'll show you now. Because first thing is that this antero-inferior portal, once if I make my antero-inferior portal and cannula placement, after that, what you should do, you should try and go behind the biceps so that crowding will not be there.
All right.
That's right. Go. Wait, first dilator.
So antero-inferior cannula is a thicker one and antero-superior cannula thinner one because your working portal is most of the time is antero-inferior.
Working portal will be antero-superior. Now for 8.5 mm cannula, always you need to make a bigger incision.
Yes.
If you are making a 7 mm, again that is a bit less. So always 7 mm or 8.5, 8 mm cannula. Now you can see we are putting it, we are dilating the portal, and over the dilatation, we are just putting our cannulas. This cannula placement is very important if you see.
I think perfect portal and perfect cannula is important. It's a way for good arthroscopic repair, either rotator cuff or Bankard.
Yeah.
I think the trocar is coming out of the stroke sheet.
Yeah, we have removed that.
Yeah.
We have removed. Once that dilator comes inside, we remove our trocar.
Yes.
For that. Okay, now I'm comfortable with this. I'll just clean this part a bit, and then I will be putting my antero-superior portal. Now, just now, Deepak asked me how you will avoid the crowding. So now this portal is in the triangle. You can see this, Deepak?
Yeah, we can
Now
see.
this is in the triangle. Now what I'll try to do, I will pass my cannula just posterior to this. But now, as we are not having today cannula of the 6 mm, because this cannula is of what they have given me is of 6 mm, 5.5 mm. So I will not be putting an antero-superior cannula, I think. Okay. Is it okay, Raju?
Yes, yes.
Yes. What I'm trying to do is I'm just trying to make my antero-superior portal.
Yeah.
This, you can see it.
And this is important to keep
Yeah.
your blade away from your biceps.
Yeah, bus. That's the important thing. That's why I kept my cutting part away from
the biceps.
Away
Yes.
from the biceps.
Good.
Okay.
Samir,
Yeah,
I think you are always using as a viewer portal Enter Superior, right?
not always, but
Most of the
yes, most of the time you have to do that.
Yeah, and is there any specific reason why you don't use posterior portal as a viewing portal and what?
Yes, yes, yes. There is a reason. First,
Because for a beginner or a basic surgeon, it is very difficult to
because if I start
orient from the anterior superior.
I'll show you. See this. This part, if I'll show you here, the labrum, you can't see it now here clearly. Just from here, you can say there is a labral tear, but where is the labrum? You can't find out.
It's a capsule
So,
labral tissue. I
Yeah,
think.
तो मुझे सामने से देखना है लड़की को,
हाँ, सामने से.
right? Not from behind. Okay. Dilator, please. Dilator, please. I'll just dilate the portal now.
So you are keeping it superior to your biceps.
Yeah,
All
that's how we can avoid the crowding, and it's useful for the remplissage also. Hold it. When we are doing a
Yes, sir,
remplissage
you-
procedure,
You want to put your scope. I think it's easy to assess the posterolateral
Yeah,
defect.
right. So now I'll be today, as we are not having a 6 mm cannula, so I'll make a trick out of it that we'll be going only with the trocar and cannula over there. Afterwards, if I need, I'll put my Now I am switching to the antero-superior portal.
All right. Now you are making it as a viewing portal, and you will make
Yeah.
your release.
We'll look at a bird's eye view, what we
Yes,
say,
yes.
or a panoramic view.
Yes. You can have whole of the glenoid. You can see as a pear-shaped glenoid from that.
Yes, yes, yes.
The posterior labrum also, you have a very good view from this anto-superior.
Right, and you can look everything from there. Now this view, what we are getting, it's because our anesthetist over here, Mr. Parimal, he has given us a very good anesthesia over here.
Yes.
He has kept the BP almost up to 96. Now I am requesting him to continue the same thing. Okay, you can see my portal placement. If you
Yes.
see this portal placement has to be perfect to reach up to the hill sacs
Okay.
lesion. One minute, just a minute. Card a shield bind. Hold it.
So you will put your anchor over the hill sacs defect.
Suction,
You
please.
take,
Yeah, I'll
yeah,
be putting.
you will take your
just
bite and
remove
then
one
you will
fast
go
fix.
for lateral.
Fast fix anchor. Suction, please.
So what do you prefer, metallic anchor or a peak anchor or all switcher anchor for remplissage?
For remplissage, always titanium anchor.
Always a titanium.
Always
Okay.
titanium anchor. Sometimes it's a hard bone and it becomes difficult. Now
How do you decide one anchor or two anchor?
I'll show you. That also is there. And when I do this method, when I do a double pulley method, we'll discuss once if I reach to the remplissage.
All right.
Yeah, here. Just a minute. Just they are removing the instruments for us. Yeah, now the question what you asked me, how much anchors and how much to decide. I'll tell you if it's a deep one. If the remplissage, when we are doing, we have to decide on two things, whether you are doing a single anchor or double anchor, first thing. Second thing, whether you are doing a double pulley or you are just putting your mattress sutures. That is your choice. That depends how you have been trained for that. Right? So here, if you see, once if I start seeing at the hill sacs defect, you can see the picture.
Yeah, we can see.
Yeah, you can
quite
see
clear.
here, it's a flat or a shallow hill sacs. You can see it's not a deep one.
All
And
right.
if you'll see from superior to inferior, it's not so bad. From superior to inferior, but if you'll see from medial to lateral, it's big one.
Yes.
So what I'll try to do, I'll place one triple loaded or a double loaded anchor in the center today. That will be covering my most of the defects. You can see it here. Here you can see the articular cartilage. Here you can't see the articular cartilage. If this defect is a bigger than this, or you can say it is more than 15, 17 mm depth or 12 mm depth, then that is indicated that you can put two anchors
All
anytime.
right. They depend upon the depth of the hill sacs.
Exactly, right. Now, no, cut up. 8.5. Now here again, see, when we are doing a remplissage, here we need to put a bigger portal, bigger cannula for this. So bigger cannula, that means at least 7 mm cannula is needed to pass. 1 minute. आपल्याकडे हे आहे. Anchor कुठला आहे आता? Fast in RC घेतले का? ठीक आहे. Now we are using a fast in RC anchor here.
5 mm titanium anchor.
Yeah, fast in RC anchor we are using. Just a minute. Needle कुठे आहे? काढा बाहेर. प्रकार दिसेना मला आतमध्ये. I have to see where I am. जा. Now you can see we are putting my cannula over here. Cannula over here. Yeah.
This is 8 mm.
Yeah, we are having a 8.5 mm in fact, but 7 mm is enough for me just to pass the sutures also. If I want to use a sixter or if I want to use my arthropiers, at least 7 mm cannula is needed. But I am using here, you can see the 8.5 mm cannula. Okay, that's fine.
Yeah.
Ras, please. Now we will be preparing our defect. Okay.
Make it raw. No. Yes.
Yeah.
So you use rest for
हे
that.
पकडून ठेव जरा असं बाहेर पकड नसतो जरा shaver please. Very important thing is that we should create a biology.
Because it's a soft tissue bone,
Yeah, it's
bone healing.
a soft tissue to bone healing. So here very important thing is that we can spare some time for this and prepare the defect properly. पायात आहे का? कुठं आहे? पायात आहे का याचं? Foot switch. Foot switch please. एक पकड़ रे कैनुला पकड़. Yeah, that's fine. Now there are wood here. Okay, these few fibers which will come in my way of my ear, I'm removing this. This preparation part, I think it's very important.
You could have a bleeding bone.
Yeah. Now with this, just I'm trying to denude all the remnants here. Ras, please, for me.
In long hill sacks, the raw bone gets synovialized. You have a slim synovial layer there also.
Yeah, fine.
I think RASP is the best instrument which will make it raw. Yes.
Support, please. You are happy with the vision, what you are getting?
Excellent.
Okay.
Perfect view.
Okay. You can see this preparation part, I think I spend much more time in this because tying the knots is not a big deal. To create a biology as well as to rasp this capsule, you can see this?
Yes.
This capsular part rasp is very important. If you don't do this part and you are just putting your infraspinatus into the defect, it's of no use.
That's a good new thing.
Yeah, this synovium as well as bony preparation, as well as you see the thing is very important. And as I showed you in my slides, like external rotation of the shoulder has been done by my assistant now, so that you can view it properly. Okay.
It's come in front of your camera now.
Yeah.
Now hill sacks is being your camera. Your camera is not being hill sacks. Yes.
Pardon? What you said?
Now hill sacks is viewing your camera. After camera location. Saying hello, I am here.
Yeah. That's it. Fine.
Good.
Now,
Bleeding bone.
yeah. Now I am happy with this. Once can anchor please. Yeah, I am just putting my anchor in through the same cannula.
Your position of anchor, center of the defect, edge of the cartilage, or
No, near the cartilage.
near the cartilage.
Near the cartilage.
Over the
Here,
center of
if
defect.
you see this, I'll show you. This is my part which is raw. You can
Yes.
see this. This much is the part. If this depth is more than 15 to 17 mm or more, I will use one anchor here and one anchor here. But here, as this defect is 12 mm, here this is the end of the defect. You can see this?
Yes, we
This
can
is the end of the defect. So I will be placing my anchor here so that I should not come outside also. Okay? This will be a better place for me. Is this okay?
Yes, fantastic.
Yeah, just a minute. Now, cannula higher gap, please. Okay, okay. Enough, enough. Hammer, please. Bus.
Yes.
Yeah, you can see now. Bus, enough.
Yeah, first laser mark.
जरा ते बंद करा पाणीचं. आवाज बंद करून टाका तो. नको आहे ते काढून टाका. Yeah. Cannula has come out. Okay. Suction please. Pressure दाखवत नाही आहे. पाणी pressure. ऐसे थोड़ी ध्यान दो ना.
I changed the saline, I think. What is not coming?
Yeah, what
Yes,
is not.
perfect now. It's now it's clear.
What is not there?
अभी नहीं आ रहा है. नहीं.
Rajiv.
Water is not there. we
Yeah,
can't
yeah,
see it.
ठीक है. That is technical problem which is there.
So by that time,
You can ask anything. If you
so
want.
from where you would like to take the bite of the infraspinatus, medial to the infraspinatus tendon or lateral to the infraspinatus?
Lateral. Always in the lateral part so that you will not hamper your external rotation. And as lateral as possible, you can take it. 50 pressure लावून टाका.
You are using a pump also in this case?
We are using the pump, but pump is not working, it seems.
All right.
Pump otherwise निकाल दो, direct लगा दो.
I think if they can increase the height of this table.
Yeah, नहीं, that's
height
fine.
of the
That will
saline
do.
stand.
हाँ close कर दो ना. हाँ. And this remplissage when we are doing remplissage procedure, when we are adding to the bankards, important thing is that all passes we have to do it before.
Yes.
Otherwise, once if I do my bankards and come back posteriorly, it's just not possible to tie my knots also.
Because the head gets centralized, so now you have less space in between the infraspinatus.
Yeah, it becomes difficult over there for that.
And vice versa, tie the remplissage knot at the last. If you tie it first, again it's
That
difficult
becomes
to view
difficult.
from posteriorly.
डायरेक्ट लाओ एकदम जाओ. छोड़ दो आपका ये प्रेशर पंप नहीं होगा आपको. अभी हो गया क्या? Do one thing. छोड़ दो वो सब. डायरेक्ट लगा दो. वो निकालो आपका वहां से. पंप कैसा चलता है अपने को मालूम चाहिए ना. And Rajiv,
yes,
in such cases, if you see, this is now subcritical bone loss. It's not the full bone loss, what we see. This is subcritical bone loss in such patients, 19 years old, always remplissage will help.
Yeah, if you add remplissage, definitely the recurrence
Yeah,
rate is
in
less.
fact, now Sugaya, he says, sometimes you can add the rotator interval closure also, along with this.
And now the 2 or 3 papers are coming, I think, from Japan. as
Yeah,
well,
even
for
they
closure
say
of rotary interval.
rotary interval closure is also better what they say. But still we don't know. This at least now in all cases we have started doing the arthroscopic Bankart plus Remplissage in such patients, and they are giving good results.
Remplissage with closure of rotary, closing of rotary
हाँ, आ
interval,
गया
I think
शायद.
that will limit the external rotation. Yes, now it's. If
क्या
it's
चाहिए?
fogging is there, I think.
नहीं, fogging नहीं, water is not there.
Oh, water is not there.
अभी आप वापस ऐसा नहीं होना चाहिए, देखो बीच बीच में आ रहा है, ये ऐसे प्रॉब्लम्स हुआ तो कैसे चलेगा?
Samir, what is your reoperation rate following Bankarts only and Bankarts plus Remplissage?
Now see, I am of the thought, if bone loss is up to 20% or more than that, I never go ahead and do a arthroscopic Bankart plus Remplissage. I directly go and do arthrolathargy in such patients, because why to take chance in such patients?
Yes, but
Shiva.
in
And-
cases of you are doing arthroscopic Bankarts,
you can say when arthroscopic Bankarts we are doing, and now I am doing a pilot study for that. Out of that, we have done now a study in which we have done last 20 years, we are taking the follow-ups, and we came across that 10% of patients needed conversion to the lethargy after 6 years.
and what is the percentage of instability?
Instability, that's what I'm saying. In 6% to 10% of the patients, they are coming with repeated instability after 6 to 7 years. Initial 7 years, they won't have any problems. And then we found out that we are overzealously doing only arthroscopic Bankart repair in that patients and Remplissage when bone loss was up to mark 20% or there. So now our results has changed. When we are doing a Bankarts plus Remplissage, now we are feeling better with all these things. And now we have to wait and watch for this. Because initially we were scared of doing Remplissage because external rotation deficit always it occurs. Okay, now we are with the pump and we'll go ahead and start doing. And I'll show you now how we do our Remplissage here when we are not doing a double pulley. Here just I am putting my cannula. I'm removing the cannula from inside. You can see this. You are having both pictures?
Yes, yes.
Yes. So we are removing our now cannula outside first. We are taking all our sutures outside and parking it outside, and again reinserting the cannula. See, we have come, right?
Yes.
Enough. Wait. Now I'll be just coming in a wait, now. Subdeltoid area. I'm coming outside. You can see this. I'm just removing the cannula and coming behind the infraspinatus. You can see this. Hold it properly. Behind the infraspinatus, and the instrument here, what I'll be using now, there are 2 instruments what we can use, either a Sixter type instrument, Sixter type instrument, or arthropierce or a 90-degree passer. Here you can see this is a Sixter type instrument what I'm passing, which makes your life easier. See, this is the part where lateral aspect I'm coming. You can see this?
Yes,
Yes.
you can see.
Yes, see this part. I'm just palpating it. And I'm just looking for a tendinous part where I can have a good bite. You can see this. I'm not coming easily. I'm pressing it. Then see, okay.
Okay.
Now I'll be pulling the suture. Which one is nearer? Let's see. It's not opening. बाहेर उघडून त्याला जरा पहिला हे करून घ्या. बंद चालू करा पण. उघडा ना, उघड रे. पहिला तयारीच नाही आज सगळं. ओके. This instrument is not opening. That's why we are waiting for this. I'll be taking one suture out of this. Okay, yeah, hold it. No, so water again problem issue. Water का देख लो एक बार और एक बार. Hold it. Now you can see this thread, it's moving. Once if I come outside, we will be trying to remove it. उगड़ हे जरा उगड़ पहला. अंदर तैयार कर रहे हैं ना. You can see my thread is not moving now.
So what is your distance between, if it is moving, I think, if you pull it out, it will unload it.
Yeah,
from the
unload
anchor.
it. So it's not unloading it. My assistant, he is looking at the thread and then.
What is the distance between the two bites of same threads?
It's hardly 5 mm, 5 to 7 mm. Okay, just a minute. Okay, now we have taken first violet color and my bite. Pani अजून कमी पड़ते हैं. Okay, enough.
So once you know that both the threads are moving, you stop and go back and start again, right?
Yeah. Now you can see this. This is my first one, which is here. Okay. So now my second bite, what I'm trying to do, it is again near to this, but 5 to 7 mm away from that. There are two different ways. Even initially, I used to use the, you can see this?
Yes.
Now I'm pulling it. As you said, it's a 5 mm difference. What I kept it here at present. Hold it, hold the cannula please for me. Okay, fine. Again, the same thing.
Yes.
It's moving. But once if I out of the cannula, my assistant will look at the knot. Just look at this. He's pulling the thread. It's unloading. Okay, fine.
This is okay. Yes.
Fine. This is very important step.
Otherwise, you unload your switches.
Yeah, otherwise one more anchor I'll use. Today it's a live surgery. पैसे का problem नहीं है.
माइटेक ने बहुत सारा एंकर दिया है.
हाँ, आज कुछ problem
अमित हंस रहा है पीछे बैठ के.
आज unload भी हो गया तो no problem.
Yes, but Amit दिल खोल के लाया एंकर.
But tell the delegates how not to unload.
Yeah, I've shown you.
Because in private you can't afford this.
Now another bite what I'm taking more superiorly now.
So you prefer using 6-star only for this also, for taking bite?
Yeah,
15 degree. I use the 15 degree of bird beak.
Even sometimes I use this 90-degree passer also.
90-degree passer, oh, suture passer, all right.
90-degree suture passer we use. Now I'll show you where I am. Just let me know.
This is important that he is trying to take the bite to the tendinous part.
This if I don't go through the, hold it.
Yeah.
If I don't go through the tendinous part, it's of no use.
Yes.
For that. Then you are doing a capsulotenodesis.
Yes.
But that's also fine. Just hold it. See, this, because of this tendon, I'm not able to come.
Yes.
Okay. So this is very important.
He's a young guy also, so it's a thick.
Yeah, and I want a good bite.
Yeah.
I just don't want to
Good,
take
you
a
are-
bite and leave it.
You are in.
See, I mean, as well as
So
a good
now-
bite.
Now you are targeting the tiger one.
Yeah, I'm targeting the target.
Tiger.
In the tiger. Why 6-star? I'll tell you once if I take this bite properly. Because it comes in all the directions and it's easy to reach.
Yes, sir. You can rotate and I think it's like 360. You can rotate it.
Yeah, and orthopairs you can't. You
Yes,
have
yes,
to be
yes.
in one trajectory. Hold it, Kishore. Hold it. Yeah, fine. Again, the same thing.
Yeah.
What I've shown you.
Your movement at the anchor. So once it's out.
Once if I'm out of the cannula, my assistant he will look at the thread and then do it. Here, if you'll see the team, what I'm having is Michael, Kishore, Mohsin, Prathamesh, all are doing their good job here.
You are a very good team here.
Yeah. That makes your life easy.
Definitely.
Yeah, just hold it. Now my last bite.
Again, tiger.
Yeah, again tiger. If actually, even if I don't take this bite, that's fine. I can take a mattress suture. Fine. But still,
But that is coming through the
through the
cannula part,
portal, through the
your-
portal,
yeah, portal.
which
So
I
that
don't
is,
want.
yeah.
Yeah.
Better to take a bite, yes.
Yeah.
Now, any tip now, how you decide whether you are going to take the bite which we have already taken or not? You are holding the
Suture?
thread. Yeah.
That once if I hold it, I'll show you.
Yeah.
Yeah.
Yes.
You just pull the thread from outside. एक दूसरा दोरा उड़ून दो. This is fine.
Yes.
Yeah. We have checked it here.
Yes,
Okay.
already. Yeah.
Fine. Hold it.
So you ask your assistant to hold the other tiger one which has gone through the tissue.
Yeah.
Yes. So now it's
Fine.
parachute like, yes.
Yeah. Now, if you see, as I said, we have taken it in a right. I am worried whether unloading will happen क्या. एक बार बाहर आने दे फिर बात करूंगा. So that एक बार बोल दिया तो बोल दिया.
बोल दिया तो बोल दिया.
So now I can talk with you.
Good. So now you have done with your bite. Now you will go for glenoid and labrum preparation.
Yeah, I'll go with glenoid and labrum preparation. Again, I'm searching for the portal, which I have made initially for my bank cards now. जरा बघा रे. जरा traction दे थोडं आणि rotation कर बाहेर.
For glenoid and labrum
Enough.
preparation, again, your viewing portal will be the anterosuperior
पानी
portal or
किती pressure
posterior
है बघा
portal.
जरा. Pressure
Dr.
कितना है?
Samir?
अरे हर बार कैसे चलेगा भाई ऐसे? Again, their pump pressure problems are coming.
Not an issue. So by that time we
ए
can
ते
discuss-
डायरेक्ट लावून टाका ना. तुम्ही नका करू ते. अरे क्या हो जाएगा भाई? या ऐसे थोड़ी रहता है. You are disturbing a lot in between. So now this remplissage is over. Now what we'll do, we'll go ahead in the posterior portal and again.
So for glenoid and labrum preparation, your viewing portal is posterior portal or anterosuperior portal?
Now anterosuperior portal preparation portal will be there. क्या हुआ है भाई? करो ना फिर. क्या प्रॉब्लम क्या आप करो. And once if we make now this major part is over, to take the bites of the remplissage was very important. Once your pressure goes up, again that becomes difficult. Direct launch takre. Now we have shifted from the pump. Pump is not working. चालू कर. पानी नहीं है. Height वाढवा फक्त. Pump pressure please. See, without pump also it gives good vision actually. No need of pump also. Hey, please. Oh boss. Now
Direct.
stop it everything. Stop it. Leave it now. We are done. Thank you. Now if you see this, cannula आगे चला था, ये काट.
So now you have passed your switching rod through the posterior portal.
No. Now what I'm doing is I'm removing my cannula outside and I will reinsert it so that all my sutures are outside the cannula.
All right.
So that this is the very important step. Now reinserting the cannula. Usually I will put a 6 mm or 5 mm cannula. Bas, enough. That's all. Okay, now we are done with this. Now, as you said, Deepak, you asked
Yes.
me like why anterosuperior and why not posterior portal. You can see, visualize from this. You can see here,
You
the
can see,
labrum,
yes.
this has gone almost in the depth. And this is like a alpsa region. If you'll see, it's like alpsa region and almost gone behind. And your IGHL, which I'll show you. Just probe, please. Probe, please. Yeah. So if you'll see this, this is your IGHL component. You can see this. My bite should
anterior
incorporate this.
This is
Yeah.
5 o'clock, right?
This is 5 o'clock. Yeah, this is 5 o'clock. Right? And here, if you'll see, this has gone almost below. Okay. So now I'll start liberating all my capsule as well as the labrum, which has been hidden. And from this view, I am very happy with this view. Bird's eye view, what we say. Okay.
I think this is a very good view for labral preparation.
Yes. After labrum preparation, it depends again, you want to continue or not with this same portal. You can go in the posterior part and again you can do it. Camera. Its fog is there. So what we are doing?
If the labrum is not good,
Ah.
the tissue is not good. So would you consider the capsulolabral fixation or you do something else?
No, if capsule is of bad quality, it's a bad idea to do again a soft tissue repair. Again, it's better always to augment it with a coracoid graft over there. Otherwise, that is again a day one failure. In a few patients, you might do well, but after some period of time, again you will have the problems. Okay, so it's better. What, Raji, you think?
Yes, I think most of the time.
If the poor capsule quality is there.
Yeah, but now you are committed to this surgery, so you can't go for coracoid.
Not necessary. Before deciding arthroscopic Bankards or remplissage, you can convert your procedure directly to the other thing. There's no harm, no? We are prepared with both arthroscopic Latarjet as well as EA.
And that is the advantage with you. You do artho Latarjet also.
Yeah.
Yeah. So what is the extent of your release?
Now, extent of my release in this case, if you'll see, I'll go up to 6 o'clock almost. But let's see, because here there is no any capsule left.
Sometimes you have a very
Yeah.
Sometimes if you have a very poor labral tissue, what about incorporation of the lower part of the subscapularis?
Yes, you can do that. That's a good idea for that. Now there are so many papers which has come up with that. Just one suture anchor will be needed for that, and you can do that.
Yes.
We are ready with all these things, but not this case. When there is a real poor quality capsule, you can see here labrum is there.
Yeah, I think once you release it, it will float up.
Yeah.
And that floating
Now,
labrum is.
it will come, don't worry.
Yes.
Just a minute, slow. Go slow, that's the key. Because once if I'm started releasing now, this is the part which you will encounter bleeding, but nothing to worry. Today my anesthetist is very competent.
He has given a good hypotensive anesthesia.
Very good anesthesia is given.
I
Because
think
if
you have
see-
treated him last night, huh? in your party, huh?
How come you know?
I saw you. I saw
How
you
come
talking
you know
with-
that?
I saw you talking with him.
Hold it. How come you know that? Because
It's good to
always
have a critic
always you need to bribe your
anesthetist before live surgery, especially shoulder.
Especially in
When you
shoulder.
where you
Yeah.
can't use your tourniquet.
You can see it's a tough tissue here.
Yeah.
And I'll spend much time over here. By putting just one anchor, it's not a big deal. To tie the knot, it's again not a big deal. Here, almost I am up to
Yes.
536. Here, you can see this? Yes. I'm using again, you get two types of rasp over here or the elevators. Here I'm using the curved, which is
20-degree up.
yeah, it's curved one. So curved one, it will go properly up to the glenoid. Here, I just need to go up till here, 6 o'clock. Okay. Today, I don't think we need any 7 o'clock or yeah to do it. Let's see how it works. It started releasing now.
Yes.
Hold it. Hammer it, hammer it, hammer it, hammer it. Yeah. Here, it's a very tough tissue. And Oh, put the anchor. How you do, Rajiv, here?
Yes,
Like
same-
how much
same.
anchors you put?
So it depends upon
Okay.
the size of the glenoid also and
Okay.
the tear pattern. So 3 anchors are good enough for I think,
Yeah,
Indian
yeah,
shoulder.
right.
Yeah.
That is good enough for that.
And sometime Indian female 2 anchors are good
You
enough.
can see now it started mobilizing.
Yeah, and you can
Uh-huh.
see it's floating.
It's
This
floating
is very
now. It's
important to see
floating.
the floating labrum. Once
Now-
you can't at
Now
the
I
level
can
of
feel,
glenoid.
even I can feel it here now.
Yes,
You can see.
very good release.
Yeah.
Samir, I think
Just hold it.
excellent labrum preparation you have shown.
And here one key is there. After preparation, I'll tell you if it doesn't bleeds. Because here bleeding is bound. You can see some part of.
Because see, it's fibrosis. You are
Yeah.
releasing that fibrosis. Some
Hold
amount
it.
of bleeding
Push,
will be
push,
there.
push. Will be there.
And it's a long-standing fibrosis most of the time.
Griffon, please. 2 Griffons, please.
So you are planning for peak anchor.
Peak anchors. Ideally speaking, I'll tell you my preference how I do. Today we are putting 2 Griffons here.
Single loaded,
2
double
Griffons,
loaded,
double loaded,
double loaded.
double loaded. And ideally what I do is first anchor, curved anchor at the almost 530.
All
And I
right.
take my bite from posterior portal if it's more. If it's a bad one, it's not ALPSA, but it's almost capsule has been elevated up to 7 o'clock. Then you can put your curved anchor here, this one, and can take the bite from posterior portal. But today it's not needed, it seems here. You can see it here?
Yes,
It's
we can
good. In
see.
front of here, it is there. I can put my 530 anchor here and I can placate this thing to here.
Yeah, so you
on
will
the
have a good south to
Yeah,
north shape.
south to north shift. Hold it, pull. Hammer. Okay. Now. Put it. But you have to be prepared with all these things. Like you have to be prepared. Why I have placed my 7 mm cannula posteriorly is because if I need to take a bite from posterior part,
Yes.
you can take it easily. From the posterior part, you can take the bite at a 6 o'clock, you having a labrum into it. Hold it, push it. Because key to success is this the part. Abhi मैं 2 minutes में I can put anchor and get away, but it's of no use.
Increase
need-
incidence of recurrence.
Yeah, see now, you can see here,
Yeah, you
subscap, you
see.
can see it now. You can see here subscap?
Yes.
Yes. Now, that means it's the end of the release. But
Release.
still what I'll do, I'll prepare it such a way that release will be much more and shift will be good one. So I might use the RF here now to just release it here at 6 o'clock.
So here you have a very thick band. Normally what happens, and it's angled also.
It's चालू नहीं है बघा. Yeah. Here you see I am touching the bone.
Yeah.
And then I'm releasing it.
So gradually you are going towards 6 o'clock position.
6 o'clock position.
Good
I have
technique.
almost I have gone, but we are just releasing it. So that some fibers also will not hinder my south to north shift. This always I remove 3 mm to 2 mm of the rim of the edge.
So why not you? Why do not you release it with a tissue liberator? Why you are using RF at this point?
It's a safe one, what I feel for me. You can do it with a tissue liberator. If you can see, if you can see, Sugaya, if you see what he's doing, he's using a scissor over here to release it.
It's to a Caesar, I think you are very close to your neurovascular bundle, 1.5 centimeters.
No. It's
1.5
far away. It's far away.
1.5.
That's why first I told you I am just touching the bone and releasing it. That's very important. But release is very important. You know.
This is a good technique. Yes.
So if you see, I am almost up to the 6 o'clock.
Mhm.
You can see it, but still I'll release it so that I get a good bumper effect.
Yes, we want to see good bump today, prepared by Dr. Samir.
Like Malika Shirawat.
You are Bawulkar sir fan, I think. He used to use this term. The good thing is that you can see whole of the floating labrum. This release is very important. Preparation of the labral part.
Yeah. It's
And now after that, he will prepare.
I am
the
not
get
at
out.
all in a hurry to put anchor, you see.
Yeah, this is very
Because-
important. This is very important.
Because if you don't do this, patient will come after immediately after 6 months and telling that there is no healing.
Maybe he will come to another surgeon after 6 months. The recurrence usually
Yeah, that's
they
what.
don't report to same surgeon.
You are right. You are right. Absolutely right.
So either
So,
he will come to Satara or
sometimes even I go beyond 6 also. If I go beyond 6, that's a rule, like I put a 6 o'clock anchor and do. Now I am taking my rasp and preparing it.
now prepare a preparation of your
Glenoid.
Okay.
Hold it, hold it. Just a minute, just a minute.
Now some papers are coming on use of curate in the anterior part to create a crater. What is your say about that?
Yeah, I'm doing that.
You will do today.
Yeah, I'll do.
Fantastic.
I'm doing that. Hold it. Even I'll now we are publishing in journal like this age removal. Hold it. Push it. Now age removal. If you see cartilage from the age, will
All
give you a successful Vancards because you get the bone
They are
healing.
telling that recurrence rate has decreased further. If
Yeah,
you
yeah,
use
yeah.
the
You
curate.
are- you are right.
Make a
You are-
crater up, put
Dusrat,
the
yes, sir.
labrum over that. You will use a ring curate for that.
Yeah. A ring curate or what I do, I'll show you. Like I do mark with RF and then I'll use my shaver and curate
Oh, all
because
right.
that becomes easier for me.
And it will give you a uniform.
Yeah, uniform. Just I know how much shaver is there. This RF is there, and then I can just do it. I'll show you within a minute. Once if I prepare my glenoid, I'll show you. Okay, I'm using a rasp here. Huh? You
Yes.
can see this. At 6 o'clock, I'm using a rasp. Push, 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 push.
So this is
Okay.
important. I think when to use the 20-degree up and 20-degree down. There.
Yeah.
So when you are moving when you are changing the angle,
Hold it, push it, push it, push it. And if I go beyond 6 o'clock, that is up to 7 o'clock sometimes. In a bad bankards, if you see that time, again one thing is that you always need to put your 6 o'clock anchor so that you placate your 7 o'clock also, or you can put it from the posterolateral portal, other one. Now you see it started floating.
yeah, it's at the level of glenoid now. You see, your labrum is at the level of glenoid.
At the level of
Beautiful, beautiful labral release.
Now this part I just want to remove, right? This. So it's very difficult. If you see, you try it out with ring curate, again it slips off all the time when we are doing. So it's always better just keep the RF and just push it and mark it, because this RF, if you'll see, it's of 3 to 4 mm.
Yes.
So now my marking started from here. I'm just removing the cartilage from the edge. You can see it here.
Another good
And-
technique. So you denude the cartilage, then put a shaver over that. Put your
Yeah, after that we'll put a shaver because that
you will have a bleeding bone.
preparation bleeding bone over there.
Good.
But here your uniformly you get a 4 mm or 2 mm or 3 mm ridge, what you want.
Good.
And second important thing why I remove this, my anchor placement becomes easier. Because you can just place it over there.
It will be over the face of the glenoid.
Yeah. This thing what I'll tell you, when I visited Ivan Wong used to do this.
So lots of people are following this.
Yeah. Ivan Wong.
Trainers of
Now
glenoid
Ivan Wong
making a crater.
routinely he does that. Now this is my position of the anchor 530.
And this is
You can
very
see this?
important message also, because this is most important part, preparation of the glenoid and preparation of the labrum. Anchor,
Yes,
it
yes.
will take hardly 15 minutes, 3 anchor and 3 knot. All right. You have almost denoted 5 millimeter of the anterior cartilage.
3 to 4 mm you can see.
Yes.
Because my RF is of 3.5.
3.5, 4 millimeter. Good.
So this ridge will give me two things: bony healing as well as placement of the anchor, as well as bumper effect.
So now you have increased the indication of use of RF in bankout also.
No, when we are not having
So
RF.
earlier it was for curve only. Now we will use it for bankout also. Again, Amit is happy.
Amit has to be happy.
Yeah. He's telling, sir, now
Just hold it.
we will ask for one RF also for each bankout repair.
It's not a message.
So
You can use a ring curate, no
Yeah,
problem.
yes. No,
Hold it.
this is good. Ring curate, you don't have control, na? So sometimes it deflects and you go inside also. I think the trocar sheath is there is some, it gets loose, na? Sometimes.
Yeah. That is the
In the morning also. Yeah.
Now you can see I'm preparing it with shaver now, because I believe the preparation part is very important.
This is the
If you
most
just-
important part.
If you just go and put an anchor, that's not a big deal. Deepak,
Yes, anytime you use burr here,
are you there?
He is
I'm
mesmerized by
asking
your
you,
surgery.
it's just like watching Netflix, you know.
Thank you, thank you. Just hold it.
Are you using burr sometimes here?
No,
to
no, no,
denude
no,
this
no, no.
bone?
Burr sometimes kills the bone.
Ever you use in oscillating?
Pardon? Now see,
Ever you use in oscillating mode or continuous mode for cutting of the bone?
you can use a oscillating mode
Oscillating
here,
mode.
but keep your shaver off, suction off.
Suction off.
Okay, this is my placement of the anchor. You can see this marking. This IGHL will come here. You can see this IGHL. What I'm holding it here. This
can.
and this part. This
Yeah.
and this part. I just want it here. Okay. Are you happy with this release?
More than.
Excellent, excellent demonstration. I think this is the most important part of the surgery.
See, now this part also I'll release. You can see this.
Yes. In front of subscapularis.
Yeah. Hold it. Release, it has to be almost up to 1 o'clock or 12 o'clock, so that you can do a shift. Otherwise, you won't get your shift. Push it. Now see, it's floating everything.
Yes.
Now it just want to come and sit on the edge. आप anchor डाल रहे हो तो ठीक है, otherwise I am coming. See, it's this release part. If you'll see, I have released it almost up to 2 o'clock now, right? Here now, after this, labrum is not that good quality. All right. Okay, now we'll start with our anchor placement. Fine. Just hold it. Traction दे बाळा आता. एक anchor ला महत्वाचा आहे. Sure. Which traction system you are using?
So
बरोबर आहे. Hold it. You can see.
So while putting the anchor, you will use the superior portal only. As a
I'll be
viewing
using,
portal.
yeah,
So
superior.
it's I think
Superior.
throughout your bankcard repair, it's
त्यात
your
घाला
viewing
काही.
portal.
याचा stick घाला. टोकार घाला. You see, this is the part here. Always I like curved anchor as well as all suture anchor sometimes, because this is of 2.8 and we are using of 1.5 now. Okay.
So you are using a Griffon double loaded anchor.
You can see this is a 6 o'clock mark my,
Yes.
and I'm coming almost at the 5 o'clock or 5:30. You can see this?
Yeah, we can.
Okay, hammer it. Okay. hammer. Just 1 minute. See, my assistant now, he is on the edge of the glenoid. One assistant is giving just hold, go. Right. Just place it. Okay. This is very important. Directly, you should not hit it. First push it, and this is the pushing griffon, what we say.
Yeah.
Mar. That's enough.
Yes, yeah.
See this
Leather
mark has
mark.
gone down. Yeah. Okay, Raju, you are happy with this anchor placement now?
Yes.
Fine. Okay. Now, if I pull on this, you can see this?
Yes, you can
I am
see
on the
stability
edge.
of the anchor.
I am on the edge.
Yes.
You can see this?
The
This
whole glenoid is moving.
Yes, I'm on the edge, and I just need to put now my steel.
You can see also your anchor is
Sir.
just underneath the bone.
Blue color, sir. ब्ल्यू कलर नवीन काढून घे, जुने घेऊ नकोस. काढलास कशाला ते? दोन्ही नवीन घे. तेच करतो. Now I'll be pulling one thread out of this. Out on it. Out. Stick, please. Hold it. Hold it properly. Grabber, please. Yes. Now I'm just pulling one thread out of this. Okay.
Any advantage of using a double loaded anchor?
I'll show you why double loaded. You can take 2 bites in the anterior inferior part.
But again, it's a point contact over all the bite. It will have a contact over that point over the anchor only.
Yeah. दुसरा पण घे, येलो कलरचा पण घे. I'll show you now both way. अरे घाल ना यात पण. I am showing you both ways, now. This bite is very important. That's why I'm showing you both ways how we do it. You can see I have come inside with my cannula from cannula is there posteriorly. I have come up with this bite. You can see this?
Yes.
This. I have come up from posterior portal. You can take a bite from here. You can see this 6 o'clock bite, what I'm saying. You asked me why you are taking this. So this is the bite which I can take it from this part. You can see this? This is the part which is only of labrum.
Yeah.
You can see this. This is the part of the push kara. Push. What you are doing? Leave me. New one, where it is?
I think some soft tissue is there.
Are you using
wire
wire or PDS suture?
No, we are having it here, but there is no. See, some soft tissue is coming in between.
Yeah, actually, that is.
You can see this.
You can just push it with some holding the artery and mosquito. Yeah.
Let's see whether
What
it comes or
happens?
not. Let's see. Otherwise, I'll take one more bite.
Yeah.
दूसरा पासर
It's
द्या.
not coming. It's not coming.
It's not coming. Leave it. काढूया परत घे तुम्ही.
Just before the mouth, you can push it with a mosquito. You can push it sometime.
दुसरं द्या ना.
This is
I am
45 degree
taking.
lasso.
I am taking once again other bite.
Yes.
Fine.
Yes, it's okay. Yeah.
थोड़ा खड़ा. Because
The
bone, bone is there.
I think some block is there. Maybe bone.
Blue, yellow one. Yellow one. काढ त्यातलं. This is the bite which I showed you.
Yes.
Actually, it was not needed. If you can take a bite from that part also is fine. Yellow. You can see again I have come inside. You can see this from posterior portal. Okay.
Yes.
And this is the 6 o'clock bite, which is very important. I have taken initially, but again I'll take it now for you. Let's see now if I get the bite, proper bite, what I have got it before. Capsule as well as labrum. Fine.
Yes.
First I pierce the capsule.
Now it's out. Yeah.
Yeah, okay.
Okay. First I have pierced the capsule in first bite, and second you have taken this. Fine. Okay. Now, पानी पकड़ा. हे आता इकडे घ्या. ढकला अजून जरा. This is just for demonstration purpose. I have taken it from the posterior portal. Otherwise, today it was possible from other portal also, anterior inferior also. Okay. Nice.
Sometime if your tear extending beyond 6 o'clock, I think you should know this
1
technique
minute.
also. This is very important.
Go. Here, go. Go. Okay. Now. So, this plan. Placing it. Okay. Pull it. Slow. Slow. Okay. Now we have pulled the thread from this side. You can see it here.
Entangled, I think, with tiger. Just
Let's
entangled with tiger.
let it be. No problem. Come out. Okay. Okay. Now give me the grasper. This afterwards we have decided. Otherwise, I would not have pulled it that way.
All right. Now you can take the tiger
this
out.
posterior.
It will be.
Yeah.
Okay. Future manipulator, just take the tiger out.
Okay.
Yeah,
I'm
perfect.
If I unload it, I don't know. Let's see.
It's double loaded. You don't have to worry that. That is the advantage of double loaded again.
बघ Michael, बघून ओढ. हाला लागलाय. बरोबर, right?
Yes.
See now? I am okay with this.
Perfect.
Fine. Now this is my first bite. Now I will not
Tie it.
tie it. I will not tie it. Okay. If you are taking a 6 o'clock bite, don't tie it.
Yes.
If you are taking above that, you can tie it. Okay.
So now you will tie your now
I will
Second knot
tie my
and-
second pass first, and then I'll do it.
Yes.
Blue color. Okay, fine. Now we will be taking your IGHL bite.
Yes.
First thing was the labrum, what you have taken. Now you are taking the IGHL bite. Okay. Rajiv,
This is through anterior-inferior portal.
same.
Posterior only.
No.
Anterior-inferior.
Anterior-inferior.
Yes.
First you took from the posterior, right? And this is now from the anterior.
Anterior-inferior.
Pivot.
Sometimes the MGHL
No.
bands comes in front of that thing.
No, just cannula is out.
Yeah.
Today my assistants are sleeping, I think. They just don't want to finish the case. So, short. Fine, now you are okay with this? बंद
Yes.
करा ते पाणी. पाणी लावा रे. Okay.
Yes.
Now, give me. Pull the threads. Now, दोरा ओढा जरा. इकडचा ओढा. ओढ. Okay. See, now again I am visualizing from the anterior superior portal itself. Okay, and I am trying to take the bite. Now, असं उलटं कर.
This bike is at 530.
Yeah, bite now it has to be below this, but I want to augment my IGHL. That is my first aim. You can see this?
Yes.
This bite is just below this. This is very important step. If I'm not taking this bite below IGHL, it will not like it. It's a tough tissue here.
Young guy, 19 years.
Yeah, it's a very tough tissue to pass. हात काढा.
Sometimes it's old ALPSA also, though you have a thing.
Then I might shift to my scorpion also.
Yes, scorpion. No,
But-
it's there.
but
You
it's
have
there.
done it.
I think so, but let's see.
Here we can see the tip.
Oh, दाखला रे. Yes. Wait 1 minute, hold it. Now you can pull it from this portal. This bite is very important, believe me.
You are taking it to the posterior portal where you have already a
पकड़ा cannula. Push करा.
I think it's
सोड रे सर. काय घालतो? No. Sorry. सरक मधून. जरा हे दे. Pull it, pull it, pull it, pull it. Traction. अजून काढा. ठीक आहे. Now, again, I am going to try it out with this. And otherwise, I might go and shift to the scorpion
scorpion.
or any other thing. But I am sure I'll get it. But I want this perfect bite itself.
Yeah, I think it's a good lateral bite. Yes.
Very good.
Very
I
good.
was not expecting.
Yeah.
There is
I think
lot of people
it's
are
getting stuck. You can use grasper also. Yeah, you can get.
Come. दुसरं
Push, 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 push.
पकड जरा हे. Bite is coming, but it's not
Yeah, I
coming.
think it's stuck. You can try to pull it with your grasper also. You can pull
Yeah,
with
we
your
are trying to come up.
future manual better if you don't get this loop.
Once if you finish this part,
That
then-
is that easy. Rest of the part you can complete with the antero superior portal.
yeah,
I'm trying to grasp it. दोरे उडा ना भरलाय काय बघत. Just push it, push it, push it. Push it. दूसरा ग्रास्पर दे. ये पकडून उडा जरा. बस. Okay. Now I'm through. Okay.
And now you can use your manipulator, switch manipulator.
Once if I get this bite, this is very important bite.
Yes.
We should not be in hurry to take another bite or ye, because this plays very important role. काय जर हे बाजूला घ्यायला पाहिजे. ठेवायला पाहिजे. ते अडकणार आहे परत त्यात कुठे तर. ते अडकणार आहे. ठीक आहे. Key. Now, now my assistant is pulling it here. You can see it. Okay, okay, okay. Come out, come out, come out, come out, come out, come out. Okay, you can see this now. Here. I am not happy with this bite. See, I am not happy with this bite. You can see this. This is not the bite up to mark. Which is,
you can take it out again.
Yeah. नाही बरोबर नाही आहे. सो जरा उडून पकड आणि इकडे घे. उलट कर. जरा हात घालायला स्टिक दे. So this thing, for this bite, you have to be ready with all other options also. Fine. Okay. Put it inside. Bas. 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 Enough. Cut. Cut. Okay. Sure. Did. काढायला दे. So I'm taking out this bite, and once again I'll be. तो दर उडून घे. Oh hi. पकड. ठीक. Okay, I'm pulling it here. Now I'll be taking one more time bite. नवीन आहे हा. बेंड झाला. दुसरा आहे का? दुसरा आहे का बाबा?
Are you using lasso or scorpion?
I am using lasso. Ideal suture grasper. Chia.
Just check outside only whether Chia is working, coming out of the tunnel.
Chia is coming outside of the tunnel, but sometimes this bone block will act for like this. Okay, Dori Uda.
So now you have changed to ideal suture.
Yeah, this if you'll see, this has to be proper, but you need to take proper bite. There is no other option. You can see this ideal grasper what I'm having now is not working it. Okay, now I'm through. You are happy with this bite now?
Yeah, I think it's okay.
Let's see. Once you
pass your suture.
Okay. Very tamba. Because this, if you'll see now, fine. Vision is good, right?
Yes.
Fine. Now I'm through. Let's see how it works. And then I'll be tying now this knot and then coming back. So take my gatlas. Okay, they wouldn't pakad. So now.
So, now I'll first tie this knot and then we will again use a capsule along with that because
I think capsular
looking-
lateral bite, next
Yeah.
one you can take.
we will take another bite from that.
So I think mattress suture. You
Let's see,
explained.
let's see. You might take mattress suture for
Yes.
that, right? Now this is the IGHL which has come up here. If I tie how it looks, I'll see and then I'll go ahead. हे कुठले दोन्ही आहेत? दोरा ओढतो, ओढ, ओढ, ओढ. Tissue bite is there. अडकले, अडकले. Now you see again here, if you see there is a bite inside.
Yes. I think
This
they soft tissue entrapment.
These things happens only in live surgeries.
Yeah, yeah. And I think people should know how to come out with that. For that, we have Samir here.
Oh.
These are all things are part and parcel of shoulder arthroscopy surgery.
No, hold it, hold it, hold it, hold it. जरा grasper दे. Grasper. No. You can see this is not at all inside. You can see this?
Yes.
नकला cannula. बस थांबा थांबा थांबा. Just give me pottery. Pottery, please. This tag of tissue is in between.
Yeah.
I'll be removing this tag of the tissue, and once if I remove, I can talk with you more. Why this happened? दोरा उडत आहे. Now this advantages of double loaded, you can see it here. Like even though if I cut this, there is the way where I can go ahead and put another suture anchor. Fine, I am through. Okay, now I will be tying that and then we will be focusing on other things.
First tiger, then purple.
Yeah, first tiger will be putting. Sarakre madna. Yeah, we'll be putting the what you are doing. Just hold it. You can see this. I am just putting this back. See, this is the
Yes.
band which I am having. Okay.
IGHL.
Fairly good labrum. What I have taken a bite. Otherwise, again I would have removed it and placed it again once again, because this one bite will decide your fate. You will get this bumper. You can see this. Let's see. So today what we have seen, and this thread, when it comes in between the soft tissue, this is just because there are, please band karate. I am putting a Duncan's loop over here. What you prefer, Raju?
Yes.
Duncan's?
No, I put a fisherman knot, huh?
Okay.
Big
Fine.
knot. So now I've shifted to pro knot for IA. So we have Griffon pro knot you have used?
Yeah, yeah, I'm
Yeah,
using
that's
it.
it. So it's a very small knot and thin knot there. So
Is there, but still.
for slap and bankard, I have shifted to pro knot now.
Sometimes, Samir, you get entanglement here and you cannot do the sliding knot. What would you do in that situation?
Simple knots.
Simple knot.
Simple knot, I think.
So-
sort of it happens. So this is important. Try to push your knot toward the capsular side.
Yeah.
Yeah. Power cut. यहाँ का power cut. I think the power cut is from this here. See this, we are live. No, this is from this camera. पीछे वाला camera. Oh, hospital.
Which knot you said you are using?
Yeah. We can see you.
No, which knot you are using, you said?
Oh,
Arre, pani,
for
pani.
for pro knot, I think it's almost knot is almost there. Otherwise, it's a sliding fisherman knot I use. But all those knots have a very big knot. You see 4 or 5, you put 3 knots there. It's a very
Okay.
big knot. Big knot.
Acha.
So if you use a pro knot, I think pro knot
Here, sir.
gives you a
Knot
very
pusher.
smaller knot towards the capsular side.
Acha.
Yeah. But good one. I think you have a good bump there at 6 o'clock position.
No, now yet after one anchor, again I will be taking a capsule bite
Yeah.
in the another one.
And that will give you a good bump over the anterior part and inferior
Let's
part.
see, let's see, let's see. Now we don't know yet. Arre pakada. Sodte, hey, sod. आता हे घाल. त्यात घाल. Now see, now I want that another part knot also.
Yes.
So that my assistant, he is placing a knot pusher through this and he is going through that.
So now you are tying your purple.
Yeah, we will be tying our purple. Knot pusher, please. Okay, let's see. And still this part I have to bring it up. And now see, this is the technique what we can use it. We can use the knot pusher over here and we are pulling it because I was not able to go there. Please. बरोबर है? नहीं.
So now you are parking both
बरोबर
the
है?
suture in antro inferior portal.
Yeah, from the posterior portal I am pulling it.
Antro inferior.
Coming. ठीक है. Clamp lava. Now this will be my post, which I have pulled it now, and
That
then
is
I will
through
be
the
putting
tissue,
it now.
yes.
Yeah, this is everything. I am doing it at 5:30 now. Now you can see, once if I put this knot, now my distraction has been decreased. I'm not able to go down now.
It's because of tightening of. I think this this suture is important to tighten the IGHL.
Yeah.
You will get a bump with another anchors also.
Yes, yes, yes.
When
That-
you
that's
when you
right,
take a
that's right.
capsular labral tissue. Yes.
Exactly.
Yeah.
You are right.
Good.
So
See, you
this-
can the axillary space. It was opened up. Now it's closed.
And when you remove a curettage on the glenoid face or the edge, that time, that bumper effect has to be above that, na?
Yes, yes.
So I am tying my again second Duncan's loop. Deepak, I think when we did a live arthrolethargy, you were there moderating.
Yeah.
Ah. See, now this knot, if you'll see, this will be pulling my 6 o'clock bite. And then I'll be plicating other things after this. You can see this. I have just pushed the shift from the 6 o'clock.
Yes. And
to
you have tightened the
5:30.
axillary pouch. I think
Yeah,
now
at-
you don't have
at
space
present.
in axillary.
Yeah, now
that is
after this,
important.
we'll be doing that. Now one more anchor ready, please. One more anchor.
All the anchor you use are double loaded anchor or second next anchor you will use single load.
Now double loaded we are using.
All the
All
anchors.
the anchors.
Yes, ma'am. Initially, ideally, first will be a single loaded and then double loaded. If I'm using double loaded 4 stitches, that will be enough. If I'm using single loaded 3 anchors, at least 3 stitches will be there. The stitches, how much you are taking, that is more important. After when Duncan's loop I am taking here, over there, at least 4 to 5 knots I am taking here.
So it's like you have to put 2 or 3 half hitches over that. It is
Yeah.
adding non-locking knot.
Almost, I have placed 4 to 5 half hitches above there.
This was the reason I have shifted to pro knot, because anyhow you can't decrease the size of the knot.
Okay.
Yeah. The pro knot gives you a very good knot, small knot over the capsular side.
Acha, pro knot cost is there. That's the main reason. Otherwise, everybody will prefer that. So for Amit, we should ask to reduce that price.
He is telling from after today workshop, he will reduce in Mumbai. In Calcutta, he is giving me at a very cheaper price.
Ah, then we need to bargain.
We must bargain with him.
We are through. Now first, second thing we'll take, and we'll take our IGHL along with that. Again, we are far away from that still. After taking this bite, you will see the nice bumper over there.
All right.
Jaldi. Now main important thing is shift what we have done from the 6 o'clock to 5 o'clock.
The next suture you will take on the face of glenoid.
Yes, again face of the glenoid and the curettage where we have done it there.
What is the distance between the 2 anchor minimum
You can
distance?
see at least 5 to 7 mm.
5 to 7 millimeter. All right.
एक मिनट. सुकून नको आहे, थांबा. You can see it here. This is on the face of the glenoid. Hammer it, hammer it, hammer it. Pani. Support, 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 support. Come on. 1 minute. You can see now he's feeling the bone. Sure. Go, 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 go. I'm almost 45 to 50 degrees angle. पहले push करा. You use pushing anchors or other one?
I think you have all the 3 types of anchor there. One is just push-in. I think Griffon is push-in anchor only. You just
both are there. Both
are there. And the another one is your where you have to tap, drill, tap, and then screw.
Grasper. There are stick there. मला एक मी सांगतो. Stick there. हे काढा आणि एक छोटा आहे पॅनल घाला.
What about all suture anchor? You have you are using all suture anchor.
Yeah, I'm using that what I said, grasper. Now if you'll see, I'm taking one from here and we'll be placing blue color. Now we are taking our another bite. As you said, I have passed this anchor close 5 mm just because I just want to placate this. Okay, this part. So we will be taking into it this part.
Capsular labral tissue.
Yeah. So my first bite will be going through this part,
yes,
which will be just a capsule. See, I have come outside the part. This is just the capsular tissue. And now we will be taking the labrum for that. You can see this.
Yes.
Okay, hold it. Now these bites, if you'll see, हो ना, काय केलं? Cannula में हे. Oh. Now if you see this, once if you are through this inferior anchor, these anchors, they are dead in front of you. Funny. So both we have done in this capsule as well as labrum. एक minute. See, you got this?
Yes.
Grasper, please. Now we'll be tying that knot and then coming for the other one. Hold it, hold it, hold it. No.
We can see 3 thread. I think you have to pull one.
Yeah, now I have got a good bite. I have got capsule as well as labrum now. And now here hope we'll see what we wanted. Okay, because I have taken the bite from the IGHL itself. That's why this anchor I have placed it again 5:30 ka 5 mm 5 o'clock only we have placed.
All right.
Or 4:30 you can say. You can see now the capsule along with.
Yes. And now your knot is toward the capsular side.
Yeah.
So once you tight pull it, it will
Once
create the
if I
bump.
tighten it out, it will come. Now I can feel here the labrum is also there. Along with that, capsular tension also we are
Yes,
giving.
yes.
Right here. You can see this?
Good.
Yeah. Deepak,
I'm there.
anything else?
After this knot, actually, Amol was telling that we will shift for talk and then
Yeah,
we will
fine.
join again. So once you complete this knot, both the knot,
Yeah, sure. I'll finish this.
then
I'll
then
show
we will
you.
come again. We'll come back
I'll-
to see the final picture.
Yes, boss.
You still need to see the bump.
Now you will start seeing the bump now. You have seen already now. I'll show you one sec after this. And the bump, if you ask me, if you are not curating that 5 mm cartilage, healing is very good. Slightly leave me. You can see this. This is the bump what we have got now started getting. This capsule along with labrum. Now once if I tie the knot again from the below, it will come slightly above.
Yes,
Okay?
Samir. Yeah,
Yeah, fine.
we can see that.
Yeah, you can go ahead and come.
Okay.
Then once if I tie the Remplisa sutures, I would like to show you.
All right, all right. We will come back again. Thank you, Samu.
Okay,
Wonderful
welcome.
demonstration.
Yeah.
Over to next session.
Now give me one more bite. I want capsule.
Now we'll go ahead with the next session. I would like to call Dr. PG Kulkarni, sir. And Dr. Jitendra Patil, sir. Dr. Umesh Patil, sir. Moderate the session. Dr. Mokashi, sir. First lecture is of Dr. Tanvi Shinde on rehabilitation of shoulder arthroscopy surgery.
Good afternoon, everyone. First of all, I would like to thank organizers and especially Dr. Amol sir for inviting me here. I'm going to talk about rehabilitation after shoulder arthroscopic surgery. So Dr. Samir sir had just demonstrated nice Bankart's repair. So it is also very important to have good rehabilitation protocol after the surgical repair for the maximum functional output. So the philosophy of rehabilitation is centered on the principle of gradual application of stresses on the healing tissue with consideration of type of surgery, tissue quality, and patient variables. So the goal of rehabilitation is to control pain and swelling, ensure proper wound healing, and also protection of the repair in the initial phases. We also need to prevent shoulder stiffness and regain the full range of motion. Strengthening of the shoulder muscles comes in the later phases, and the ultimate aim is return to pre-injury status and maximum functional output. So rehabilitation is the team effort, and the surgeon is the one who is leading the team. Patient is the most important variable, and you can also include the relatives in this rehabilitation protocol. Sometimes in periphery, you don't have a rehabilitation team. So the surgeon must be aware of the protocol so that he can connect the patient in one-on-one fashion. So first we'll see rehabilitation after rotator cuff repair, which we can divide into 5 phases. So the first phase starts immediately post-operative up to 6 weeks. So initially, to minimize pain and inflammation, cryotherapy is essential. You can use a cryo cuff or bag of frozen peas for 15 to 20 minutes as and when needed. The most important factor is patient education. You should have a better communication with the patient regarding the expectations, which should be realistic, and goals we want to achieve with each phase. And it should be ensured that patient avoids activity which can produce stress on the repaired tissue, such as lifting objects or supporting body weight by hands or sudden movements. Sling should be used for immobilization from 2 to 6 weeks for about 2 to 6 weeks. And many patients complain that they cannot sleep properly at night. So you can advise them a proper position with support under shoulder for better sleep. After the surgery, initial mobilization is essential to prevent scar formation, and it promotes healing of the repair tissue. The immobilization period depends mainly on the size of the tear, tissue quality, and patient compliance. For small tears, immobilization up to 2 weeks is okay, or if it is the massive tear, immobilization up to 6 weeks is necessary. So you can start with neck, wrist, and hand range of movement exercise. Elbow range of movement passive if associated with biceps tenotomy or tenodesis. Pendulum exercises can also be started immediately after the immobilization is over. So start with passive forward elevation up to 90 degrees initially, which can gradually increase, and passive assisted external rotation initially in neutral and then progressively to 20 degrees of abduction. So there are certain risk factors which are associated with post-op shoulder stiffness after RC repair. These are calcific tendinitis, adhesive capsulitis, pasta type tear, concomitant labral repair, or acute single tendon cuff repair. So it has been shown that adding unweighted table slide into forward elevation helps to prevent this shoulder stiffness. So if you are comfortable, add unweighted table slides to prevent the stiffness. Remember shrug sign. If on starting the range of movement, patient is lifting his shoulder like this, it indicates insufficient activation of scapular muscles and altered glenohumeral mechanics. The balance of scapular muscles is essential, otherwise this type of shrug can lead to impingement of the repaired cuff. So scapular exercises like scapular retraction and protraction is essential for scapular mobility as well as strengthening of the scapular muscles. So after phase 1, coming to phase 2, we need to start the staged range of movement exercises. So going from passive to active assisted, and then active range of movements can be started. In this phase, take extra care to not to overstress, because sometimes for gaining the range of movement, we may push the patient a little bit, which can hamper the healing. patient can perform light activities of daily living at the chest level and below. So we tell the patient, do activities where you can see your hand. Don't do activities where you cannot see your hand. So starting with passive range of movement, which we have already started in phase 1, add progressive flexibility such as use of pulley in forward elevation, external rotation at multiple angles, and horizontal adduction across the body. Internal rotation with gravity assisted can also be started at this stage. So active assisted ROM can also start with cane or stick. Forward elevation, external rotation, abduction, and internal rotation. So all these can be done with cane or stick. Now again, we need to be more flexible, and as the patient is progressing, we can add a wall walk or finger crawl and scapular exercises with little bit of resistance and assisted external rotation in abduction. So how we assess that patient is actually progressing? There is better control of inflammation and pain. Patient has achieved adequate range of movement, that is forward elevation of 100 to 120 degrees, external rotation of 25 to 45 degrees, and abduction of 90 degrees. And there is proper healing of surgical repair without any shrug sign, and patient is able to do light activities of daily living. So strengthening can also be started in late phase 3. I'll say about after 10 weeks. So what you can do is side lying external rotation, which is again against gravity, gentle wall press in leaning positions, scapular exercises with resistance, and biceps and triceps strengthening can be added. So that was about phase 2. Now coming to phase 3, we can start the advanced training, and aim in this phase is to achieve full functional range of movement with continued protection by avoiding sudden movements or jerky movements. So now active range of movements can be started, initially beginning with supine position. Forward elevation can be done in standing, and internal rotation in supine and again in standing. Similarly, abduction and external rotation can also be started. So to achieve the end stage flexibility, stretching should be done so that the end stretch or the end range of movement can be gained. So this is forward elevation with wall slides, internal rotation, abduction, and internal rotation and external rotation. So this table, the washcloth or towel slide helps a lot in internal rotation. So strengthening can begin after 12 weeks, begin with light resistance band or lightweight. So external rotation in abduction or in neutral position with TheraBand or weights. Forward elevation can also be done with TheraBand or weights. Internal rotation, abduction. So to achieve more strength, we can add such exercises which can be easily done at home, that is ball on wall, which also helps in achieving proprioception, scapular strengthening, and shoulder extension. So now for after phase 3, the patient should have almost full range of movement. If not, in phase 4, we have to be more aggressive, and restoration of maximum strength and power should be our goal. So in this case, if the patient has achieved range of movement, we can gradually increase the resistance and weight and add extra exercises such as push-ups, planks, or internal external rotation in abduction with weights. So return to gym can be planned at the end of 6 months, and patients with rotator cuff repair should avoid bench press, military press, dips, upright rows, and chin-ups. And always tell them to avoid lifting in long lever position, that is with elbow extension and heavyweight lifting. So phase 6 is for those who are into professional sports or recreational sports, and it mainly depends on the sport specific strengthening. Hydrotherapy, if available, provides a good mode of exercise, and range of movement when performed underwater helps a lot. So to summarize, in rotator cuff, we have to respect the tissue quality and healing And the program has to individuate for each patient, protected range of movement for 6 weeks, and then strengthening can be begun. So labral repair is almost as rotator cuff repair, but we can start the strengthening earlier or stretching earlier as compared to rotator cuff. So immobilization is hardly necessary. If you are comfortable, you can start the pendulum exercises and passive movement initially in 0 to 4 weeks and strengthening after 3 weeks, phase 3, that is after 8 weeks. So at the end of 3 months, full range of movement should be achieved, and heavy weight training can also be started at 3 months. The only thing we have to keep in mind for patients with labral repair, these exercises should be avoided at any cost. That is pull down behind the neck shoulder press, wide grip bench press, standing deltoid raises, and triceps press overhead. So to summarize, rehabilitation after shoulder scopy need to be individualized. It is very essential for patient to understand realistic outcomes, and patient education is important. Care should be taken to avoid stiffness, and return to sports and recreational activities depends on our range of movement, strength, and conditioning of the shoulder. Thank you.
Thank you, Dr. Tanvi, for a nice presentation, because in rotator cuff tears and Bankart repairs, the post-operative management of the patient is much more important. And I have seen many times the rotator cuff open repairs or semi-open repairs, they get stiffness and frozen shoulder by the time we see the patient again.
Yes,
So
sir.
these things are very important. Thank you very much again.
Thank you, sir.
So
We'll just go to OT to see the final picture of the last case. Can you switch to OT?
We'll switch to operation.
Yeah, Rajiv?
Yes.
Yeah, Raju sir is
Deepak?
coming there only.
Yeah, okay. The Deepak, you can see this now after repair, post repair, you can see now the bumper effect, what we wanted, we have achieved it here. You can see this is the second anchor. The first anchor is more below this. I am just pushing this and I am trying to show you that there is a good labrum repair. What you can see, this is the MGHL. You can see this is subscap. Almost up to 3 o'clock we have repaired it. And these 3 anchors and the 6 stitches are there. What we have got, and even though if you do now, if you see this head has centered properly.
Yeah, yes.
You can see this. If this
Yes,
head
sir.
has centered properly, even wait 1 minute. Head has centered properly, and yet I have not tied the remplissage sutures also. But I'm not able to see the remplissage Hill-Sachs lesion. You can see this. I'm trying hard to see the Hill-Sachs lesion, but it's not possible. That means your antero-inferior as well as posterior-inferior part has got the head in the center now itself, and remplissage will be just a augmentation to it. Right?
Yes, sir.
Yeah. Now after this, just I will tie my remplissage sutures knots and finish my procedure. Fine?
thank you very much.
Yeah. Okay. Sure. See you.
So I'm calling upon the second speaker, shoulder arthroscopy Hill-Sachs repair, Dr. Rajiv Munde. Shoulder arthroscopy Hill-Sachs repair.
Good afternoon, everyone. First of all, I would like to say thank to Satara Orthopedic Association, organizer Dr. Amol Dhawale sir, and the secretary and president of the Indian Arthroscopic Society. So recently, just now we have seen bankers repair and how to go for the bankers repair and remplissage repair. What are the indications? So I will be just throwing the little bit short talk on the remplissage. Why banker repair is not enough in a anterior shoulder instability. So I will be covering the what is a remplissage procedure, where it is indicated, what are the histories or recent concept on the Hill-Sachs lesion and the remplissage surgery, what are the techniques and the outcomes. Pointer. So what exactly meaning of the remplissage? Remplissage is a French word. So literally meaning of the remplissage is a filling in. Filling is something in a dump or the pocket. And what by definition, it's a capsulodesis and the tenodesis. Not only the tenodesis, it's a capsulodesis and the tenodesis of insuspicious tendon into the remplissage. So before understanding the remplissage, just for the beginners, you should know what exactly the stabilizers of the shoulder. There are static stabilizers and the dynamic stabilizers. In statics, bone itself structure, that's the glenoid surface and the head of the humerus. Then the negative pressure in the interarticular joints, glenoid labrum, humeral ligaments, that is glenohumeral ligaments and the coracohumeral ligaments. And dynamic stabilizers, there is a musculature around the shoulder. That's a rotator cuff, deltoid, long head of bicep, and scapulothoracic musculature. So all these factors involved in the anterior stability of the shoulder joint. So if you see the literature, so in the first dislocation, there is chances about the 70% of the Bankert lesion and Hill-Sachs lesion about the 65. And in recurrent shoulder dislocation, it's around 97% of the Bankert lesion and the 93% of the Hill-Sachs lesion. So in the anterior surgery, we have to always look toward the Hill-Sachs lesion. Let's see why it is more important, why there is chances of recurrences. So for the Hill-Sachs lesion, it's not a old new term, it's a old terms. Initially in 1861, the Flower was the shoulder surgeon who has defined there is lesion around the posterior surface of the humerus in anterior shoulder dislocation. And 1940, Hill and Sachs, those are the surgeons. And then they defined what exactly the Hill-Sachs lesion is: the impaction fracture at the posterolateral surface of the head of humerus above the anatomical neck of the anatomical neck. And that's the definition of the Hill-Sachs lesion. And that floor should be parallel to the axis of the hand. That's a Hill-Sachs lesion. You can see how this Hill-Sachs lesion seen in the dislocation. When there is anterior dislocation, the head get impacted at the anterior rim of the glenoid, and that causes the fracture. That's why it's around 63% risk of having the Hill-Sachs lesion. To understand whether Hill-Sachs lesion required surgery or not, we should know what is glenoid tract. What is glenoid tract? When we keep our shoulder in abduction with external rotation and extension, there is a contact between the glenoid and the head of humerus. That's known as a glenoid tract. So on this image, you can understand when you take our shoulder in abduction with external rotation and toward the with a full external rotation, 0, 45 and the 90 degree or 120 degree, there is a contact surface between the glenoid and the head of humerus. So that's important. That's known as glenoid tract. On this image, you can see here, when you do the abduction, there is a contact of the head of humerus to the glenoid. So you can see the surface is only around the 84% of the glenoid, and rest of the glenoid around 16% is out of the head. Why? Because of pull of the rotator cuff. That's why when normally there is 80, we take the glenoid tract around 80% of the glenoid. And this is important in Hill-Sachs lesion and the Bankert lesion. That is a two-level lesion at the glenoid and the Bankert. So on this image, you can see here, when there is a glenoid bony Bankert lesion is there, naturally this glenoid tract get reduced and there is chances of the dislocation. And again, you can see the surface on the head of humerus, that's a contact glenoid tract on the head of humerus. And if there is a depression at this level, there is high chances of the glenoid, that's impaction or engaging lesion. So now we should know what is on track and off track lesions. In live surgery, Sheikh sir has told what's on track lesion and Hill-Sachs lesion. So to understand here, you can see when it is spot at here and pot at here. So this is a glenoid tract and this is a Hill-Sachs lesion. Hill-Sachs lesion, and this is what is believed thing is a glenoid tract. Here is a Hill-Sachs lesion, here is a Bankert lesion. So when there is both level injuries there, that is Hill-Sachs lesion and the bone back, naturally this glenoid tract get reduced and there is a chance of the engaging lesion. And how to calculate whether this lesion is engaging or not, that's depend on the calculation of the diameter of the glenoid. On the first image, you can see this is a diameter of the remaining glenoid around the 83%. And this is diameter of the Bankert lesion. And this is the diameter of the Hill-Sachs lesion. So when Hill-Sachs index is more than the glenoid tract, that leads to the engaging lesion. And when Hill-Sachs lesion is less than the glenoid tract, then it is a non-engaging lesion, that is a on-track lesion. And there we don't require any the Emplisage procedure. And that is calculated by ultrascopically or by CT scan. For that, we need to go ask our radiologist to calculate about the whether lesion is engaging or not, or Hill-Sachs lesion high or not. So how to diagnose the Hill-Sachs lesion? So this can be diagnosed clinically also. There is a test is a load and shift test and relocation test. We can get idea about whether this lesion is engaging or not. And by radiograph, so to diagnose the Hill-Sachs lesion, we can diagnose clinically with the relocation and the load and shift test. And by radiograph, we can get the idea whether the patient is having Hill-Sachs lesion or not. Even through X-ray, you can see some depression at the superior surface, just below the articular cartilage. Then the important X-ray is the striker notch view and the western axillary views to see the Hill-Sachs lesion on the X-ray. But 3D CT scan, MRI are the gold standard investigation to check whether this lesion is engaging or not. Here, this is the image. Just we can sometimes see to check the ideally whether lesion is Hill-Sachs or not. We need to go for the normal CT scan. Also nowadays they are doing the normal CT scan to check the diameter of the glenoid. On this we can see, we can say it is a on track or off track lesion. So on this image you can check here. This is the Hill-Sachs lesion, and this is Hill-Sachs index, and that's the glenoid tract G1 and G2. So Hill-Sachs index here, as a important thing is location of the Hill-Sachs lesion, not the depth of index Hill-Sachs lesion. Location, not depth of index, depth of the Hill-Sachs lesion. Depth of Hill-Sachs lesion never decide whether this is a engaging or non-engaging lesion. To calculate we need to calculate the area, that's insertion of the rotator cuff to the articular surface. So most lateral middle part of the rotator cuff insertion to the most middle part of the Hill-Sachs lesion, that is Hill-Sachs index. So we have to calculate the bare area between the hill sac lesion and also the between the rotator cuff. There is a bone area. Bone block is there between the lesion. So location of the hill sac lesion is important. More medial is a hill sac lesion, there is a chance of the engaging. So not depth, it's the location of the hill sac lesion that is needed for the whether it is engaging or not engaging. So according to recent literature, this has formulated recently last 2021 what's the algorithm of managing the anterior joint stability. On this image you can see when patient is young male and professional athletes with a contact sports person, if whether it is the first dislocation or the recurrent dislocation, we have to check for the glenoid and the humerus. So here, if there is a glenoid bone loss less than 25% associated with the hill sac lesion, which is on track, we will go for only the banker surgery. If it is off track, we have to go for the both procedure, remplissage or banker's lesion, when patient is young also. And when there is a glenoid loss is more than 25%, we have to go for the bony procedure like lateral procedure. And when there is a patient is not younger, not a contact athlete, not a professional athlete, and dislocation is more than 2, that is known as a recurrent dislocation nowadays. That is a recent article. And if there is no true dislocation, we have to go for non-surgical. If yes, then again we have to follow the same thing. Just 2 minutes. So what exactly it is remplissage procedure? Just told you. How it works, how this remplissage procedure work, why it is important. It not only the why it prevent the engaging of the head into the glenoid. It convert the intra-articular lesion into the extra-articular. That is the first thing. Second thing, because of the capsulodesis, it shifts the head centrally, and that is prevent the recurrence about the 4% when lesion is engaging. The types of remplissage: knotted, knotless, mattress, and double pulley technique. Nowadays, most common literature says that double pulley technique is more better or more functional or anatomical rather than single pulley technique. And knotted suture, not knotless. Knotless are the failure. So this is just my cases of how I go for the remplissage repair. So normally standard lateral position, diagnostic arthroscopy. And here most important thing is, as sir has told, antero-superior and antero-inferior portal. That is most important. Antero-superior portal is a weaving portal and the posterior portal is a working portal. So while taking the antero-superior portal, this has to be a little bit more posterior than the natural or standard antero-superior portal. That gives best view of the hill sac lesion. So how I go? So diagnostic arthroscopy, then glenoid preparation, no any suture anchor. Then I go to the hill sac preparation. I will prepare the hill sac lesion, and then I put the suture anchors. Then again I go to the banker repair. I will put the suture anchors. Then I repair the hill sac banker from the inferior to the superior. Then I shift to the remplissage. That is my last procedure for tying up the knots. So diagnostic arthroscopy, banquet preparation, no any suture placement. Then I go to the hill sac lesion, putting the suture anchor, passing the threads, and then I go to the banquet repair, complete banquet repair, and lastly tying up the knots. That will give the very easy and good way to do the both banquet and the hill sac lesion without any hasslement. So that's the video. Actually, I have a short of time. Lateral position. So that's my video of the surgeries, but it's not, it's a slow one and I'm short of time. So to summarize, it's not working. So to summarize, Hills about the remplissage procedure, the most important thing is that knowing the hill sag lesion, whether it's on track, off track. When it is off track lesion, we have to go for the remplissage plus Bankart, because recent literature says that when if you don't go for the remplissage, when lesion is hill sag, there is chances of the 30 to 40% of recurrence more than the plain Bankart repair. And second thing, double pulley technique is more important and the anatomical and functional than the single pulley technique, because what happens in the single pulley, when you put the single anchor and when you put the multiple threads here, there is chances of the suture strangulation with the single suture anchor. But same thing if you put the two suture anchor, one is here and one is here, and when you put the threads from here and here, one thread of this two anchor, one thread of this anchor, and we try to pull it out, this infraspinatus capsule will be attached natural, anatomical, more anatomical to the hill sag lesion, and that
Dr.
gives the
Rajiv.
good results, sir. Thank you so much.
So you gave a very excellent, excellent explanation why this remplissage is important, even after doing the Bankart. And that's really important in the patients who have got these types of hill sag lesion. Thank you very much.
Thank you so much.
Again
Thank you
for
so
an
much.
excellent lecture.
Thank you so much.
So I call upon the third speaker, Dr. Santosh Yadav. He's going to speak on indications of high tibial osteotomy.
Good afternoon, friends, all my senior colleagues and all the delegates. Firstly, I thank you, the IAS One and all the IAS office bearers, especially Dr. Sachin Tapasvi sir and my friend Dr. Sandeep Biraris for giving us such a huge lifetime opportunity to the Satara Orthopedic Society to have such a nice, wonderful CME, and also the MOA office bearers also, and all my SOS colleagues and friends. And the most and none of the best is my friend Dr. Amol Davle, who has taken a lot of effort since last 1.5 months, and for the grand success of this live surgery first time in the Satara. So today I am going to talk on the indications on the osteotomy. I know this is the era of the replacement surgeries. In this scenario, we mostly concentrate more towards the joint replacements, uni and all other things. But I've worked in the Europe with the AO osteotomy group with the Professor Lobenhofer, Alex Tobley, and Professor Robert Hiva-Warden. So this is an excellent group. She's working since last 25 years for the corrections of the deformity in the knee, tibia, as well as distal femur, proximal tibia, and even ankle also. I got a great opportunity to work with them for a period of 1 year at 3 different clinics, one in Switzerland, Germany, and one in the Amsterdam. So today is my talk on the indications on the osteotomy in the knee. Primarily, we're talking about the knee. So what is the high tibial osteotomy? So why the osteotomy is needed? High tibial osteotomy is a procedure with the goal of repositioning the mechanical axis of a varus small aligned knee into a slightly valgus one.
Slides are not moving. Right.
To decrease the joint tenderness, to decrease the rate of cartilage degeneration, and also to postpone the joint replacements. Even though I'm the big fan of the joint replacements, still I find that these recent osteotomy surgeries are very good. So next, so primarily the osteotomy around the knees has been started in, first is generated by in 1826. After that, Würzburg Clinic, Hein, it has in 1830, they have tried the first osteotomy. And after in Glasgow in 1975. So what are the main? There are frontal plane deformities which may cause the arthritis. The alignment in the frontal plane is the most important part. So what is the major part is the constitutional varus deformity. It is in 32% males and 17% in females. So this is the shows the normal alignment as well as the constitutional varus. So biomechanical studies have done in the 6 humans shows how the axial load in mechanical testing system is in the extension as well as ligament and meniscus, as the ligaments and meniscus are intact. So this graph shows the varus malalignment when both the meniscus and the ligaments, especially the ACL and PCL, are intact. This is after the open wedge osteotomy with weight bearing line to 62% and HTO has got 9 millimeter and MCL is 100% released. This shows the primary alignment, mechanical axis, as well as varus and valgus deformities. So what is the epidemiology of the STO? A frontal plane deformity more than 3 degrees increases the risk of osteoarthritis in the knee. 4 degree of deformity, which has got 3 times risk of the arthritis, and which progression to the 10 to 20 times faster with the deformity. Deformities induces abnormal joint loading and can be restored to normal by osteotomy. So what are the prime indications for the high tibial osteotomy? Either in the congenital deformities, post-traumatic deformities, or in unicondylar osteoarthritis. Going by stage, we can say that high tibial osteotomy, considering the age. So what is the right age for the high tibial osteotomy? It's between 45 to 65. It has got excellent results if done properly. 90% survival rate for the 10 years of more than 10 years. If the correction is more than 6 degree to 14 degree. If correction is less than 5 degree, then there are high chances of failure are there. Considering the level of activity, for this, doing the high tibial osteotomy, all the patients, male or female, should be active with isolated joint pain. That means either a medial compartmental pain should be only there. And second, also the most important thing is it should have the unilateral osteoarthritis. That is a medial compartmental osteoarthritis with all the both medial and lateral meniscus should be intact. ACL and PCL ligament should be intact. And joint should be functioning properly with range of movements more than 120 degree. Between 90 to 120 degree, it should be more than 90 degree. So this shows the deformity in the frontal plane, which shows the constitutional varus. So constitutional varus shows the tibial bone varus angle, which is the most important part in the STO. If it is more than 5 degree, there are 83% survival rate. If it is between 2 to 5 degree, it's a 71% chances that 10-year survival rate. Less than 2 degrees, 56%. And if it is 0 degree, there is 36% chances of the survival of the joint. Some studies show how the regeneration of the potential of the osteotomy. These are some examples. A 26-year-old male with lateral condyle with 2 arthroscopic surgeries with pain in the activity of daily line. A distal femoral osteotomy has been done and significant pain has been improved even after 2 years. This is second example, 62-year female with grade 2 with JO score is more than 50. This is preoperative X-ray. This is post-operative after 1 year. This is post-operative X-ray after 1 year. And implant removal at the end of 1 year. So another most important finding is it should not have any malalignment. That means deformity should not be more than 15 degrees, and it should have the metaphyseal varus and very good range of movements. Also, most important thing is patient should be a non-smoker and some degree of pain endurance capacity should be there. So these are the prime important things to improve the high tibial osteotomy because it has got a very high success rate as compared to the other procedures. More than 80% of patients survive more than 10 years, and it has got less complications such as infections, and non-union is 0 to 4.4%. In conclusion, STO is an alternative procedure for the knee arthroplasty in young patients, in active patients with malaligned knee, which induces medial compartmental degenerations. Thank you.
A very nice presentation, doctor. I want to ask you one question regarding whether do you do whether do you do or here, whether do you do close or open wedge? You do open wedge, I think most of them are open wedge.
Open wedge.
So do you do high tibial osteotomy close wedge?
I do open wedge osteotomy.
And what is your opinion about close wedge osteotomy?
Close wedge osteotomy also works fine, but in tibia, I prefer to go for the open wedge osteotomy.
Okay.
Thank you very much, Santosh. But I have one question. Previously, when I was in Bombay, they used to only cluster the patient, no implant inside. And afterwards, they will mobilize the knee joint. Close wedge, yeah, right. And that also was giving very good results. Even I had seen Dr. Anand Joshi sir also got his STO done with Eliza Rao. And when I was there, he was coming to theater with Eliza Rao, STO corrected. And he has got very good results. So STO is a very good procedure.
With the modern implants like the Tomofix, we can start patient made to stand on the same day and start walking on the very next day. Yeah. Thank you very much.
Now I will call Dr. Ankit. He's going to speak on H2O and planning.
Okay, so I'll try to make it crisp so that we can focus more on the surgery that is lined up after this. I'll talk on planning of medial open wedge high tibial osteotomy. Now, before that, this is a case example. This is the X-ray in front of you, and we've got three options: a total knee replacement, a unicondylar knee replacement, and a HTO. Can we have a raise of hands who will prefer a TKR for this patient? Good. So the next question that comes is the age. So this is the age and the occupation. Now, are there any changes in your thoughts? Sorry? Come on. I think this is good enough to have a solid. So will you do a HTO for this bone on bone or not? Is my question, is the direct question. So this is a. So yeah, so this is one of my colleagues who he's a little aggressive who works with me, and I was really not ready to do a HTO in this patient, but he ended up doing an HTO and the patient is doing okay. I just wanted to show you, let you know that we are pushing our limits for joint preservation surgery these days, and age actually and these changes in the radiological changes are actually bypassing the indications that we are having now. Anyways, so the indications have been taken already done. So I'll just skip all these things. Contraindications, smoking and all was decided. Okay. So for planning, the first thing that we all have to understand is that the lower limb orientation is to be understood properly, because if the lower limb orientation is not correct in our minds, we will not be able to plan properly for any joint preservation surgery for even for the upper limb and the lower limb. So the current orientation in the frontal view is the patella, which is centered and looking dead in front of you. So almost all the times we'll have to internally rotate the foot to have this position. Similarly, in this picture, you'll see how somebody in the front has to feel the patella to actually have it in front of you. So the lower limb orientation should be clear. Now we'll see what happens when the lower limb orientation is not clear. So this is the correctly oriented lower limb scanogram that is there in front of you. And in this video, I'll show you how a badly done scanogram or a orientation can make so much of a difference. So when the patella is not looking in the front, you can see what is the difference out here. And the moment you've changed the orientation and the patella becomes centered, suddenly the joint looks okay. So this is a major difference that you can get when the orientation is not correct. First things first, we need radiology. So these are the things that you need. You need a full length standing scanogram. Remember, it has to be a standing scanogram. Then you need a standing AP view, isolated AP view of the knee. You need Rosenberg view in 15 degrees of flexion. You need a lateral in full extension and a monopedal stance view monopedal stance lateral view. This is for chronic ligament deficiencies that you need. Now, what's an ideal scanogram? An ideal scanogram is one where which is done in standing position. The patella has to be facing forwards in the center. The lateral tibial flare should cover 1/3 of the fibular head. So this is what this line means. The lateral tibial flare should cover the 1/3 of the fibular head. And there should be no overlapping projection of the distal femur. There should be no overlapping projection of the distal femur in the AP view. So this is the ideal scanogram. My suggestion is please don't accept anything less than an ideal scanogram when you're planning for high tibial osteotomy. Now, the next question is how to take a proper scanogram. So this picture will illustrate this. You need the patient standing with a cassette, a 51-inch cassette behind the patient. The X-ray beam should be about 10 feet away from where it is being projected, and it should be dead at the level of the patella. So this is the ideal scenario where a proper scanogram can be done. It's difficult to have these in, so you need a big room for all this to be done. But this is the ideal way to do it. Now, a standing AP view is this, and a Rosenberg view is this. So this is the major difference that you get when you have a standing view and a Rosenberg view with you. So there are times when the arthritis can get accentuated. You can see the arthritis better in a Rosenberg view. A lateral full extension will give you the idea of flexion deformity. And after you finish the X-rays, you need an MRI. So MRI predominantly will help you to tell you the status of the cartilage inside and will quantify the arthritis basically, and will let you know the status of the meniscus and if there's any subchondral bone edema or not. These things are important for you to decide where to shift the line of weight bearing ultimately when you're planning. And if you want to do anything at the time of HTO procedure, if you want to do something for the cartilage or for the meniscus, so an MRI becomes important. Here you can see how the medial meniscus looks extruded. So this patient had a root tear also. So ultimately I ended up doing a root repair with a HTO. Now, this book is essential to read if you want to really learn planning of osteotomies of the upper limb, the lower limb, not just the high tibial osteotomy. This is the basic principles by Dror Pally that everyone, whoever is interested, should take reference from. Next, we need to understand the lower limb axis. So the mechanical axis, anatomical axis, we all are well familiar with our arthroplasty concepts. The mechanical axis of the tibia and the anatomical axis of the tibia are almost the same. The femur, both the axes are different. The center of the femur head and the center of the distal femur is the mechanical axis. Anatomical axis is running along the shaft of femur. Similarly, on the lateral view, so these are the lower limb axis. Next, you need to understand what is joint line orientation, joint orientation lines. So you need to draw a line. So a proximal tibial joint orientation line would be a line connecting the deepest part of the tibial plateau on the medial and the lateral side. So that is the joint orientation line for proximal tibia. For distal femur, the most convex part of both the condyles, the line joining both the points, is the joint orientation line for distal femur. This is important. I'll let you know why. Next, we need to understand what mechanical axis is. So mechanical axis, when we are talking about joint preservation surgeries, HTO, is the line joining the center of the femoral head and the center of the ankle. Normally, it is also called Mikulicz line by the name of scientist called Johann Mikulicz. Normally, it passes about 4 to 8 millimeters medial to the midpoint, which means it is not in the center. So the distance between the center of the knee joint and the mechanical axis is called mechanical axis deviation. So mechanical axis deviation in a normal knee is a little medial, it's a little varus. So which means that anything which is up to about 4 to 5 millimeters from the center is not considered to be pathological. So what is significant varus? 15 mm of medial mechanical axis deviation would be significant varus, and 10 mm lateral would be significant valgus. So these things are important to understand. Now, there is always a question. Once you see a varus malaligned knee on a scanogram, how can you be sure if the varus deformity is coming from proximal tibia or distal femur, or where exactly it is coming from? So these are the angles that you should be familiar with. When we are talking about deformity varus, which is around the knee, the two most important angles are the MLDFA and the MPTA. This is the basic nomenclature that we are using for reference. MLDFA is the medial lateral distal femur angle, which is this, and MPTA is medial proximal tibial angle, which is this. These are both complementary angles and they are both same. They're between 85 to 90. We take the average of 87. So this actually, a calculation of these angles will let you know where exactly is the deformity, and there you have to operate. That correction you have to do for the patient. Now the next question is how much to correct. So there's something called Fujisawa point. We are all familiar with this. It matches over the mechanical axis with 3 to 5 degrees of valgus. So Fujisawa believed that shifting the mechanical axis to this point, which is 62% of the tibial plateau width when measured from the medial side, is the ideal point where unloading of the joint will happen. So it is just lateral to the tibial spine. So for long, it was believed that every HTO should be shifted to Fujisawa point. Then came the concept of arthritis with metaphyseal varus. So you don't need to, so the concept was that you don't need to shift the mechanical axis every time to Fujisawa point. So you can quantify the cartilage loss. If it is 2/3 cartilage loss, you have to shift it to 55 to 57%. A 1/3 cartilage loss, 60 to 62, about 62%. And if there's no cartilage loss, there's just varus and the patient is symptomatic to have arthritis, you can just shift it to center. So this is how you can use cartilage deficiency to assess how much to correct. Now, this is the actual planning that you do. There are a couple of methods that you can choose from when you have to decide how much to correct. And the one that I use is called Miniachi method. It's a very simple method. So this is the pre-operative scanogram. First, you need to make a weight-bearing axis, the Mikulicz line, center of femoral head, center of the ankle. Next, you make a line where you want the desired mechanical axis to be passing from the knee. Next line is to mark the hinge point of the high tibial osteotomy. Next line is to join to drop a perpendicular from the hinge point down to the ankle. And then you have to make the line connecting the hinge point. So that the angle subtended between the last two lines, the last two green lines, is the correction angle that you want. So out here, you've decided in degrees how much is to be corrected. So first we decided where to shift the mechanical axis. Then we decided how many degrees is required to shift it. But you don't have degrees. You can't use degree while you're actually correcting it. So you need some millimeters so that wedge base is decided. Now the basic understanding, or people used to believe that for 1 degree, you have to open 1 millimeter. So that's not true because of the difference in morphology of the population. You can get a small tibia, you can get a big tibia. So Professor Hernigu actually came out with this trigonometric chart where he gave correction angle on this axis and the depth of the osteotomy, the length of the osteotomy on this axis, and you just have to match it. Most of the times it will be 1 degree to 1 millimeter, but there are times when when there'll be a difference. Say for example, a 9 degree with a
time is over actually. You can have half a minute.
Sure, sir. Thanks. So this is how you can use the Hernigu's chart. So this is the basic understanding of planning of high tibial osteotomy. A little bit of advanced understanding. There are times when you can have varus malalignment due to intra-articular problems also. For example, the ligamentous laxity also. So a very complex calculation of alpha, which was the effective angle of varus because of ligamentous laxity was this. This was a very difficult understanding given by Dugdale and Noyes. Ultimately, the easy concept was to understand that the normal joint line congruence angle is of 2 degrees, which is acceptable. And say, for example, you have a JLCA, which is 8 degrees. You just have to do this calculation, JLCA minus 2 divided by 2. Say, for example, it is 8. This becomes 6 divided by 2 is 3. So 3 is to be subtracted from 9 there to ultimately have what you have to correct. If you don't do this, then you will be overcorrecting your high tibial osteotomies because of the ligamentous laxity in the knee. So this can be a catastrophe if you don't take this into consideration. Finally, this is how my OT boards look like when I'm doing an osteotomy. I use the Herny-Goose chart very often. This is the software that I use, Bone Ninja, for my Miniachi calculation. And this is the app that I use in my phone for ready reckoner in front of the patient, where I have to show them what osteotomy means, how to draw the lines. This just take about 10 seconds of total planning. Thank you.
Very nice explanation about the planning of high tibial osteotomy by Dr. Ankit. Thank you very much. So now I will call the next speaker, Dr. Nikhil Likate. He's going to speak on surgical technique of high tibial osteotomy.
Very good afternoon. First of all, I would like to thank Satara Orthopedic, IAS One, and Dr. Amol for giving me opportunity. Ideally, this is one of the very interesting topic, and which I really love it. And this is on a high tibial osteotomy. As previously discussed, there are a lot of techniques through which you can do the high tibial osteotomy. But most commonly and most commonly utilized and user friendly is one is like a middle open wedge or whatever I'm going to tell about. So going for the high tibial osteotomy, yes, it's technically demanding surgery because it requires a lot of pre-op planning and then intra-op execution. Unless and until you do the pre-op planning before surgery, you're not going to get a better surgery results in high tibial osteotomy. So there are different. High tibial osteotomy is like a broad term. You have a lot of osteotomies around the tibia. So we have an open wedge osteotomy, we have a closed wedge osteotomy, and there are some different osteotomy like enter closing wedge and enter opening wedge, like slow putting osteotomies. But today we're going to talk more about the opening wedge osteotomy or a middle open wedge osteotomy. So points I'm going to cover is pre-op planning, already been covered. I'm not going to emphasize more on that. Position, the instrumentation, the equipments, special implants which require for these osteotomies, surgical steps, and post-op regime. So as initially my previous speaker already told about the pre-op planning, what you require a good standing X-ray with a calibration. That calibration is extremely important because we have to deliver that reduction component and a magnificent component of the X-ray, and you have to manage intraoperatively. So that is what is called a scanogram, and you require a good software. And if you don't have that good software, I think you should have a ruler and pencil, and you have to draw some angles before going for the surgery. So planning, obviously, you need to understand the Michaelis line, that is a weight-bearing axis from head of the femur to the center of the ankle. Then you need to calculate the MPTA, that's proximal, mechanical medial proximal tibial angle. LDFA is a mechanical lateral distal femoral angle, and important is the JLCA, the joint line closure angle. If you don't pay attention to the JLCA, probably you can undercorrect or overcorrect in the postoperative phase. So this is a Miniachi method. Again, I'm not going to go detail, but it's same way. It's a software based. Once you put your scanogram in a software, that is why you require a calibration. You have to calibrate that with a software, and you get a lot of information about the angles, what you have it. So you have to pay the attention towards this angle. The more important is the LDFA and MPTA, where you're going to give some idea. You have to plan your weight bearing axis where you exactly want, and accordingly you have to plan your wedge, and you get some idea. So you can get the how much millimeter you have to open, what degree you want to open, and after opening, then what MPT and LDFA are going to achieve after the surgery, so that you can predict the results. So that is why you need a good software with you. So obviously, again, same thing, drop rally, there are some angles. Again, it's a MPT, LDFA, not going to go much. These are normal values for those. So if you have a metaphyseal varus or either in a tibia or a femur, you have to plan your osteotomy accordingly. If the defect is in tibia, plan your osteotomy in tibia. If the defect is in femur, you have to plan your osteotomy in femur. Don't try to go with all the time in a high tibial osteotomy for entire deformity. So now question comes, where you're going to shift your weight bearing axis. So this is just a summarize of things. So if you have no arthritis, or only you're doing something for the cartilage repair, or you just want to unload the things, you can shift your weight bearing axis to 50 to 55%. You don't want to go to the formal Fujisawa point, which is 62.5%. But if you have a Lawrence class type 1 or type 2 arthritis, you can shift to somewhere between 55 to 60%. If you have more arthritis, you have full loss of cartilage, you can even shift your weight bearing axis to 65% to 70%. And that you have to decide preoperatively. And once you put a scope. So, main question, whether middle open wedge osteotomy or lateral closing wedge osteotomy. Okay, why I choose a middle osteotomy? Because it's more precise. It doesn't require a fibular osteotomy, and it can be done concurrent with the ACL reconstruction, your root repair, your meniscal stabilization, your centralization. So, many surgeries can be accompanied with the middle wedge open wedge osteotomy. But there are some risks involved with this middle wedge osteotomy. What? It causes patella baja. So if patient has previously patella baja and you're doing a middle wedge operation, you're going to land up with the problems. Again, the limb discrepancy, because open wedge going to cause a lengthening of the tibia. So you need to take that point into consideration. And if you are not proper in doing the osteotomy, probably you land up with the increased slope. So when I choose a closed wedge osteotomy, when there is a limb discrepancy, when I have a patella baja, and if I have to go with a larger correction, say more than 12 mm, 13 mm, I will prefer the lateral closing wedge osteotomy. Again, if I have a Cartan-Duchamp index is less than 0.8, that means I have a previously done a previous existing patella baja. And if I have to do a middle wedge osteotomy, probably what I'll do, I'll take, rather than biplanar doing proximally, I'll take this distally so that my patellar distance doesn't changes. So prevention of complication is extremely important when we are doing a high tibia osteotomy. So there are major 4-5 complications. One is a neurovascular complication. Then we have a hinge fracture. You can alter the slope, and we can have a non-union pseudoarthrosis. So you have to take care of all those complications. Like if you have to deal with the neurovascular injuries, you have to keep the leg in a flexion, and you have to use some sort of radiolucent retractor, which you can put behind the tibia. And when you are sawing this bone, I think under X-ray vision, you are safer to do that. Hinge fracture, again, you can use some novel things like a hinge wire screw. You have to open the osteotomy gradually, and you have to and don't cut your saw cut to the lateral cortex. Slope alteration, always you have to open more posterior compared to the anterior part, so that you are not going to alter the slope. And for a non-union, you have to use a newer implant, which is a 3rd generation implant, which is angle stable with a variable angles. So these are some ornamentals you require when you're going for the surgery. No doubt, a good CM and a area of instrumentation of those stack osteotomes, a laminar spreader, and this is a radiolucent retractor which you can put up behind the T. So approach, it's just like a hamstring harvesting approach, or your knee flex position. You have to take an incision. It's just like a hamstring harvesting, but you have to just pull it a little bit proximally towards the joint line, almost 4 to 5 centimeters in between the anterior cortex or the posterior cortex, more than sufficient. Then how you do expose? Once you open the sartorial fascia, either you can take a reverse incision, or you can take a double window method. So this is a routine way which you do. Take a reverse incision, you start erasing your MCL, you start erasing the sartorial fascia in one go. Or else, if the patient is bulky and not able to put your retractors behind the knee, you can take this double window approach, where you can have one window anterior to the MCL and other window behind the MCL, and straight you can go ahead with the further. So how much MCL you want to release in this situation? So when you're planning an open wedge osteotomy, you need to release your MCL. And how much? At the most, whatever the comfortable way you can go. Sometimes you can release an entire MCL till the 6 centimeter down, but don't touch your deep MCL. Why you require to release the MCL? Because if you don't release and if you're opening the joint, there is an excessive tension happens on the MCL, and indirectly what happens? It increases the intra-articular middle compartmental pressure, and it entirely haywires your principle of the H2O. Second thing, this is a condition for a patient is very painful. So patient land up with a full flexion deformity, and patient lose some sort of flexion in the postoperative phase. So once you open it, you have to put your wires where you can put the wires at least 4 to 5 centimeters from the middle joint line, and you have to aim towards the tip of the proximal tibial joint, somewhere 2 to 2.5 centimeters from lateral cortex. You have to stop short of at least 5 to 10 millimeters from the lateral cortex, and both the wires should be extremely parallel. And you have to arrange your CM in such a way that you are negotiating with the posterior slope. So you should able to see the entirely both the wires in the same plane, and your sawing cut should go parallel to the wires. So how are you going to protect the neurovascular bundle? So the neurovascular bundle is extremely important, it's just lying behind the tibia. So you need to put some sort of protector behind the knee and you can cut the things. Second thing, angle of cutting. This is called as omega angle. So if you have a less angle omega, I think you are safe with a neurovascular end. If you're taking a 90-degree, I think you are more prone for the damaging the neurovascular bundle. And these are the new saws available. These are called precision saws, where the blade, the entire blade doesn't oscillate. It oscillates at the only tip. So you're protecting so oscillation, say you're protecting the neurovascular. It doesn't cutting beyond certain range. So this is a normal blade which oscillates, and these are only the precision which oscillates. So these are better implant instruments which you can use for the high tubular osteotomy. Again, we believe in a biplane osteotomy. Why? Because it gives additional stability, it gives better bone healing. So we always prefer you can use the proximal based or a distal based depending on the patella baha or not. And to hinge fracture, again, there are 3 types of hinge fracture, as you know. So how we present, you have to open the tibia very gradually with all these kind of conventional instruments available in state. You can use a laminar spreader, you can use a stack osteotome. But important thing is that you have to cut a posterior cortex completely, and you have to when you take a biplane, it should be a through and through cut. Otherwise, your patella, your tibia doesn't get opened up, and you land up with the fractures. Always try to open more posteriorly in a trapezoidal matter so that you are not going to increase the slope. This is how you can change the slope with the high tubular osteotomy. You have a leverage with the high tubular osteotomy where you can increase or decrease slope by just changing your hinge pattern. So again, hinge wise, again, this is a very novel concept. Just this prevents the propagation of the fracture. It prevents the propagation of the saw as well, and it increases the viscoelastic property of the hinge, and so that you can safely open the tibia without having the fractures. You can put this antegrade, you can put this retrograde. This gives a direct compression, but if at all you find there's a hinge fracture at the time of surgery, you can use the direct compression screw from the plate and you can compress the hinge at the lateral side. So these are the angle stable, these are variable angle plates. You can use it, they have a very low profile, and you can use them with the ACL reconstruction or a PCL, so that you can negotiate with the tunnels and there is no coalition of the tunnel. And these are very angle stable, and because of their stability and their strength, you can immediately wet bear the patient in the immediate next day. So this is only the surgical step. I just wanted to this is a small video, is a 1 or 1.5 minute video of HTO, but we have just saw. So that's the opening. I just bear 1 minute. So there is always oozer. So always find out there is oozer, and there is always infrapatellar branch of the saphenous nerve. Try to protect that so that you should not have any neuroma. This is the reverse L-shaped pattern incision. So I just releasing the sartorius fascia in a L-shaped manner so that we can expose the MCL. This is the superficial part of the MCL, and again you have to release that superficial MCL part with the help of cautery or some sort. These are the MCL. Okay, you can see the MCL. Now you can start releasing this MCL from anterior to posterior till you can go behind the tibia. And once you do that, you can put a radiolucent retractor just behind that part, reaching towards the tibiofibular joint. You can put your finger down as well and you can palpate your tibiofibular joint so that you can plan your cut. So this is a sharp osteotome, which we are releasing the popliteus and the all soft tissue from behind the tibia so that we can have a space for that radiolucent retractor. So this is the trithovan going just anterior cortex, and where we are protecting the patellar tendon so that we can plan our biplane cut. So once you put your trithovan, you can see the entire proximal tibia, and then you can just see the place where you plan. This is your biplane cut. See, normally it is up to 100 to 110 degree angle with your horizontal cut of the tibia. So put the wire, first wire always on the posterior cortex, head towards the superior tibiofibular joint. And once you do that, you can plan your second wire exactly parallel to the first wire and check under Siam. And if you're happy with that, you're ready to go for a saw cut because you're already protecting the posterior neurovascular bundle. This is the sagittal saw which we used to do before. And try to use osteotome. If you are not pretty acquainted with your posterior cut, initially you can use osteotome to cut the posterior cortex, or else you can take a cut. This is the biplane cut. It's almost at 110 degree, and this biplane is through and through. Okay, you have to go from medial to lateral completely, and you have to cross the hinge. Otherwise, you're not able to open the osteotomy completely. So this is once you're cut, you can see that we can open the osteotomy with only hand. You don't require any retractor, only laminar spreader, because you are already done a complete cut, and it's a viscoelastic, and you can see that the hinge is still intact, and it's a very stable osteotomy. So now I'm just putting my laminar spreader and just wanted to open up the tibia, whatever the way want, which I previously planned. So my pre-op planning says it's 8 mm. I'm going to open 8 mm. If my previous plan says it's 6 mm, it's 6 mm. I cannot detect what exactly amount I have to open on table because this is a pre-operative. Whatever the surgery we're doing in the lying down position, it is not on the standing position. Whatever the calibration we have done, whatever the measurements we have done in the standing position, that you have to reciprocate on the table. So you trust your pre-operative plannings and go with that. So once you do, see, this is the just check whether we are opening same or not. And you're cross-checking with your long rods and with the CM. And once you're happy with this, I think you're good to go with the fixation.
Dr. Nikhil.
Yeah, and that's a plate. I just put it. So that's how we fit. And I think this is a technique how you do it. And that's all. So this is how you do it. Rehabilitation, I think, is a standard rehabilitation. Thank you very much.
Very nice presentation about the high tibial, open wedge high tibial osteotomy. But what I feel is that in open wedge, era of open wedge osteotomy, we should not forget the closed wedge osteotomy also.
So there are a lot of problems with the closed wedge. So when we are planning a open wedge osteotomy, there are a lot of other indications. The indications for the closed wedge are very important. Okay. I say, if I had to go with a very large correction, I can go with a lateral closing wedge osteotomy. The problem with open wedge, the closing wedge, if you are planning closing wedge and after 10 years down the line, I have to go with a replacement surgery. I think closing wedge is it's a disaster for the joint replacement surgeon. But if you go with a medial open wedge osteotomy, I think it remains pristine even if you go for the joint replacement. And you have to always think for the future as well. It's not only what you're doing right now. You have to think for the 10 years down the line, what is going to happen with that as well.
Two things. One is that you told that there need to be osteotomy of the fibula has to be done, head of the fibula. But it is not necessary always. Just by doing an subluxation of the superior tibiofibular joint also, we can take the closed wedge there. And secondly, the closed wedge which we take, we make a bone, crush the bone there, and we put the same bone inside and correct the whatever valgus varus or varus is there. So these things are there and no implant is there. It's economically less. So I don't say that whatever procedures you are doing are not correct, but one should not forget about closed wedge osteotomy also.
Get the art of doing, but you have to choose the indications properly where we are going to go. See, if I'm doing my lateral closing wedge, yes, there are indications. We are doing lateral closing wedge as well. But if you see that if I'm doing a closing wedge, I'm going to increase the slope of my tibia, okay, which is not get controlled. But if I'm doing a medial open wedge, I can control my slope so that my joint integrity and my alignments. See, we are just showing one like a coronal alignment. But what about the sagittal alignments? You have to see those as well. And for those, I think you have to choose the indication and go ahead with that.
Okay, thank you very much. So now the case-based discussion is going to be there or no? So I call Dr. Tonpe, Prashant Tonpe, for the case-based discussion shoulder. You are going to show knee, okay?
Just wanted to just join. So for the major correction, Kulkarni sir, for the major, if you wanted to do major correction on HTO, so we can do the dome osteotomy also. It is there is a stable osteotomy without any implant also, we can do dome osteotomy of the tip. Close wedge, dome osteotomy. Mangal Paryada. Can you try? Hello. Really? So coming to the, just I wanted to uh, present two cases, as Dr. Kulkarni has shown his technique of joint preservation. So I just selected that case and I'm just presenting. So this is a around 22 years old male, and this is the X-ray. So Mokashi sir. Male history of trauma.
There is a intra-articular fracture of
Yes.
abdomen.
Yes.
Eversion of ACL is there?
Yes. So what you want next, sir? How you will go ahead further?
So I would like to do MRI in this patient
Okay,
and see how much the avulsion is, which bone exactly has gone up,
okay,
how much millimeter the distance is, those
exactly.
things, whether it is undisplaced or displaced, so you can classify the avulsion also.
Yeah.
So that I will do
So
first.
next investigation is MRI with what type, how much the type, the size of the fragment, which ligament is damaged, and other concomitant injury of the meniscus and cartilage. So here, sir.
So here what
Sure.
I see is the avulsion is there. There is about
Just you, Sham also can join the stage. A chair by the.
2 to 3 millimeters of, millimeters of distance is there.
Okay, so what's your plan, sir?
Patient, I will do the same thing which I explained today in that.
Okay,
I will do figure of 8 but tension band like fixation of arthroscopic anterior posterior ligament avulsion.
okay. Sham, sir.
I usually do arthroscopic pull-out suture.
Okay.
That suture bridge technique,
Okay,
and that is giving me a good result over the period of time.
okay. What about the Nikhil? Suture bridge, huh? Techniques, huh? So same thing. We did like in this any time for the ACL avulsion. I just wanted to show there are so many types of fixation. You can show suture bridge, then wire loop. What sir shows. The previously I was doing the same thing, wire loop, but to remove the again wire, that is another surgery we have to do. That's why we shifted to the suture bridge technique. And now I will show this. This is a pre-op video. Before surgery, there is a laxity, and this is how. This is the fragment. The ACL is totally intact, but the bony avulsion. This is the intermeniscal ligament. So that bridge is there. So that's why it can sometimes what sir's technique is there now, so that so this ligament can come inside. So it can you can see the toggling of that our fragment, and so that fragment we have to take it out, that intermeniscal bridge. So this is how I planned. So what, how you will, sir, with suture bridge, Nikhil, so how many? Okay, suppose it is around around 1 to 1.5 centimeter to 1.5 centimeter. Fragment is size, and it is in a curve. Okay. Give one mic.
Hello. Okay. There are many times if you go put your scope inside and you find that the fragment is not alone. It is attached with your meniscal roots as well. And they're bringing back to the place is very easy because there is soft tissue attachment. So probably that time only single suture bridge is more than sufficient.
Okay.
But if the fragment is large and you try to pull with only single suture, it try to toggle up or it open up, and then you require a 4 coats, and then you have to crisscross it and you have to bring it back.
Exactly. Huh. So I planned same every time. I will do the 4 guide wire. I will put. This is the planning of the guide wire. I with the jig, ACL jig. I just mark the guide wire. This is incision, and these are the 4 just guide wires. No any 4 mm drill on that. Just guide wires. All 4 guide wires. This is the first. I will fix that fragment with K wire, And so that the fragment will stable, then around that we'll do, these are the 4 guide wires. And this is the K wire, which is a fix. Then these are the 4 guide wires from outside. As this economically, but still we have to use the fiber tape. I will use always fiber tape, not fiber wire. Now the Indian company fiber tapes are very good. They're having the 2 mm thread on both side and the tape on the main middle side. This is the first suture, and crisscrossed with this another with suture pass. Then again, this is the fixation. There's all 4 wires we should take out from the all corner crisscrossly, and the same, which is the which end is on that side, that suture, so that like umbrella, like that kind of fixation of the suture will on that fragment. So just this is the just I have this as a poor constraint, so I'm not using any button, fancy button. So just simple suture disc. I don't have that time or that flat disc, so I use this round disc. But it is the reverse because I can't use because there is no any, I not made any 4 mm hole or like that. So this is the final fixation. And the fracture is anatomically reduced. This is the tibial, anterior tibial side, and this is all very stable fixation. Excuse me.
And what I want to tell about this procedure is that the beauty of this procedure is we can do this procedure even in the patients who have got non-union of the ACL avulsion. I have done many patients, and recently also I did one patient who had 2 years old non-union of ACL avulsion. What I did was the bone piece was still there, but bone piece must be there. The bone piece was still there. Then I just shaved the bone piece from behind, made a raw bone even on the tibia also, and pushed the whole thing down with some little bit of force and maintained the tension in the anterior cruciate ligament. And recently, after about 2.5 to 3 months over, his follow-up was there. His anterior drawer is negative and the patient is walking with full weight bearing. So this is the beauty of this particular procedure. We can do it even in non-unions of ACL, and we can preserve the ACL and the knee by doing these things.
Tell me. Okay.
Fracture. Is this a overkill, you think?
No, just only just
But
small,
still,
it is
if
only
you,
1.5.
for a beginner or a starting,
Fine,
who is
for the
starting,
beginners,
to
it
put
is-
4K wires, 4
it is little
wires,
difficult.
then fixing it, it's bit tedious job.
Yes.
Even if I am doing it now,
Yeah.
I'll tell you to put 4 wires, again fixing it, and all the time you have to place the zig in proper places.
Proper place.
You have to place his anterolateral, anteromedial,
Medial,
posterolateral, posteromedial, these all. But it's really tedious job.
Tedious
It's
job,
not
but-
an easy thing to do for fixation.
But with this technique, we can achieve very good reduction.
Good reduction.
That is very important, and healing is also very nice. No, but
Put 2 sutures, locking sutures with the fiber tape and fiber wire, and pass with the one side, one thread from one side and one thread from the other side, and fix with the suture disc. Because as
No,
sir
that's
has
why
told-
the figure of 8, what I'm telling
Yeah.
is very easy method. You just go behind the ACL.
ACL.
And one, you just reverse it with that particular thread you take from the other side, and this from the other side. That's why the loop is formed there.
So, no, but
And
so
you
that
can do.
the
There are so
anterior
many
part of
procedures.
the fracture, now it will always toggle in that case.
If,
That is
if,
the-
if fragment is fully free, then it can toggle, posterior part can get lifted up.
Yeah.
No, what you have told is just a correct way, because passing the sutures from the 4 side gives definitely good stability, but passing the 4 drill bits holes through the tibia and again drifting the threads, it's a not so easy job. Sir.
No, it is,
Fixation with the KY,
Just,
it takes
with, I am
too
just
much time, yeah.
using a spinal needle and
Okay.
and just ethylone number 2, 20 ethylone. Just take with the suture base, and just we have to just do the suture management with this. So I should just show the final fixation, the laxity is gone. The case 2 now, again, it's the same case about, sir, another preservation technique. Sham. And this is a directly
this
CT
is to have-
scan. I don't have X-ray.
This is a PCL avulsion fracture,
This-
lifted up almost around more than 6 millimeter, which is the indication for the surgery.
Okay.
And I would like to have one MRI to know the associated injuries.
I don't have MRI. I think this is a CT scan only. No, not have MRI. So, how you will fix, sir?
I usually fix arthroscopic pull-out sutures,
Pull-out
suture bridge
sutures.
technique.
How many tunnels?
Usually, depending upon the reduction, I take 1 or 2 tunnels.
2 tunnels, okay.
Yes. With 2 portals, obviously.
The
but
suture,
2 portals.
you will pass to the substance, or you will just like, sir, will give the loop to the PCL?
Initially, I started passing sutures through anterior portals around the stump.
Yeah.
But nowadays, I take 2 bites with the
Yeah.
scorpion
Yeah.
through the substance of the PCL,
PCL.
which gives better control over the bone fragment.
Okay. Nikhil?
Yeah, I always do through the posteroscopy, all this, I never go. Obviously, we do scope anteriorly, but yeah, my technique is all posterior. And yes, I always take with the scorpion, I take a bite, because I take the control on the PCL first, rather than the bone.
Bone.
We are not really worried about the bone, it will heal. If you properly maintain the tension in the PCL, bone heals. So it's a single technique for the PCL, which goes below the footprint, so that crisscross switches go through that.
Yeah.
It compresses the bone, but I'm not really worried about that compression. It's a tension on my PCL.
PCL.
Bone automatically heals.
Okay.
Sir, I have one case which I followed with your principle. Bone remained lifted up in one single case, but that patient was having pain and she hit my head since 2 years.
Okay.
Ideally, we use a tape, which is a strong tape. It's a 2 mm tape.
2 mm
Okay, always 2 mm, no smaller than that. And even if you put right goes to left, left goes to right. So
Yeah.
it should not come in the front. Otherwise, what happens? That fragment gets escaped. Okay, if you're crisscrossing it behind the bone as well, it doesn't get escaped.
Okay.
What happens sometimes, even after tying the knots, when you scope and see that the even crisscross sutures go means lie sideways.
Sideways.
They don't presses the bone fragment.
Exactly. So, we have to use, you have to use actually, sir, how many portals you are using? Posterior portals? Posterior portals?
Posterior middle portal as you go normally,
And?
and my posterolateral portal, posterior middle portal. I
Same,
always
that
take a
interceptal portal.
Yeah, interceptal, always
Okay.
septum. So it's easy to do that.
So for the fixation, 2 portal, always 2 portal. So this is the diagnostic.
Vision is clear and you can manipulate.
This is a
as well.
PCL.
So-
is, coming.
The surgery is ready there. Theater
Yeah,
is
yeah.
ready
Just
for
one,
surgery.
I wanted to just show you.
Yes.
This is the how I same management with the Scorpio. Again, sorry, gone. And then it's the same thing. We'll take the will use in this case I use a 2 tunnel technique with the same with wire, 2 guide wire. This is a jig for the first tunnel. Then another. This is the 2 guide wires. You can see a blunt guide wire actually. Far below the fragments on both sides. Then these are the 2 guide wire, position of the guide wire from the outside. This is how we can manage that. I told you as a spinal needle, and with the help of suture passer, take that echelon out and pass that suture. Next, this is how we did the fixation, and after this is just I am holding ahead, not yet done anterior drawer, and then fix the that on button. I will show you the final. This is the final fixation on TBL side. This is the final laxity after. There is no any laxity. And I just wanted to show you the last slide. They're very important. I don't know why it is happening. After fixation, you have to check for that slow PSL sign is gone. Your PCL is fixed very precisely, and there is enough tension on a PCL. Last, okay. This is last. This is after fixation. You can see the slow PSL sign gone. The ACL tension and PCL tension is good enough. And then this is the most important part after the PCL then fixation. This is called we can give the post. It is called TBL post. So like some pad you have to press under the TBL part of your brace, so it should not sag down. So PCL is very much fixed, stable in extension. So that's why you have to give this. So even if you are putting the normal knee brace, TBI will sag down and there will be tension on your repair. So always give this TBL post or like some kind of soft tissue, some cotton pad behind on the TBL part of in 70-degree anti-drawer test. 70 degree of flexion knee, anti-drawer, giving anti-drawer.
Thank you, Dr. Tonpe, for excellent presentations of these cases.
Yeah,
And especially which I also do for a long time. And thank you very much for very nice lectures in this particular session. So now we are ending this session. Before that, all these all these speakers should come forward.
Dr. Ankit
Mementos.
Varshni, Dr. Rajiv Munde, Dr. Tanvi Shinde, Dr. Kiran Doshi. Rajiv Munde. Sir, Dheeraj. Tanvi Shinde. Deshpande sir. Dr. Deshpande sir.
Got to come here.
Dikate sir and Prashant. Prashant Gomte.
करूं? 52.
I'd like to call Dr. Sham Shinde sir and upon.
This is intact.
To moderate the next case, Dr. Sharad Jagtap sir and Vinod Jagtap sir will come on the stage. Ajit Bhosle sir, you have to.
That's okay. जैसे कर दे
स्टेबिलिटी है उसको, ये लगता है लॉकिंग होता है
ठीक है
उसके चलते होता है।
या लेटरल इज ओके एसीएल देख लेना ऐसे जरा नीचे तू एंगल नहीं करता ना
नहीं मैं तो ये पूछने कभी कोई दिक्कत नहीं करता हूँ तो सब हो जाता है।
Sandeep,
yes
you already started.
so we have just entered into the scope 2 minutes back. So patient clinically now Rajiv is doing arthroscopy. So there is a degenerative changes in the medial compartment. Medial meniscus already has got degenerative tear, which I don't think is require repair. And lateral meniscus is normal. Now, Rajiv, I'll hand over to Rajiv. Is it intact? The patient has a gross instability.
Rajiv sir.
Yeah, hello.
Yes.
So you can see we are inside the knee joint. You can see this is your medial compartment. the medial femoral condyle, the medial tibial condyle. If you go, you see, there is a kissing lesion there with the medial side. You can see some amount of degenerative tear is there. And if you go inside the medial meniscus, the whole of the medial meniscus is intact, but some osteochondral defect is there. You can see a big OCD is there. So we will go for microfracture. And what happens when such a big osteochondral defect is there? What happens most of the time? The patient gives the history of instability, but at per you can see the ACL seems to be intact. Huh?
Hello, Sandeep?
Yeah.
Yes.
Am I audible?
Yes.
Yes. So you can see.
We have started the video seeing now.
Yeah.
Just, so will you please introduce your case first?
Yeah.
What
So I
your
think we will have a. There is a
what
small
your-
history. There is a small history.
Partial tear.
So yeah, the posterolateral bundle is gone.
Wait.
Yeah.
So 52-year-old male patient with history of RTA 1.5 years ago. He had complaints of difficulty in walking, pain in right knee, and occasional giveaway sensation. Range of movement is good. Varus valgus test is negative, anti-draw test is positive, and Latchman test is positive. So these are his clinical examinations. Good range of motion. Varus valgus test is negative. Latchman positive. Anti-draw test positive. His angles were drawn. MLDFA is 88.7, MPTA is 85.6, JLCA is 4.2, slope is 4, angle of correction calculated is 9. The plan is to do medial opening wedge osteotomy and arthroscopic ACL reconstruction using MyTech implants and new clip implants. Over to OT. Sandeep, you're live.
Yes, Sandeep. So by the time we have seen the patient as a tear of the single, I will do that.
Can you hear Rajiv?
Yes.
Yeah. So we have a plan of doing a ACL reconstruction with HTO. So sequence of events, first we have done a diagnostic roundup. There is a posterior medial compartment arthritis with some degenerative changes in the medial meniscus, right angle artery, please. And patient has also symptoms of instability. One of the, you can see there is a tear in the one of the bundle. One more right angle.
Extra.
So you can see this large incision we have made. All right, not an issue. So we have made this large incision in view of our plan of doing a HTO. So I will be showing you the just Langenbeck. One more right angle is not there. One more right angle is not there.
Mixture.
So since
Bond.
we have a plan of ACL reconstruction with semi-T graft, I will take only semi-T graft, 4 full semi-T, and after doing in the HTO, we will try to fix it with adjustable loop in the proximal part in the femur and a disc over the tibial side. So this is the standard incision. Normally, when we plan for ACL with HTO, we take a long incision around 6 to 7 millimeter medial side inverted J type of incision. Who is moderating the session?
Yes, myself, Dr. Sharad Jagtap.
Yes, welcome, sir, Dr. Saro. So you can see here, this is my semi-T. So just I will take my graft. There are some myofascial adhesions there. I will try to take them out. The good thing is when you're planning for ACL with HTO, chalo.
Stripper.
No, kaat do.
Either still is.
Adhesion, sir, because of age?
Yeah, because of age, and he was an active person, BSF personnel. Huh? Yeah. One more suture.
दोनों एक ही लेना है ना?
ना एक ही 4-fold डिस्क के लिए तैयार करना, ठीक है। वन मोर सूचर,
और एक डाल दो।
डबल ले लेता हूँ, चलो। टेंडन स्ट्रिपर. So the sequence of event when you are planning for ACL reconstruction with your HTO, most of the time what we do, we go for a diagnostic roundup, then harvest our graft, we'll make our femoral tunnel, then Sandeep will do his HTO part, the high tibial osteotomy, putting the posterior screw and the inferior screw. Then I will make my tibial tunnel, and accordingly we'll put our second and third screw. So two of the screws in these plate systems are variable. So that is the advantage. So you can see this is a long semi-T graft.
Graft board. Okay.
What steps are doing for harvesting?
So already we have, you can see here, can you focus, cameraman, can you focus here? We have around 7 to 8 centimeter incision on the medial side. It's around a J-shaped incision. So we have done a bigger, see, suppose you want to do isolated ACL, you put an incision of 2 or 3 centimeter. Here our plan is to do an HTO with ACL. So we have put a bigger incision that has made my life easy to harvest the graft. I have already done the diagnostic arthroscopy. So now,
You said the graft part, which you are removed.
yeah. And patient, yesterday we have saw the patient gives a history of significant instability. You can see one of the,
Yes, we have seen in clinical.
yeah, clinical examination. So just no shiver. So how do you plan your when you are getting a ACL with HTO? Do it a single stage? You can see this ACL. This is mucoid, typical mucoid degeneration. You can see that was the cause of the instability. Yes. So mucoid nowadays we've gone for. You can see the yellowish discoloration of the ACL, and that was the reason the patient was giving me. So I told Sandeep, one of the bundle is intact. He said, no, Rajiv, he is giving significant history of instability, and that is the reason. You can see the bundle. It's like a dead bundle of cells. You don't have an intact collagen there. That is the main issue. So medial compartment osteoarthritic changes are there. I will go for a medial meniscus balancing also. The lateral meniscus is intact. Some amount of degenerative changes are there in the medial meniscus. So just we will go for a medial meniscus balancing here. In the meantime, Sandeep is preparing graft.
That's what we want to see.
And Sandeep graft has a unique technique. Just I will take you to Sandeep. Because by that time I will prepare femoral tunnel. So you can see whole of this ACL had a mucoid degeneration, and that was the reason the patient gives a history of instability. So just try to clear whole of the posterior condyle. And whenever you have a patient with mucoid degeneration, nowadays I think the standard practice is we don't keep the remnant. Yeah, so earlier, so nowadays that is the standard practice. We don't keep any remnant there. You can see this is your tibial footprint, that is your femoral footprint. So just I have taken it out. You taken it out. So cameraman, can you focus towards Sandeep graft harvesting technique?
Yeah, he's doing already.
So Sandeep, you can sue them.
Yeah.
So I will put
we
a
have
disc
got
there.
almost 32 graft.
Yeah, fourfold, huh?
So we are
femoral
doing,
tunnel, chalo.
because the plan
Offset.
is adjustable loop on the femur side
Offset.
and
Four-fold.
four-fold graft, correct. So now what I have, you can see here, I have done 2-fold. So now I'm preparing graft. So this my assistant Rahul. Sushant is I think lost somewhere. Cameraman Sushant. Now try and zoom in here. So
offset
Which material you are using?
ET1 number 5. So I have straightened the needle. He's holding the end. Now
Beat pin lagao.
I'm going entering into the substance of the end of the ET bond. Now that's far extreme end, and now I'm again doing the same loop very closer to the ET bond. It's closer to the needle, so that gives loop. Can you see? So that's the loop. So now my assistant is holding at the loop. So I am doing like what we braid technique or like a veiny. So I'm entering, coming out, single hole in the center, and you get good compression of the graft from both the sides. So I would like to do this way. So this technique we have already submitted for publication. Dr. Pradeep Nemade, good friend of mine, is the inventor of this technique, and I have done little modification. So it is same like forming the knot. Other commercial companies have such type of suture, but we don't use that. We just use our number 5 Ithiband, number 5 Ithiband, and make the needle straight and make this type of speed loop.
Yes, very nice.
Yeah, can you see?
90 degrees.
Very nice, robust, less traumatic compression. You focus here.
Yeah.
Focus here. So by the time Raju makes portal,
Adjustable loop.
I have already taken adjustable loop. So this company, they come, they have two type of adjustable
Offset.
loop. The one is long and the other one is shorter. So here I'm
Offset.
using longer adjustable loop.
Make it long.
Sizer. So it is 8.5. Tight in the 8. Yeah. So I am
7.
We are going to take 8.5. क्या किया है? ये change कर. ये change
चलो
कर.
flex.
अच्छा ठीक है चलेगा.
चलो flex. Flex. अभी इस पे नहीं था. Flex.
So I'll just tension it and leave it. Then while we prepare for the
Keep one disc also there.
yeah. Hanko. Bas. So I always use Vanco or Genta.
Yeah.
Always soak it. So we'll go to now Rajiv. I think he's already done with the femoral tunnel.
With down. Yes. Go. Now go. Yeah. Yes. Take it out. So now, as I told you, for ACL with HTO, the steps are like that. Start your diagnostic roundup. Go for meniscus debridement, which we have done. Then harvest your graft. Then harvest your graft, make your femoral tunnel. Then Sandeep will do the HTO, then we'll pass the graft. So normally when I am doing HCL with HTO, I usually prefer putting a disc there. What happens? Sometimes your osteotomy is very close to your screw side. Go. Yes, fantastic. It's coming out at 4 millimeter. So I have used a 7 millimeter offset here, 4 millimeter cannulated here.
4 mm.
And today we are using a nucleoplate, which is a very good plate when you are doing HTO with ACL reconstruction, or sometimes you are doing HTO with a root repair. You have all those options available there, where you can tie your root, you can tie your endo button also there. Even if you don't want to put your disc, you can tie your suture also. We have separate holes there, mean to tie your suture also. 4 millimeter, yes. And measuring depth, keep it ready, please. Depth gauge. Depth gauge निकाल लो जब.
Yeah.
Depth gauge. Thank you. Yeah, go through and through. Yes.
8.5.
Now Sandeep is familiar with TKR position. So I told all like today I will learn the TKR position, and I'm doing, I think, first time in TKR position. But it's a good one, Sandeep. I loved it. Take it out.
You prefer leg hanging?
Leg hanging, but जब दोस्त TKR में कर रहा है तो मैं leg hanging कैसे करूंगा? So you can see it's a 38.
Yeah.
So now we are using adjustable loop. Reamer. What is the diameter? Put reamer. 8.5. So 8.5. I will go up to 28. 28. So 22 for graph, 20 and 6 millimeter for tensioning if the to tighten the disc also. Chalo, reamer लगा दो 8.5. One more bit, please. One more bit.
Position you have done the femoral tunnel.
Yeah.
At which position?
It's a hyperflexion. That is the advantage in TKR position. You can see my sister. Can you zoom back? She is holding. Push कर दो इसको.
Zoom out.
Then zoom out. You can see. Push करो. Push
Zoom out.
बस हाँ. Artery से पकड़ लो उसको.
Yes.
You can see it's hyperflexion. That is the advantage of TKR position. So you can put it 8.5. So I have a very good assistant. I think Sandeep fellow is with me, well trained, and I think he is doing fellowship for.
Drill. Push.
Yeah, just push.
Yeah.
Go. Yeah. Slow.
How much
Eyes up. Yeah.
How much you are going,
So
Rajiv?
25. Yes, you can see. Just rotate high with hand. It's a soft bone. You can go like this only. Yeah. 20. You can see 25. It's a soft bone. 52 year.
Yeah.
So 25. Just 26. Just I will keep 1 or 2 minutes more and come up. Okay. And switcher. So my job is done. Now it's Sandeep job. Hold it, sister, please.
Okay, that we can do later on.
My job is done. Yeah. So now Sandeep, over to you for STO.
So we are starting HTO now.
You
Chalo.
have forgotten your PEDA box over here, Dr. Rajiv.
Oh, which box?
PEDA box from Saka.
I
Yes, we will hand over to you after your surgery.
yeah. So send someone in from OT only. We will leave for airport. At 11 o'clock, I have to catch flight.
Yes,
Ma-
we will.
I think Mai and Sunita also.
Yes.
He is with me here only.
Dr. Hadra also.
Yeah, Dr. Hajra, Dr. Sunit Hajra. So
Pottery.
Sandeep, over to you.
Pottery.
Chalo.
Sandeep can
Pottery
take
now.
anytime.
Pottery. Blade देतो पर्यंत. Inside knife. Inside knife.
Any question till now about the preparation, or you do it in another way? When you are planning for ACL with STO?
Pottery there. Can you see the view? I'm just getting pottery.
Yeah, just zoom in, huh? Zoom in, yeah, yes.
Pottery, please. Blade दे.
6:30 leave. आज होएगा जो तो ग्राफ तुले लाके.
Hello.
Yeah.
So Rajiv sir,
Yes.
so with the new new clip technique plate, we have a variable angle screw. So
Pottery झाली की
it's
चालू
easy to miss the tunnel.
Yes, that is advantage. And suppose earlier when we were using the fixed angle device also, in that also, what happened, we will try to put the plate on the pit of posterior aspect so that in between the screw you can bypass your graft. So you put two screw, make your tibial tunnel. The third screw, just try if it is hitting your tibial tunnel with pin, leave it, central screw. Otherwise, you can put an oblique screw there. So I think with variable angle, we have more options available. And I think that is a boon for ACL with STO. Now we are doing it in same sitting. That is the reason now most of the arthroscopy surgeon or sports surgeon are doing it in the same sitting. So now we have Sandeep here. See Sandeep. Sandeep, over to you. He is going for
So I have done the
frequency.
see, I am elevating. So this is tibial tuberosity.
Sandeep sir,
Yeah.
routinely we are putting with beginners and with routine plates, not so fancy plates. Can we put a tibial tunnel first, put a graft, but only don't fix the tibial part and then do the osteotomy?
No, because always you need to do first your osteotomy, because if you are planning your planning your tibial tunnel.
Yeah, we are planning routinely what we do. Might be less experience, but we take a less angle for the tibial tunnel and then do the osteotomy. So it don't come in the way of the osteotomy.
Because very difficult to judge Because if you are doing lot of
So,
correction, then sometimes you may land up putting your tunnel into the osteotomy site.
Okay.
So it is always better. And what I do now, I'm going to open that plate, open ACL plate.
plate, nuclear plate,
So you can see I'm just elevating the flap
ACL plate.
where I'm working by.
The advantage of first doing the osteotomy is that you can shift the osteotomy a little distally
Yeah, that's
to
what.
normal. So you know your ACL tibial tunnel then can come into the proximal tibial. A little distal compared to the normal osteotomy level.
Okay. Because what in PKC they have shown like this previously.
इथे periosteum आहे ना. आधी का नाही घेतलं ते? Cautery, I'm not happy. किती cautery ठेवली आहे? मॅडम.
You can tell him about the plate. This
I'll tell them.
just I will.
Cautery, I'm not comfortable with this cautery here. Don't push, bhai. And now see, yaar, what is the purpose of putting there? Elise.
Rajiv sir.
Yes.
So when you were using the old conventional HTO plates,
Yes.
after doing the osteotomy, you were kind of fixing the plate a little more posterior compared to being
Yes, yes, because and I what there are three screws in the Tomofix. You can see the posterior, the central, and the anterior screw. So try to put your posterior screw first. It will never come in front of your ACL tunnel. Second, anterior screw, make your tibial tunnel. So always try fix your osteotomy first. Posterior anterior screw, then distal screw of the plate, and then make your tibial tunnel. Then try to put your central screw. Sometime by miss and match, you see it passes away without disturbing your tunnel. Because when you have made your tibial tunnel, normally I put my reamer there in the tunnel, and if your drill is going freely without touching the reamer, you can put your third screw also. So that was the technique we were using when we were using the fixed angle device. So now with this, I will show you, Sandeep will show you the plate. We have opened the plate. What are the advantages of this plate?
So if you can see here what I'm doing now, I have gone completely posterior to the tibia. Can you see?
Yes, sir.
Yeah, and I have kept knee is in flex position, because if you try and do it here, so MCL will be very tight and there is a risk of injury to the posterior neurovascular structure. So I'm slowly I'm elevating with such a nice curved osteotome. I'm sorry, periosteum elevator. Sometimes you may use osteotome, but they're little sharp. So now I'm almost complete behind, and with my finger, I can even palpate the fibular head.
This is very important step. You can see knee flexion at 70 degree and subperiosteal flexion.
Mera spike Siam. Mera color spike.
Siam.
Remove this. So I am flexing, passing my this radiolucent spike. Hold.
Guide wire.
Okay, like
Two guide wire. Go back. Yes.
You don't understand.
Now you have to focus on
Down.
both this picture, then Siam. Huh? When he will say Siam, you have to focus on the scale.
Good, sister. Ah. Kalakar. Can you see?
Siam.
No,
Focus on.
sir.
No, sorry, yeah. Dakho.
Zoom and see. Show them. Zoom in. Zoom in. Zoom in. Zoom in.
Can you see?
Yes, now.
Oh,
Yeah.
fantastic.
So that's my spike placed there. Come on now here. The drill.
This is the radiolucent, no? Yeah, radiolucent.
Yes. Good. Stool, please. Good. Let day. So what I am doing here, I have already opened the plate.
And you can focus here. Left side ACL plate. Yes.
Can you see?
L. Focus on. Yes.
So that's the plate. So the advantage is I'll always
put it here and check. Good thing is this screw is variable angle, the anterior most. Then this middle screw is also variable angle. So whichever angle you want to put, so you can easily miss the tunnel of the ACL or even for the root. Then all others are fixed angle. So I'll check here. That's how will be my plate. Shoot,
A bit high.
shoot.
Siam ठीक करो.
Can you see?
Yeah, Siam. Focus on Siam.
Can you see the Siam picture, please?
Yes, sir.
Yeah. So here I am going to put it little higher. Show. And osteotomy, I'll be taking the artery.
Diathermy.
So I'll be taking
Focus here.
osteotomy somewhere here. Shoot.
Shoot.
Somewhere here.
Siam. Focus on Siam. Zoom in. You can see?
Yes, sir.
Yes.
So osteotomy will be here, and then that's above area I'll be using for the screw. Picture of the wire. Shoot. 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 Shoot.
Yes, fantastic. Toward the tip of the fibula.
Tip of the fibular head.
Yes, fantastic.
Remove. So, then they have got a very good दे देना वो flat wire का. So they have got a very good this guide which allows us
Zoom.
put another parallel to it. Wire.
Fantastic.
Shoe. Give. So second wire.
It will be parallel.
I hope you are able to see the picture. Shoot.
Yes.
So that makes life very easy. Shoot. 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 Okay, remove. So my both wires are in. So you can see I will retain this here. I'm not going to remove. Give me a small spike. So this small spike I'm just putting over the tibial tuberosity. So I know where exactly. Now with this, I have already put my wire. So I'll be marking this 110 degrees of angle. This is the posterior border of the tibia. This is the tibial tuberosity. So this will be my 110 angle HTO. So I'm planning to do biplanar. I am very much fond of biplanar osteotomy. So this angle is 110 degrees. Are you able to appreciate it?
Yes, sir.
So
Sandeep sir, are you fond of putting a hinge protection wire?
I'll be doing, yes. Not now. Shoot.
So when
So
he is
that's
doing
my thought.
osteotomy, at that time he will protect
Siam
it.
picture दाखव.
Yes.
Siam, so
So one thing you should, you should be always careful to do osteotomy under the wire. I always do under the wire. I never do over the wire. Because if you do over the wire, there is a chance that osteotomy may escape into the lateral tibial plateau.
Cameraman, can you show the live picture of the knee? Cameraman.
Cameraman over the knee. यहाँ पे shoot करो. Yes. You can see he is cutting under the wire.
Yes.
So these are the wire on the top, saw blade is underneath.
So assistants is try to keep the knee in 20, 30
And it
degree
is
flexion.
exactly at the same position where I have kept my radiolucent spike. Shoot. 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 Shoot.
Sir, are you using Falcon saw, precision saw?
Sorry?
Is it
Precision saw. No,
Falcon?
no.
Hinge protection wire.
Hinge
Sorry, come
protection.
again.
Is it Falcon saw? Falcon, the precision saw?
No, it's not precision. It's our regular
Okay.
striker saw.
Jugaad.
Yeah.
You don't have that privilege always to get the precision saw. Pati, Barte. Sarak. 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 So for this one particular step, I always like to come on this side. Shoot.
Focus.
Shoot. Shoot.
Cameraman, zoom out.
See arm.
Shoot.
See arm.
Shoot.
So this is the protection hinge wire.
Shoot. Shoot. Shoot.
Fantastic.
Remove.
Excellent.
So that's my hinge protection wire.
Yes.
So at this step, I put that wire. Saw.
Saw.
Shoot. You can see where I have reached.
Yes.
Shoot. Yeah. Shoot. I'm going to stop it there. Just short of hinge wire, I'm going to stop. Now I'm going to take my other cut. That's the horizontal cut. Sorry, vertical cut.
Small saw. Change the saw.
Small chota blade.
Chota saw.
So here I always use small blade. Sister, retract here. Retract this. Retract this.
In front of a face here. Show them the
So now my this wire work is over. Okay, so I have removed them. Hold this, sister. Hold this. Now you can see I'm asking them to do little extra rotation. So I'm going. Any doubts or queries?
Yeah, Sandeep. Hello.
Yes.
Dr. Santosh here.
Yes, sir.
While doing this dome osteotomy,
yeah,
if by default or by chance you can cut out the hinge, then what is your alternative plan?
So I'll put hinge screw there.
There is screw there over there.
Or I can put the Coventry pin. So you can see, show here. Can you see the opening now? Can you see the osteotomy?
Yes.
Can you see the movement?
Yes.
Yeah.
Hey, zoom in kar. Zoom in kar.
Yes.
कोणी तुला आगाऊपणा सांगितलं नाही.
So how much correction you're planning?
9
He will
degrees.
show everything.
But we'll still always
Rod.
decide. Can you see the movement?
Yes.
So now I'm going to put
Alignment.
these chisels. I don't use hammer. Now I'll use later. I always believe in my punch for this, because I don't want to be too aggressive, because no everyone doesn't have this small open thoda. This lightweight hammer you don't get everywhere. बीच में हाथ मत डाल. Okay. Open.
ओपन कर दो हल्का हल्का. वहाँ हाथ रखो एक. बस.
Right angle lower bicep. Shoot. Shoot. Yeah. Don't worry, not required.
Do you plan pre-operatively how much correction
Yes,
you are going to
yes,
do, or
yes.
you decide intraoperatively?
No, I always plan.
Light
I
on,
always
light,
plan.
the light.
So these are the osteotomes or chisels, which, and you can see here, I have not removed that posterior spike. Sister has been holding it very diligently. So I think that is will be my correction. I'm going to check with the alignment
Alignment
rod
rod.
in case I want to go
Ready.
inside. So this has completed my osteotomy. Now what I'm going to do is, can you right angle? It focus kar. Can you see?
Yes. Yes.
It has opened and this has hardly moved. So that is good. I am so happy
Chalo.
because sometimes purale. Hip joint AP. Hip is a
Hip. X-ray hip.
Is there any change in the tibial posterior slope?
No, normally.
we usually don't change, and here it is not going to change. I have in fact kept when you do this medial open wedge osteotomy, there is always risk of you tend to increase the slope if you do open wedge. So that's why I'm going to put my lamina spreader into the posterior cortex.
Yes.
Or upper.
Yes.
Here you have
Shoot.
opened the medial side.
Pakad. Shoot. Yeah.
Fantastic.
Sure. इथे तिकडचं दाखव त्यांना.
Siam. Don't show here.
तू खाली आण आता. हे शिफ्ट कर इमेज.
Rajiv sir, do you always like to
Ankle.
No. Never. So if it is up to 18 millimeter also, don't bone graft. If it is more than 15 millimeter, 1.5 centimeter,
Ankle.
then if you want to graft, put a tricortical graft.
I like crest ICB.
Yeah. Here you can see Sandeep has put a ECG lead there over the femoral head, center of the femoral. You can see there.
Yes.
Yeah, that is very important.
Ankle,
Step.
center of the ankle.
And you can see center of the hip. Now
Yes.
save that image, here. And now he will focus on C-arm only image. Center of the ankle, yeah, please. Yeah, go.
Shoot, sister. Sorry.
Shoot.
Yeah.
Yeah.
Now knee.
Knee, come to knee joint. I think you can be a bit lateral also.
Yeah. Little more.
More.
Knee joint.
Knee joint.
Shoot.
You can see the sequential X-ray we are taking.
Yes, sir.
Hip, ankle, and now we will see in the knee. You can see, and now he will correct.
Yes.
You can see it's almost over the medial tibial spine.
असं करू नको.
ठीक से कोई बात नहीं, आराम से हाँ, डोंट बी इन हरी हाँ. थोड़ा अच्छा सा घुटना को दिखाओ. यस, थोड़ा सा ठीक है. ओहो, he is scared of.
असं नाही करायचं. फुल मशीन.
चलो हाँ. बस.
Fantastic. So that's
beautiful. Bang on.
Okay. So now this everything goes out. Hammer.
Sandeep.
Yeah.
Can you tell us exactly where your cuts have gone?
Sorry.
That means you have opened up medially.
Yeah. I didn't get you. Please come again, sir.
You have opened up medially.
Yeah.
Yeah.
Then you have taken the anterior superior cut anteriorly, which has gone intact towards the lateral side.
Screwdriver.
I didn't get your question. Sure.
So that's what we want. You have done the osteotomy.
Yeah.
You have opened up medially with the help of multiple osteotomes.
Yeah.
Then you have taken one cut.
Now focus here.
Which is on the anterior side.
Focus
yes,
here.
Correct.
Yes. So
yeah,
we want to
see that
know about that cut.
Yeah. What you want to know?
You have opened up medially.
Medially, correct.
That superior cut is there.
Yes.
Anterior cut is there.
Here.
Zoom here.
How you have taken that cut and till where you have cut that?
Perfect.
See.
So this cut I have taken through and through to the anterior aspect of the lateral tibia.
Tibia.
Yes, because when I pass my small, I always palpate on the lateral side and feel the blade is just reaching.
Yes. So it has gone throughout the lateral side. Yes.
Up to on the behind the tibial tuberosity,
Yes, behind the tibia.
on the anterior aspect of the tibia.
Yes.
So-
So what happened with that cut, which is on the superior side?
No, so now
Superiorly where it has gone? Whether the tibia is intact till?
tibia is intact. So
Yes.
I have, it is oblique.
Yes.
That's the 110 degrees. So it is very, I can palpate the tibial articular surface here on
So
the.
you have, your
Small
cut
saw.
has gone superiorly, obliquely above the tibial tuberosity.
Yes,
Which is throughout cut?
throughout.
That is through and through.
Complete, complete.
Yes.
Tibial tuberosity is attached to the distal fragment now.
Yeah.
Yes.
But here, as I told you, this case did not need dual osteotomy. But I am always in favor of dual osteotomy. Open.
The advantage is that you don't change the posterior
Ek-
slope when you are doing it.
Bas, shoot.
So
Bas.
posteriorly it has total cut. Okay. Yeah.
Chal, final shoot.
So you can see final
Done.
rod alignment.
चल क्यों निकाला तू Gerson will put the, are you palpating?
Hip.
Hip AP. Shoot. वर ढकल. Shoot. Yeah.
Fantastic. Chalo. Ankle.
Like knee, no need to show ankle. Just
Chalo.
come and show the knee.
Chale.
Knee I have
Knee.
already,
Knee.
ankle I have already marked that slot there.
Knee.
अरे वर जा ए ताई.
ठीक से.
Shoot.
Anterior part of that osteotomy remained as a hinge. Okay.
Yes.
Yes.
Lamina spreader.
So you can
Show
see the
this.
amount of correction and he
Lamina
has
spreader.
measured already. You can show this X-ray, the alignment view. Wo
Very
X-ray,
nice.
lamba.
Okay.
So already pre-op he have made what are the amount of correction and 9mm opening. So already he had
Yes,
made all those
right
things.
angle there.
So now he is using the laminar spreader to. Don't
Hold this, bus. So always here
See there, yeah. So here.
to put in the posterior side. Short. So lamina spreader always goes in the posterior aspect. Can you see?
Yes. You measure your
Yeah.
opening here. And you can measure your opening, which you have planned pre-operatively.
Almost 9.
Good enough. So that
Yeah.
was your planning
There
here.
is a little crushing here. But
Not
it's
an
a
issue.
9.
9. Good. So now plate here.
And that's the anterior
Tibial here.
cut.
Yes.
Plate.
Chalo.
So here, now what I am going to do, because we are
Screw.
planning to do ACL here. So I will not be putting, just give me skin knife. I will not be putting all the screws here. I will be putting posterior screw here and one screw here. And we'll be stabilizing it. We may put this anterior screw as well, but this screw we will decide depending upon our tunnel.
Tunnel. Big incision here.
एक ड्रिल पे
So drill.
लगाओ. Shoot. Shoot. Shoot.
A bit higher.
Show this.
You can see the lateral hinge is intact.
Shoot. Chal, sleeve. Drill.
Fantastic. So drill, chalo. Hold the plate, hold the plate.
Don't worry.
Screw.
Second drill. No.
Screw. One more drill.
Excellent correction, Sandeep.
Shoot.
Sandeep is very
Sorry?
meticulous in every step.
What I did?
Excellent correction he is telling. So I am telling Sandeep is very meticulous in every step. So before OT, he has planned everything. His OT table.
Don't do anything unless I tell you. Okay?
I think there is no need for grafting for at least medial open wedge
Dena hai baba.
No. We actually, if it is more than 12 or 14 millimeter, the standard it is if you want to don't put chronos. It's a non-union device. Try to put a tricortical iliac graft if you want to graft it also. See, once you remove the tourniquet, the whole area will be filled up by blood.
Should.
And your lateral hinge is intact. So in 6 weeks, you will see the callus getting gradually formed, 6 to 8 weeks.
Okay.
Soft callus being formed there.
Sorry, sister. Yeah.
So he is putting the posterior most drill, you can see here. And now he will fix it. Chalo.
So you can check here. I have put the drill bit. I have not removed it. Then I have not perforated the posterior cortex. So screw is 45.
45 screw.
Or yeah.
So here everything is disposable. So you should be very prompt in measuring everything. See, all these screws are disposable screw.
So this is my drill bit, which I have not removed. I'll put this screw and I'll show you the Siam picture.
So screws are also gamma irritated. So you have to open it. So you measure it everything perfectly, then you put it. Screwdriver is there. Sir,
So that's the
focus this one, screw. Screwdriver.
Laminar stator just moved, but it doesn't change anything because screw and our drill bit is in the position. Second, sure. So you see here, I am still not removing my drill bit.
Once
Because
you put the screw,
it is still unstable. So I'll put the screw and then the drill. So the drill bit is holding. Now I am putting another screw here. Then I'll hand over to Rajiv for the
tibial tunnel.
counter, please. Yeah, very good, sister. Sometimes you can use your tummy to give pressure. So that is advantage of having tummy.
Yes. So Sandeep propagates, keep your tummy for orthopedic surgeon so they can push it with your tummy.
The pressure on that.
Hello, Sandeep.
Yes, sir.
Dr. Mokashi.
Yes, sir.
Throughout the surgery, you are not seen Siam on coronal plane.
No, I don't need to, sir, now.
Okay.
But I'll be seeing.
Okay.
Of course, I know. But because why, I'll tell you the reason.
Yeah.
It will make everything unsterile.
Yes, yes.
Siam will come from down.
But it is not mandatory.
Yeah, sir, 35.
35.
So we can do that. But now, at this point, I don't think it is required because I know where my plate is sitting.
No, it is okay. Yeah.
But I'll be showing the final picture.
Okay.
If there would have not been ACL, then I would have shown you right now.
Okay, no problem.
And we'll be sharing the X-rays in our delegate group.
Yeah, okay.
35. So this also I'm going to replace. Yeah, I'll tell you. Cute. 50.
This plate fixation drill bit is very good step, Sandeep.
Yes. So now,
So even if lamina spreader.
yeah, so I am removing lamina spreader now.
And now you can.
So Raju will take over, sir. So two screws here, one screw here, and then anteriorly I have left now one screw I'll be putting later, and then here two screws, because our ACL tunnel depends on that, and both are variable. So these both screws are variable. So after the upper femoral tunnel, tibial tunnel somewhere here, we'll be putting those screws.
We can remove the hinge now.
Yes, I am going to pull out the hinge wire. Siam nikal lo piche abhi. Siam abhi lagega nahi.
ACL.
So with the plier,
tibial tunnel.
I just pulled out the hinge wire. Tibial tunnel ready karo. So now the construct is relatively stable. It is not stable, but it will allow us to do our femoral tunnel.
Tibial tunnel.
Oh, sorry, tibial tunnel.
Your scope. Light on.
Lights, light source on. Light source on.
Light source.
Top light band.
Footprint jig.
एक मिनट मैं ये निकाल देता हूँ, क्लीन करता हूँ. I just want to डाल दो, वो डालो ना, शीट डालो, ड्राई मॉप.
वो फिर से फॉगिंग हो गया. ड्राई मॉप.
प्रोकार.
सब रेडी रखो. ड्रिल, विथ पिन, रीमर रेडी रखो. Reamer.
Rajiv sir has got
No, we will do it.
light to catch. Prokar.
चलो.
अरे भाई.
टोकर
Prokar दे यार.
टोकर.
Why don't you guys understand?
चलो. Yes. चलो. So for me, you can see this is a footprint jig. So you can put it to the footprint and try to put it medial to the medial tibial spine. You can see here. You can see here. Sandeep, tu idhar drill tu karna. So Sandeep will make the tunnel for me because light here, light focus here. This is very important step. See where you will make your tunnel. You can see this is very important. See. So
show this.
See. Yeah. Zoom in. Karo. You can see the angle of the plate. It allows you to zoom in this place. Light on. Yeah. You can see here.
Superb.
Can you see the location?
Yeah, like that is the angle they have made. Chalo.
Cameraman is doing good job.
Yeah. Sushant.
Actually, cameraman is good. Director is more good. Sandeep is director.
Cameraman. Sushant is the cameraman. He's my regular cameraman. So whenever I record surgeries in my hospital, he always comes there.
So you can see.
He's used to you there.
Yeah.
Yeah.
So. Fantastic. Bas.
How much angle you have taken?
What is that?
55. You can see we have enough bone there. So we will remit. यहाँ पकड़ के रखो. Curate.
Plate also looks very good design.
So that is the advantage of this plate, na system.
Yes.
Curate.
देखो, हे देखो, Sushant, हे देखो. Can you see the location of the?
Yeah.
Very good.
Yeah. Remit. Yeah.
So that is the reason when I checked under Siam, I kept my plate and I saw where I'm going to. Because if osteotomy is too high, then somewhere it comes screw. So you have got a good bone stock for the
Chalo, reamer.
8.5. You don't want to.
So you can see it's
serial name 8.5.
अच्छा reamer 8.5 का तो कोई दिक्कत नहीं होगा.
And now the trick here is once we do this, we'll be leaving this
reamer there.
Reamer there.
You can see here. Go.
थोड़ा withdraw कर, scope withdraw
Go. Yeah, go. But wait. हाँ. Just take it out with hand.
बस
Yes.
छोड़ देना.
बस ठीक है, बस. See,
Go.
now I will keep this here, and then I will put my screw. Rest of
Now-
the screw.
Reamer stays there.
You got it?
Okay.
Yeah, yeah.
Reamer stays there. I will
My
put later.
osteotomy procedure will continue.
Yes,
So my TBL tunnel will not. I will take it out. It will not hamper anything.
नहीं, हाँ, बस.
बस ठीक है. बस ठीक है.
बस. Scope
Just
out.
screws. And now we will complete our osteotomy.
Yes.
We'll
Got
put
it?
our screw.
Yeah.
Chal, right angle.
And then you pass the graft. So this is the
Yeah.
main key.
Siyam, please.
निकलता हूँ. Stop.
निकल रहा है.
हाँ वो क्या अब तो ग्राफ डालना है दिस में. अच्छा चल ठीक है फटाफट कर दे.
देख.
मैं ग्राफ डाल.
Drill.
Drill.
So you can check here.
So
Drill
if
bit
it-
is in position. I can do in
You-
whatever
you-
action I want.
So first he will try to put it anteriorly in this direction.
See
Yeah.
this?
You can see.
See this
So
Yes.
variable angle.
yes.
Yes.
Chalo. Yes. So
Variable
this will be good enough.
So
It will
I'm
go.
going to do like this.
Yes, yeah.
with anterior.
Raju, you have to catch the flight.
Yeah, come. Sister.
Not an issue. Huh?
Siyam.
If I miss it, I will come back to Satara.
Yes.
So Raju will stay at the venue, yesterday's venue.
Yesterday Venu, huh?
Yes.
With the cave Sandeep showed me.
Shoot. Before I drill, I would like to check the trajectory.
Yeah.
Shoot.
देखो.
Shoot.
Shoot.
So I have very well crossed my drill bit. Show.
So fantastic. See, you can see. So it's not hitting the drill bit.
Yeah, yeah.
Got it? Yeah.
Siam picture not available.
Siam picture. sorry.
Siam picture.
Oh,
No. So the Siam picture. Siam picture. Siam picture.
Shoot.
You can see it's crossing the drill bit now.
Shoot.
So I can put this screw.
Can you see?
Yes, yes.
Yeah. So
Wonderful.
this is the important of this day.
Put right angle. That's the advantage of this variable angle. Shoot. 60.
60.
I have not penetrated distant cortex. 60. So because of variable angle, because this particular plate has got two variable screws. Other plate has got only one central variable screw. So because of this variability, I get this almost 60 length screw. Now this screw, I don't think there will be any issue. I'll be putting slightly posterior the middle screw, because main issue was only this screw.
So what we were asking earlier, this option was not available with the older.
I never
plates.
take out my depth gauge till my
Screwdriver.
screw is in my hand.
Another drill bit.
Sleeve, don't do sleeve.
Sleeve.
Variable
Sleeve,
sleeve. Sorry.
Again.
Shade of Baba.
Posterior. Yes, this posterior. Focus. So now you can see
So this is put. So here I can.
a bit
I want to go
posterior.
little posterior and also straight. Shoot.
Yes.
Missing the drill bit.
Yes.
So
if it
again
hits,
you see and check
I'll
it.
come
See,
to know when it hits. Shoot.
not hitting. See.
Definitely.
Shoot.
So crossed. You can see Siam. So the Siam.
No need even.
No, we want to show you. Shoot.
So Siam.
Shoot. दाखवलं? ते दाखव. निकाल.
Size.
I think lateral is important.
I actually want everyone to go home before I shoot lateral. I'm scared to show lateral to you all.
Sandeep, just want to ask you about the lateral cortex of the tibia.
Yes. Shoot. 50.
50.
Sorry, what was the question?
Lateral cortex of the tibia.
Yes.
when we have done the cut.
It's almost intact. You can see here.
Yes.
The hinge is intact, so we have removed the hinge
See,
wire.
tibia, proximal tibia is a very triangular bone. So when you do tibia nailing, you always see that your screw has, the locking screw is so much closer to the bone as if it is on the nail. That's what Siam picture looks.
Yes. Okay. बीच पिन में धागा दे दो. Yes.
Last screw. So drill bit has come out. It will come out now. Yeah, it locking last. And then we'll show them lateral, Rajiv.
Lateral, all right. So lateral, I think you can then pass the graft. Sandeep, I will leave.
Yeah.
So guys, I'm leaving now. Sandeep will pass the graft with the adjustable loop with the suture
Yes.
disc there. So thank you everyone.
Raju, thanks very much to you and Dr. Sunit Hazra.
No,
And
thanks
thanks
for
to Amol, Satara Orthopedic Club, whole of the OT staff of anesthesia team. And thank you so much.
Yes.
Thank you from
So learn some good tips from Sandeep also today for osteotomy.
Rajiv, we don't joke, shoot. Yeah,
Thank you
40,
from Satara Orthopedic
40,
Society to Dr.
40.
Raju. Long way came here to show us. So much thanks.
Have a safe flight back to your native place.
Thank you so much.
हलून घ्या lateral. वगैरे बाकी आहे ग्राफ पास करणं बाकी आहे. टेबल अप कर. काढ. एक सेकंड काढ. lateral. चल टेबल अप कर. So lateral. No, final AP. Sorry. Final means first. Lateral. निकाल. टेबल डाउन कर. सीएम वर दाखव. That's the AP picture.
Okay. Looks good.
Shoot. Worker sister. Shoot. Worker. वर सोड. Sir. Short. Shoot. Shoot.
Reduce key.
व्यवस्थित दाखव.
Good.
Shoot. 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 खाली है. No, shoot. Don't worry. That's the final picture. Shoot.
Yes, very nice. Very nice. Very nice.
Very
Shoot. In full internal and external rotation.
Yes, yes.
See here now all the screws. I'm happy. Shoot. Yeah. I'll pass the graft. Mokachi sir.
Yes, yes. Happy,
Yeah,
happy.
thank you.
Excellent surgery, Sandeep.
We'll pass the graft. Chal kaad Syam. With pin. Prokarshit. Pakad. Table down. Syam out. Proka. चल. Grab passage. पकड़. Clean कर.
Hello, Dr. Sandeep.
Yes, sir.
What are chances of common peroneal nerve palsy in your series?
Less likely, sir. Means I don't see any reason
Okay.
why it should be.
Okay. No, if there is over distraction of the.
It is not hardly anything, sir.
Okay.
But common peroneal with that much distraction, it will never get Palsy in the medial opening wedge, sir.
Lateral opening it.
Lateral opening wedge or yeah, medial closing wedge it can. RF. Shoot. Baju. Baju ho ja. Yeah, give. Don't come in my way, yaar. Yes. Flex, flex. Cut. Please pull. Please pull. Please pull. पकडून ठेव, सोडू नको. चल, ए रिट्रीवर दे. पकडून ठेव, सोडू नको. बस. ओके, चल ग्राफ. Now that's okay. Leave this. We don't need too much flexion now. Hold. Equal कर. ऊपर क्या राहुल? Pull, 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 pull. You go, Rahul. छोड़. Leave it. Give it to him. Don't do anything.
You can see the graft going on.
No, not yet. It is just a portal.
No, no, the threads are,
Yeah, so that's button will go now.
yeah. You are waving through medial portal.
At medial portal, yes. So button is where, yeah, come. Come. So that button is here. Yeah, pull. Push kar. Yeah. Don't worry. Chal, खींच. Gentle. Yeah. पकड़. I doubly check. Show. Gerson, can you show me clearly? Hold. Hold. Leg निकालो. Yeah. पहले डुगु डुगु कर. Okay?
Yeah, it's flipped.
It's at flip. I'm now pulling very hard.
Yeah. So this is adjustable loop you are using.
Adjustable loop. Now we'll shift to lateral portal. Come here, Jason. Sure. पाणी बघा. आहे ना, पाणी चालू कर. Go. Can some of you can help me with this? Sure. Pull. Pull. Bus. So I'm going to put screw here.
Yeah.
Because I'll show you it is this much out.
Graft is quite visible. Yeah.
So graft is, see, osteotomy is there, graft is there, and plate is there.
Yes.
No connection. Everyone is free.
Yes. Sandeep.
Yeah.
By the time you fix the graft, we'll do the remaining.
Please do. Chalo.
Thank you.
Uh, huh?
Ajit sir,
Ten-
you
ten-
should proceed with the valedictory.
10/23. Okay, thank you very much.
Thanks a lot.
Doctor. And
Wonderful
I'm so
demonstration.
thankful
Thank
to
you,
Satara
Sanjay.
Orthopedic Society.
Yeah, very nice.
Yes, and I'm thankful to our team of anesthetists, Dr. Parimal and Dr. Nilesh Bhute, Ajit Bhosle sir, Nilesh Barkade sir, my fellow Jerson, our sisters Suhana, Pratibha, Saste brother, Yamuna sister, Prem, and all our camera team.
Yes.
Anil from Everest. So they have worked very hard for this meeting. And I think they were whole day, they were busy in this operation theater, managing the show.
Yes.
Thank you very much. सगळ्यांचं picture घे.
Once you are done with the fixing, we will again come back to OT.
Fine. Okay.
Yeah.
Yeah.
Half of my work of photo of thanks is done by Sandeep.
No, sir, you were here managing whole day. Right, uncle.
Remaining part is all.
Sir, whole day you have been very busy.
Yeah. So, good evening, ladies and gentlemen. Already Sandeep has thanked all of the OT and the related staff. I would like to thank Sandeep himself, General Secretary, Indian Arthroscopy Association, for his kind and cool cooperation since beginning of the planning and till the execution of this conference. I'd like to thank Dr. Rajendra Abhinkar for even though he has to attend one CME and conference at Kolhapur, he came all the way to Satara for our inauguration because he loves Satara since beginning. To be short, I would like to thank all faculties, all operating team, all delegates, and on behalf of organizing committee, I would like to thank Indian Orthopedic Association, Indian Arthroscopy Association, and Maharashtra Orthopedic Association. At the end, I would like to thank all members of Satara Orthopedic Society for their wholehearted support and participation in the conference. Thank you all.
So we'll conclude this meeting.